Good morning to all of you. I'm Dr. Padma Gunratna, President, Sri Lanka Medical Association. Let me very warmly welcome all who have gathered here at the auditorium of the Sri Lanka Medical Association, and all doctors who have joined online for this joint clinical symposium organized by the Sri Lanka College of Internal Medicine in collaboration with Sri Lanka Medical Association. In this early morning, we all feel that there is a very nicely lined up, most interesting and practically applicable series of lectures that would be useful all clinicians that who do day-to-day clinical practice. But in today's context, I know that among all of us, there is some fear behind us, behind the mind, that what is there in the background and what is there in our day-to-day sort of in general in our it is applicable to our medical profession. That is COVID. So we are amidst COVID, where we see increase in number of cases, increase in number of hospital admissions, increase in number of deaths, and in a situation that where we all who are in professional organizations have become so much busy in attending to mitigating the COVID outbreak. So in this context, still, despite all this, we thought that we need to have this program because that you know that we have been living with COVID for last 1.5 years. And also that it's important, even in COVID context, that we control all the other non-communicable diseases, that we educate public that they need to be active and that they need to be continuing their medications and so on. So it has become so important for all of us to be in touch with our day-to-day clinical practice. So based on that, the Sri Lanka College of Internal Medicine came up with this program, and that we agreed, so that it has become a reality today. I'm very thankful to the President, Dr. Hashi Satish Chandra, for proposing and sort of deciding to do this program in collaboration with Sri Lanka Medical Association. And then so thankful to Dr. Achila Balasurya, who liaised with the Sri Lanka College of Internal Medicine in organizing this program. So let me again welcome all of you for a very fruitful program ahead over this next 6 hours or so. And let me conclude. Thank you very much for your patient attention.
Good morning to you all. On behalf of the Sri Lanka College of Internal Medicine, as the president of the college, I warmly welcome you all to this program, this joint venture between the Sri Lanka Medical Association and the Sri Lanka College of Internal Medicine. I must thank Dr. Padma Gunratna, President SLMA, for agreeing to this program. We mooted this idea because even amid a pandemic, I think we have to take care of our medical specialties and our medical patients. And so it's important that we carry out programs of this nature. And I must say that we have had a history of joining with SLMA and having programs, having had one in 2017 in, that was in Anuradhapura. So, but this is the first time that we are having it at the home of SLMA. In Vijaramawata. So I think it's a special occasion. And I must once again thank Dr. Padma Gururatne and the Council of SLMA for agreeing to have this joint program. So we have lined up a number of topics and which are actually relevant to the clinical practice of physicians. And I'm sure the program will be enlightening to you all. And let me again thank the SLMA and also the two secretaries of the SLSIM, Dr. Tushara, Dr. Indika, and Dr. Priyamali, the treasurer, and Dr. Achala Balasuriya, who was instrumental in liaising with us to make this program a reality. So without saying anything further, I will start with the program, and I wish that you stay with us till afternoon and gain knowledge through this program. Thank you very much. The first segment is on peri-operative management, and we have lined up 4 eminent speakers to talk to us on 4 important topics. And the first topic that we have lined up for you is on high blood pressure, the peri-operative management of high blood pressure. And to deliver the lecture, may I invite Dr. Ganaka Senaratne, specialist in internal medicine, teaching hospital Karapitiya, and he happens to be the president-elect of SSIM. Now over to you, Ganaka, to begin your lecture on high blood pressure.
Good morning. Can you all hear me?
Yes, we can.
Right. I'm starting the screen sharing now. Madam, can you see my screen?
Not yet, not yet.
Can you see it now, madam?
Yes, yes, yes.
Right. Good morning, everyone. At the outset, I must thank Madam Padma Gururatne, President Sri Lanka Medical Association, and our President, Dr. Satish Harishchandra, and both councils, and especially Dr. Madhuvanti, for giving me this wonderful opportunity to talk to you today. Ladies and gentlemen, we'll start from a MCQ in the morning. Right. Can you see the screen?
Yes.
Right. Let's try and answer this question. True or false regarding blood pressure management. 1. Hypertension mediated organ damage affect cardiac perfusion during surgery. Number 2, preoperative blood pressure of 210/110 needs to be controlled with intravenous drugs. Number 3, postoperative 4th-day blood pressure of 170/100 needs to be treated with drugs. Number 4, bisoprolol should be stopped preoperatively in a patient with ischemic heart disease or angina. Number 5, losartan can be stopped day before the surgery if the blood pressure control is optimal. So with these questions in our mind, let's try to find answers to these questions at the end of the presentation. So this brings me to the talk today, perioperative management of hypertension. This is the outline of my talk. Sorry, I would speak about importance, blood pressure response, risk assessment, and so on and so forth during this 20-minute talk. Importance. Blood pressure is one of the major determinants of hemodynamic stability, as all of us know. And intraoperative and postoperative blood pressure will affect organ perfusion during this period. So intraoperative and postoperative blood pressure are influenced, in fact, by many factors, mainly surgery, anesthesia, drugs, and not only that, the preoperative blood pressure also influence the blood pressure during the surgery and even post-op period. And hypertension-mediated organ damage can affect cardiac perfusion during surgery. So there are so many things need to be optimum before the patient goes into surgery and even after to have a safe post-op period. Therefore, optimum management of hypertension in the perioperative period prevent undesirable patient outcomes. So that it's really, really important for us to discuss about this important topic. So Anesthesia Journal 1996 reported this study: hypertension, admission blood pressure, and perioperative cardiovascular risk. The patients who died of a cardiovascular cause within 30 days of a surgery, they had two groups, 76 with pre-surgical hypertension and 76 with normotensive patients. So preoperative hypertension was 4 times more likely than among matched controls. So patients who had some cardiac event and death had a preoperative hypertension as a history. So this denotes the importance of managing preoperative and perioperative hypertension well. What happened to the blood pressure during anesthesia? So during induction, sympathetic activation happens, and therefore blood pressure would be going up with the heart rate. And during anesthesia, what happens is that mean arterial pressure falls because of vasodilatation and all, and intraoperative hypertension could set in. And in recovery, again, the blood pressure and heart rate would rise back. And these changes are in fact more pronounced in untreated hypertension, people with untreated hypertension and pre-existing hypertension. So what would happen with these pronounced changes is that they all will cause myocardial ischemia during the surgery and even after the surgical period. Right, surgery and cardiac risk. Physiologic factors now, not only the anesthesia, the surgery itself affects the blood pressure and it affects the cardiac health during the surgery. So physiologic factors associated with surgery predispose to myocardial ischemia like volume shifts and blood losses, and enhanced myocardial oxygen demand because of the high catecholamine release as of the stressful condition. And then only in the post-operative period, we have aggravated activity of platelet activity. And therefore, cardiac ischemia could set in. And these all effects are more pronounced in patients with coronary artery disease and hypertension. So cardiac risk of surgery, in fact, is increased by having hypertension-mediated organ damage, like cerebrovascular and coronary occlusive disease. If the patient has already set in coronary vascular disease, when the hypertension sets in, so the cardiac perfusion go down. Not only that, diastolic dysfunction from left ventricular hypertrophy, congestive heart failure, and renal impairment, all could cause increased risk of surgery. Therefore, overall preoperative cardiovascular risk assessment, including search for HMOD, is important in treated and untreated hypertensive patients. Now it's time to discuss about the blood pressure goals. So what is the goal for preoperative blood pressure? It's 180 over 110. So in those with systolic blood pressure more than 180 and 110, there's no urgency to do the surgery unless it's an emergency situation. So you could postpone it and control the blood pressure, and you can do the surgery later. So the target is 180 over 110. Sorry about this. So British Journal Anesthesia in 1971 reports this study. Patients with untreated severe hypertension, that means mean systolic and diastolic pressures over 211 and 105, and had exaggerated hypotensive response to the induction of anesthesia and marked hypertensive response to noxious stimuli. So meaning that they could have serious cardiac outcomes during this period. This is another study reported in Medical Clinics of North America. Diastolic pressure over 110 immediately before the surgery is associated with number of complications, including dysarrhythmias, myocardial ischemia and infarction, neurologic complications, and renal failure. Let's move to intraoperative blood pressure goal. Well, there's no fixed target there. It's the teaching is avoid large intraoperative blood pressure fluctuations. JAMA reported this effect of individualized versus standard blood pressure management strategies on postoperative organ dysfunction. So when the blood pressure values are kept within 10% of difference from the preoperative blood pressure, resulted in reduced risk of postoperative organ dysfunction. Our anesthetic colleagues are trying their level best to do this by using volume expanders, inotrope, vasopressors and all to keep this range within 10%. Postoperative blood pressure goal is actually similar to general population. So if the post-operative blood pressure is more than 180 and 110, we need to see whether it's due to severe pain. If it is not, it is a medical emergency. You need to bring this blood pressure down with intravenous antihypertensive therapy. But if it is less than 110, 180, 110, the management would differ whether the patient had hypertension before or was de novo hypertension. Let's say the patient hasn't had pre-existing hypertension. We need to exclude or treat pain, agitation, hypercarbia, hypoxia, hypovolemia, and bladder distension, which all could contribute to blood pressure, elevation of blood pressure. In the absence of those, with the elevated blood pressure, you need to start drugs, and you could discontinue these drugs once the patient is stable surgically. And perhaps you need to resume these therapies if the blood pressure keep remaining elevated after 72 hours. In the case of pre-existing hypertension, patient who had been on drugs, then you could resume the usual medications post-operatively as needed. Now we discuss about the antihypertensive medications during peri-operative period. There are few important facts to remember. Most continued until the time of surgery, taken with small sips of water in the morning of surgery. So there's no problem in it. Most of the drug, but there are some exceptions which I will elaborate on next slides. And drug treatment used previously will need review prior to surgery. That has to be done. There is no clear evidence support the use of one class versus another. An individualized approach to managing hypertension perioperatively may require due to conflicting data on safety of several antihypertensives. So individualized approach has to be done, whatever the case. Can you all see my slides? Hello?
Can you share the slideshow?
I try to do slideshow, yes. It didn't work. Is it clear now?
Kanaka, we can see your slides very well, Kanaka.
I tried this slide sharing, but it's not working, I believe.
The slides at the moment is antihypertensive medication during perioperative patient.
Yeah. Okay.
That we can see very clearly.
You can see very clearly, but it's I can't do this slide show thing.
Yeah, why don't you try to move with this, Kanaka?
Yeah, we'll do it as it is, neither. Otherwise, it would go.
Yeah.
Okay, right. Moving to the next slide. About calcium channel blockers. In fact, calcium channel blockers are the safer option to be given in perioperative period, among the others. But they may have increased incidence of postoperative bleeding, probably due to inhibition of platelet aggregation. However, benefits outweighs the risk. So you can start or continue calcium channel blockers during perioperative period. Moving to the next slide. Diuretics. Diuretics also can be used, but of course we know they can cause some problems, especially electrolyte imbalance, hypokalemia. If that happens during the surgery, that may potentiate the effects of muscle relaxants used during anesthesia. It might predispose to cardiac arrhythmias as well. And you need to think about volume and potassium replacement in any case. Next slide. About beta blockers. Well, beta blockers have potential beneficial effects as well as adverse effects. So beneficial effects, it reduces the ischemia by decreasing myocardial oxygen demand due to increased catecholamine release in this stressful situation. It helps to prevent control arrhythmia, especially in cardiac surgeries. And potential adverse effects are, it's very well-known fact that it can cause bradycardia and hypertension during the surgery. And not only that, withdrawal syndrome is another problem. If you stop this beta blockers in a patient who's been taking it for long, for angina or ischemic heart disease, then they can have rebound ischemia during the surgery. However, it's less common with people who have been taking these drugs for migraine prophylaxis and hypertension itself. Literature about beta blockers, there are so many conflicting evidences. So this is the Heart reports this study, meta-analysis, RCTs of beta blockade. The conclusion was increasing the risk of hypertension, stroke, and mortality in patients preoperative beta blockers versus placebo. So if the patient has been on beta blockers preoperatively and your mortality is high, that is what was reported in 2014. In 2018, Cochrane review. Next slide. About perioperative beta blockers for preventing surgery-related mortality and morbidity. In non-cardiac surgery, they concluded shows an association of beta blockers with increased all-cause mortality. They again stayed in that stance that the beta blockers has an association with increased mortality and suggest an increase in stroke rate with the use of beta blockers as well. But more evidence is needed before a definitive conclusion can be drawn. So, and then substantial reduction of ventricular arrhythmias, supraventricular arrhythmias, and acute MIs in this setting offsets by potential increase in mortality and stroke. In cardiac surgery, of course, this is about non-cardiac surgery. cardiac surgery, this prevention of MIs and arrhythmias is a significant thing. Moving to the next slide, the Cochrane review in 2019, however, they conclude the evidence for really early all-cause mortality with perioperative beta blockade was uncertain, and no evidence of a difference in cerebrovascular events or ventricular arrhythmias. And they also concluded that further evidence from large placebo-controlled trials is likely to make this clearer. And in fact, there are so many trials being planned and under review to come to conclusion in this effect. So beta blockers, perioperative continuation of beta blocker is recommended in hypertensive patients currently on chronic beta blocker treatment. So if the patient had been on beta blockers for long, especially for angina ischemic heart disease, you could consider in continuing them. However, starting a beta blocker on the day of surgery, however, can be avoided because of the problems of intrasurgical hypotension and bradycardia and stroke rates. Moving into AC inhibition and ARB blockers, theoretically, they blunt the compensatory actuation of renin-angiotensin system during surgery, and that can result in prolonged hypotension. That is a serious problem. In fact, several studies have reported high incidence of hypotension actually with AC inhibition and ARB blockers. So this study, Anesthesiology 2017, continuing AC inhibition or blocker before non-cardiac surgery. So withholding associated with the lower risk of death and post-operative vascular events. A large randomized trial is needed to confirm this finding. So in the interim, in the setting of this finding, clinicians should consider recommending that patients withhold AC inhibition or ARB 24 hours before surgery, unless there is a very compelling reason to have it on board. So transient preoperative discontinuation should be considered unless there's a compelling reason to continue them, like such as heart failure, or can be resumed safely as early as second post-operative day. That is no problem. Right, ladies and gentlemen, we'll try to answer these questions now. Hypertension-mediated organ damage affects cardiac perfusion during surgery. We discussed when you have this damaged vessels, hypotension and perfusion issues might be there for the heart during the surgery. So that's true. And preoperative blood pressure of 210, 110 need to be controlled with intravenous drugs. Well, that is not a medical emergency, to be honest. You can postpone the surgery and you can control the blood pressure by giving oral drugs and then do the surgery unless it's an emergency. So it's false. And post-operative fourth day blood pressure, 170 over 100, needs to be treated with drugs. Is it true or false? Well, we said if the blood pressure is persistently high after 72 hours, then you might consider starting treating the blood pressure with drugs. So it's true. Bisoprolol should be stopped preoperatively in patient with ischemic heart disease. Well, when the patient has been on beta blockers for long, then if you stop it all of a sudden, it can cause rebound ischemia, that is called withdrawal syndrome. So you might not do this intervention. So losartan can be stopped day before the surgery if the blood pressure control is optimal. Continuing losartan, of course, we know can cause some problems, especially blocking of renin-angiotensin system and causing intraoperational hypotension. So if the preoperative blood pressure is optimal without losartan, you may stop this drug. Otherwise, you can continue it. So it's true. Right. In summary, optimum management of hypertension in the perioperative period will prevent undesirable outcomes. Preoperative blood pressure goal is 110 over 180 over 110. So you can postpone the surgery unless it's emergency. Post-operative blood pressure more than 180, 110 is a medical emergency and need urgent treatment. in patients with pre-existing hypertension, resume their usual medication post-operatively as needed. There's no problem. Most drugs can be continued, but some have some limitations. However, there are no clear evidence support to use one class versus another. Calcium channel blockers are the safest among all, and perioperative continuation of beta blockers is recommended in patients currently on chronic beta blocker treatment. Otherwise, it can cause rebound ischemia. And transient perioperative discontinuation of AC inhibition, aiming to reduce intraoperative hypertension, should be considered before non-cardiac surgery. I would like to thank again all of you and President Sri Lanka Medical Association and Sri Lanka College of Internal Medicine for giving this opportunity for me. Thank you very much.
Thank you very much, Ganaka, for that very comprehensive talk on a very important topic, controlling high blood pressure in the perioperative period. There are some questions, but I think we leave them till the end of this session. So the next talk on this segment is on the perioperative management of hyperglycemia. And may I now invite Dr. Suranga Manilgama, who is a specialist in internal medicine at the Colombo North Teaching Hospital. He has been instrumental together with Dr. Madhuvanti Hettiarachchi in drawing up this program. And he happens to be one of the editors of SLCM as well. So over to you, Suranga, for your talk on hyperglycemia.
Good morning, everyone. I'm going to talk to you on perioperative management of hyperglycemia. I will start with a case scenario. Mrs. XY, a 55-year-old previously healthy woman, admitted to surgical casualty with right hypochondriac pain and fever for two days. She was hemodynamically stable. Her capillary blood sugar was 258 milligrams per deciliter. She was not a diagnosed patient with diabetes. Diagnosis of acute cholecystitis was made. Medical referral was done for management of hyperglycemia. What do you all think? What is the reason for the hyperglycemia? Is it due to undiagnosed diabetes or due to stress-induced hyperglycemia? How do you find it out? This table shows the diagnostic criteria for diabetes. Just concentrate on the middle column. It shows cutoff values for diabetes. Fasting blood sugar more than 126 milligrams per deciliter. OGTT 2-hour value after 75 gram glucose ingestion more than 200 milligrams per deciliter. Or HbA1c more than 6.5%. In a patient with classic symptoms of hyperglycemia or hyperglycemic crisis, a random plasma glucose more than 200 milligrams per deciliter confirms the diagnosis of diabetes. Otherwise, diagnosis requires 2 abnormal test results mentioned above from the same sample or in 2 separate samples. So we need to check HbA1c in all hospitalized patients with newly diagnosed hyperglycemia. If the HbA1c is more than 6.5, it is due to undiagnosed diabetes. If it is between 5.7 to 6.5, that would suggest prediabetes. If it is less than 5.7, that would suggest stress-induced hyperglycemia. In patients with CBS more than 140 milligrams per deciliter or HbA1c more than 6.5%, we need to monitor capillary blood sugar levels regularly. So coming back to the case scenario, a detailed history was taken and patient has had osmotic symptoms, polyuria, polydipsia for a few weeks. And the admission HbA1c came as 9.4 and the diagnosis of type 2 diabetes was made. And she was started treatment for both infection and hyperglycemia. Let us see the glycemic targets and the treatment options. What are the glycemic targets for acutely ill hospitalized patients? Patients with non-critical illness, the targets are less than 140 for pre-meal sugar levels and less than 180 for random values. You may modify the targets according to the clinical scenario on individual basis. In selected patients, more tight control of blood sugar levels can be recommended, only if it is possible without hypoglycemia. In patients with terminal illness or with multiple comorbidities, less stringent control, even more than 180 milligrams per deciliter, is acceptable. Let us discuss how to treat hypoglycemia detected in hospitalized patients. Insulin is the preferred treatment. Initiate insulin therapy when blood glucose level is persistently more than 180. And continuous intravenous insulin infusion is the most effective method for critically ill patients. Patients with type 1 diabetes, they must be maintained on insulin therapy at all times to prevent diabetic ketoacidosis. This diagram shows how to calculate the insulin dose for non-critically ill patients. I will zoom out the picture. In non-critically ill hospitalized patients with diabetes or stress-induced hyperglycemia, subcutaneous insulin regime is recommended. And it should consist of basal insulin, bolus insulin, and correction insulin components. The first box shows how to calculate the total daily insulin dose. 50% of it is given as bolus insulin, and you can give basal insulin once or twice a day. If you're using long-acting analogs like Glargine, Determa, Degludec, it can be given once a day. When you're using intermediate insulin like NPH, it is given twice a day. 50% of the calculated total daily dose is given as bolus insulin. So you can give rapid or short-acting insulin in 3 equally divided doses before each meal. If patient is not able to eat, you need to hold the bolus insulin. The adjustments to the insulin dose should be done according to the correction scale and the CBG levels. The number of units of regular or rapid-acting insulin per dose is shown in each column. Start at insulin-sensitive column in patients who are elderly and those with impaired renal functions. Start at insulin usual column if the patient is able and expected to eat all or most of his meals. Start at insulin resistant column in patients receiving corticosteroids and those treated with more than 80 units per day before admission. If the patient is not able to eat, give regular insulin every 6 hours or rapid acting insulin every 4 to 6 hours, and you need to follow the sensitive column. Coming back to the case scenario, hyperglycemia was managed with insulin and acute cholecystitis was managed with intravenous antibiotics. She was discharged on both insulin and oral hypoglycemic drug. Interval laparoscopic cholecystectomy was scheduled in 4 to 6 weeks' time. Let us discuss how to prepare a patient with diabetes for an elective surgery. We will discuss pre-op operation, peri-op, and post-op management separately. First of all, we'll see the pathophysiology of hyperglycemia. The stress of infections, trauma, and injury cause a neuroendocrine stress response with release of counter-regulatory hormones and inflammatory cytokines such as epinephrine, glucagon, cortisol, growth hormone, inflammatory cytokines like IL-6 and TNF-alpha. These neurohumoral changes result in metabolic abnormalities such as insulin resistance, decreased peripheral glucose utilization, impaired insulin secretion, increased lipolysis, and protein catabolism. There are a lot of other contributory factors that exacerbate the response in a surgical patient. What are those? Type of surgery, type of anesthesia, hypothermia, drugs like steroids, vasopressors, immunosuppressives, and enteral and parenteral feeding. This cartoon shows how the activation of autonomic nervous system produces those changes. Final result would be protein catabolism and lipolysis, exaggerated gluconeogenesis, glycogenolysis, and insulin resistance, giving rise to hyperglycemia. And this is another schematic presentation of the above cascade due to metabolic stress. What are the outcomes of poor glycemic control? Will cause poor surgical and overall outcome. Those are infections, poor wound healing, acute kidney injury, acute coronary events, high mortality rate, lengthy hospital stay, so on. For elective surgery, early preoperative optimization should be arranged by the treating physician. Satisfactory level of glycemic control, that is, required HbA1c should be targeted before the surgery. Patient assessment should be done to evaluate risk of hypoglycemia, hypoglycemic awareness, diabetes-related complications like renal, autonomic neuropathy, and macrovascular diseases, etc. The goals of preoperative glycemic management include prevention of hyperglycemia, prevention of hypoglycemia, prevention of diabetic emergencies like diabetic ketoacidosis and hyposmolar coma. So HbA1c target should be less than 8.5%. If it is more than that, need to refer to a specialist team. So when the glycemic control is suboptimal, weigh the benefit versus harm of early surgery and may need to delay the surgery. At the admission to the ward for elective surgery, check the consistency of medication already on and prescribed at the admission. Document the medications those are self-administered by the patient and monitor capillary blood glucose regularly. When you operate on high-risk patients with poor glycemic control or with diabetes-related complications, book an ICU HDU bed in advance. If patient has high risk of peripheral arterial disease, take measures to prevent pressure ulcers. Use DVT preventive stockings with caution. Maintain glycemic target of 110 to 180 milligrams per deciliter, especially for anesthetized, sedated patients, and for patients on insulin or sulfonylureas, which carry the risk of hypoglycemia. For awake patients, a lower glucose value of 70 milligrams is acceptable, and it does not warrant rescue therapy. Where do you keep your patient in the theater list? What do you think? Patient with diabetes should need to come up in the list as a first case. If the fasting period is expected to be limited to one missed meal, the patient can be managed by modification of his or her usual diabetic medications. This table shows how the modification can be done in antidiabetic therapies before surgery, day prior to admission, and day of surgery. These tables demonstrate the detailed descriptions for individual drug classes. Further, the dose modifications according to the timing of the surgery are shown, which includes a separate columns for morning procedures and for the afternoon procedures. If patient is fasting for more than one meal, the insulin dose modification is recommended. This chart shows how to modify the dose of long-acting insulins. I'm just putting these charts for the completion. You actually need to refer those when you want to modify free of insulin doses. When patient takes two types of insulins, this regime is called self-mixed insulin. This shows the dose modification for those. When this comes already mixed in a single vial, it is called pre-mixed. This is for the pre-mixed insulin. You all know what is short-acting insulins. There are new rapid-acting analogs also. This table shows dose modification of them. The patient now is in the theater. During the surgery, the aim is to maintain satisfactory glycemic control. The glycemic range is 110 to 180 milligrams per deciliter. For critical ill patients, it is 140 to 180 milligrams per deciliter. CBS level should be checked before induction of the anesthesia and monitored regularly during the procedure, at least hourly or more frequently, if the results are outside the target range. When blood sugar is 180 to 220 milligrams per deciliter, more frequent monitoring is warranted. When blood sugar is more than 220, it is needed to correct the intraoperative hyperglycemia using additional subcutaneous rapid-acting insulin or insulin infusions. If patient develops intraoperative hypoglycemia, management should follow agreed protocol that we will discuss later. Let us see how to manage perioperative hyperglycemia in patients who are not on insulin infusions. Look at the flow chart on the left-hand side. If patient has blood ketonemia more than 3 millimoles per liter or urine ketones more than 3 pluses and metabolic acidosis, you need to follow ketoacidosis pathway. Otherwise, give rapid-acting insulin subcutaneously and assess the response. If the patient develops hyperglycemic emergencies like diabetic ketoacidosis or hyposmolar coma, start the fixed rate IV infusion, insulin infusion. How do you manage perioperative hypoglycemia? If CBG is less than 70, give 20 to 25% glucose, 100 ml intravenously. Repeat up to 3 times. If CBG within 70 to 110, consider giving 50 ml. Repeat up to 3 times. If patient develops hypos, inquire about and look into errors of prescribing, lack of oral intake, delay in parenteral or enteral feeding, which cause insulin glucose mismatch, whether the patient has got any acute kidney injury, and lack of hypoglycemic awareness, etc. Okay, now patient has undergone the surgery. For post-operative period, if they are on variable insulin infusions, I will discuss in due course. The glycemic target would be 110 to 180 milligrams per deciliter. Other patients who are awake, the target would be 70 to 220 milligrams per deciliter. For critical ill patients, it is 140 to 180 milligrams per deciliter. Encourage early return to normal eating, which will allow the use of the usual diabetic medications of the patient. Consult the specialist team if the blood glucose levels are outside the acceptable range. Mrs. XY was discharged home post-op third day with satisfactory glycemic control. Unfortunately, 2 days after the discharge, she is brought to the hospital due to recurrence of fever and right hypochondriac pain. On examination, blood pressure was 100 by 70 milligrams per deciliter, and she was tachycardic with pulse rate of 104 beats per minute, and she was icteric. Her blood sugar level was 380 milligrams per deciliter. The diagnosis of septic shock due to peritonitis following bile duct injury was suspected. She was initially resuscitated and planned for emergency explorative laboratory, followed by ICU admission. How do you prepare for an emergency surgery? Fluid resuscitation, intravenous insulin, correction of serum electrolytes, baseline lab investigations to assess organ functions, all should be done. Now there is an indication for intravenous insulin for Mrs. XY. Let's see, what are the indications? She has poor glycemic control. You need to do an emergency surgery with no room to postpone it. And she is expected to keep nil by mouth for a prolonged period. So invariable rate intravenous infusion, insulin infusion. There are 3 different rates. Consider the use of reduced rate if any risk factors for hypoglycemia are present, like renal impairment, low body weight, when starting insulin for the first time in an insulin naive patient. Variable rate insulin infusion is the best method to control hyperglycemia for the post-surgical patients admitted to ICU. Subcutaneous basal insulin can be added to variable rate insulin infusion for more effective control, and that help smooth transition to subcutaneous insulin later. How do you prepare the infusion? Add 50 units of insulin containing 0.5 ml to 49.5 ml normal saline to prepare 50 ml infusion syringe pump. As I mentioned before, continue 80% of long-acting insulin subcut along with the infusion. Monitor CBG hourly and adjust the rate accordingly. In this chart, there are 3 main columns to represent 3 different infusion rates. This shows standard rate. This shows reduced rate for insulin sensitive patients, and this column is for insulin resistant patients. After the exploratory laparotomy, the patient was transferred to the ICU. So what are the glycemic targets for critically ill patients in ICU? It is 140 to 180. And we can consider target of 110 to 180 if it can be achieved without significant hypos. In terminally ill patients and in patients with severe comorbidities, higher glucose range might be acceptable. Intravenous insulin is a preferred method to achieve normal glycemia. There are numerous protocols and algos to follow. In our ICUs, University of Washington protocol is a widely used one. This is the protocol of University of Washington. Measure blood glucose levels frequently as appropriate, ranging from every 30 minutes to every 2 hours. And there are more sophisticated methods for continuous glucose monitoring. Those will pick the tendency for hypos than point of care testing. Now, patient is ready to be transferred to the surgical ward. Before that, let us see, how do we convert insulin infusion to subcut regime? It is possible once patient is stable, off vasopressors, extubated, and eating or being maintained on stable regime of enteral or parenteral nutrition. The transition should take place when the next meal-related subcutaneous insulin dose is due. Example, with breakfast or lunch. The conversion may vary according to the insulin regime that you are planning to start. There are several regimes: basal bolus, twice daily premix insulin, or the subcut continuous infusion, etc. Finally, we'll briefly discuss how to follow up stress-induced hyperglycemia with normal HbA1c. Hyperglycemia can be managed as discussed above and patient can be discharged with anti-diabetic drugs if normal glycemia is not achieved post-op. And they should be reviewed in 1 month with repeat fasting blood sugar and arranged medical follow-up. These are the take-home messages. This is a summary table showing the glycemic targets at various levels. Thank you.
Thank you, Suranga, for that very detailed lecture on a difficult topic. I think you covered almost every aspect of it. I once again thank you. Now we will get on to the next item in the segment, which is a talk on patients on antithrombotics, the perioperative management. And to talk to us today is Professor Lalindra Gunaratne. He is the professor in hematology, Faculty of Medicine, University of Colombo. Over to you, Lalindra, for your talk on patients on antithrombotics, the perioperative management.
Thank you very much, Satish. Can I be heard?
Yeah, you're clear. Yes, slides can be seen.
Can you hear me?
Yes, we can. Slides are also visible.
Right. Let me start by thanking the SLMA and the College of Internal Medicine for inviting me to give this talk. It's on, as you can see, perioperative management of patients on antithrombotics. Now, this is quite a broad and diverse topic. For example, if we say, think of a patient who's on aspirin and he requires fine needle aspiration for an insisted pleural effusion, managing that patient would be quite different to managing a patient who is on warfarin for a prosthetic mitral valve, who's had an ICH with a midline shift requiring a craniotomy. And maybe we can spice it up a little more and say if this patient had cirrhosis with a bit of thrombocytopenia, that would complicate things even more. So because of the diversity of these clinical cases, I'm not going to discuss case-wise, but what I've done is to look at some of the guidelines that's available. Many countries have their own guidelines for the perioperative management of these patients. So I'll share with you some of the guidelines and how we would approach a patient when we need to manage them perioperatively. So as an introduction, we have an aging population and there are many advances in treatment of chronic medical conditions, many drugs available as antithrombotics, and therefore we're going to see more and more patients who are on these antithrombotics prior to surgery. It is sort of described that about 1 in every 10 surgical patients are on chronic anticoagulants. Dual antiplatelet therapy is another commonly used treatment technique now, especially for secondary prevention of MI and patients on PCIs. Interruption transiently increases the risk of thromboembolism, and we all know that. And continuation of therapy can increase the risk of surgical bleeding. So therefore, we've got to balance the clinical consequences of these risks, which are absolute and are paramount, because both of these can adversely affect morbidity and mortality. But it is important to remember that clinical harm from a major perioperative bleeding event may be less likely than from thrombosis. So it appears that it is more dangerous for a patient to develop thrombosis than to have a perioperative bleed. Now, this is supported by some of these evidences where it shows that the case fatality rates with mechanical heart valve thrombosis in the perioperative period is about 17%, VTE 5 to 10%, embolic stroke about 37%, where and compared to the major bleeding on antithrombotic agents estimated around about 6 to 10% only. So I think it's important for us to keep this in mind. So when I approach a patient or when I'm asked to see a patient for a pre-procedural assessment, these are the things that I would look at. Firstly, the timing of the surgery and the procedure. Do we have time? Is it an elective or a routine procedure, or is the surgery an emergency? The second most important is the risk of bleeding. What sort of a bleeding risk does this procedure have? And what sort of antithrombotic agent or combination of agents is the patient on? And are there any additional risk factors for bleeding in the patient? Like, for example, does the patient have a bleeding disorder? Is the patient on other drugs like NSAIDs and stuff like that? And thirdly, what is the risk of thrombosis? What indication does the patient have to be on these antithrombotic agents? And how long since the patient has been started off on these agents? So for example, when did the patient have a PCI inserted? And what is the current state of the indication that the patient was started on antithrombotics is? So these are the things that I would think of when approaching a patient. Now, if you look at the risk of bleeding from procedures, we can look at it in three categories: minimal risk, minor risk, and a major risk. And you can see that those which have a sort of almost a minimal risk are things like doing skin biopsies or removing, doing cataract surgeries and so on. The ones which are a little more have a little more risk of bleeding are the things like lymph node biopsies, coronary angios, laparoscopic cholecystectomies, and so on. And the ones with a higher bleeding risk, a significant bleeding risk, are those which are like cancer surgery, things which a lot of surgery with extensive tissue injury, major orthopedic surgery, and so on. So it is important for us to take account of which of these procedures the patient has been teed up for. What are the antithrombotic agents that the patient might be on? Anticoagulants, parenteral, unfractionated heparin, low molecular weight heparin, or fondaparinux, or the oral ones, warfarin or the DOACs. The antithrombin agent, dabigatran, or the direct anti-10A inhibitors, rivaroxaban, apixaban, edoxaban, and betrixaban. We know that we have rivaroxaban and apixaban available to us, and we have many patients on these two drugs. So we need to know a little bit about them. The antiplatelets, aspirin, and the P2Y12 inhibitors, or the clopidogrel, prasugrel, ticagrelor, and ticlopidine, which our patients may be on. So they could be on one of these or a combination of these prior to surgery. So as I mentioned earlier, the bleeding risk assessment is probably the most important thing to see if the patient is on any additional drugs, what is the baseline platelet count of this patient, what is the hemoglobin level, and if do we have a chance of optimizing these factors like the hemoglobin and the platelet count before we take him or her up for surgery. And to remember that for most surgical procedures, anticoagulation usually is stopped due to the bleeding risk. However, there are procedures where the bleeding risk is not significant and anticoagulation can be continued. Now, these are two trials. The first published in the New England Journal of Medicine called the Bruise Control 1, and the second one, the Bruise Control 2 trial. Now, in the Bruise Control 1 trial, the cohort of patients were patients who were undergoing elective cardiac implantable device surgery, and the endpoint was to see whether they would develop a significant hematoma. So you can see that the randomization here in the top part were that patients who had an INR of less than 3, they were continued on warfarin, and the other group, warfarin was stopped, and there was bridging with either heparin or enoxaparin. And you can see that those who were bridged had a higher risk of hematoma formation than those who were continued on warfarin. Then the bruise control 2 trial was a comparison of the same cohort of patients, but this time those were on direct oral anticoagulants, and the randomization was between those in whom the drug was continued or in those who and in those who drug was interrupted. And you can see that there is no difference in the bleeding risk even if the patient was whether the patient was on the direct oral anticoagulant or whether it was discontinued. And a multivariate analysis done between the two trials showed that there was no difference between continuing warfarin or continuing a DOAC. What was different is the patients who are on an oral anticoagulant alone and those who are on an oral anticoagulant together with an antiplatelet agent. So addition of an antiplatelet agent increased the risk of a significant hematoma by almost double. So therefore, we can see that every procedure does not need stopping of anticoagulants. And that's why the bleeding risk assessment and the thrombotic risk assessment is of paramount importance before we start the procedure of surgery. Now, what is how do we assess the thromboembolic risk on anticoagulation? Now this is a risk assessment. You can see mechanical heart valves, atrial fibrillation, and venous thromboembolism, and a high, moderate, and low risk on the left hand of your screen. And if you can see, say for example, a patient who's had a mitral valve replacement or who's got a CHA2DS2-VASc score of between 7 and 9 in a patient with AF, or who's got a recent VT in the last 3 months, that person would be at a higher risk of developing a VTE than someone who has a CHA2DS2-VASc score of 1 to 4 and no history of stroke or TIA, or who's had a VTE over 12 months previously. So this risk assessment of thrombosis is also very important. Now, how do we manage these patients perioperatively? Looking at the anticoagulants first, warfarin or DOACs. Now, in the case of warfarin, let's say a patient requires urgent surgery. The first step would be, and the patient is on warfarin, the first step would be to check for the INR. And if the INR is less than 1.5, we can go ahead with the surgery, even if the patient is on a therapeutic dose of warfarin, because his INR is subtherapeutic and this will not interfere with the surgical process. If the INR is between 1.5 and 3, then we need to risk assess about the procedure. If it is a minimal or selectively a low bleeding risk, then we may be able to proceed with the surgery just as it is. However, if the bleeding risk is high, the bleeding risk of the procedure is high, then we would need to reverse this anticoagulation. So the INR between 1.5 and 3, or even if the INR is more than 3, and the bleeding risk is high in the procedure involved, then we would have to reverse. The next point would be, could the surgeon wait for 6 to 8 hours before we can go in? If he can, then an IV dose of vitamin K would be probably sufficient to reverse the warfarin effect. However, if the procedure has to be done even before or within these first 6 to 8 hours, then we would have to reverse it by way of using an agent such as ideally a prothrombin complex concentrate. We have either 3-factor or 4-factor prothrombin complex concentrates. The 3-factor one is 2, 9, and 10. The 4-factor one would have 2, 7, 9, and 10. And for example, we have octaplex here in our country, and a dose of between 25 to 50 units per kg, a single dose, would be sufficient to reverse the effect of warfarin. If we don't have PCC, then fresh frozen plasma at about 15 ml per kg would do the trick. So that is if there is an urgent need for a reversal of warfarinization. However, if we have time and it's an elective procedure, then again we need to first estimate the bleeding risk of this patient as per the surgery. And if the bleeding risk is minimal and if the surgeon is happy, we may be able to even perform the surgery. So for example, like a dental extraction or a cataract surgery, while the patient is on a therapeutic dose of warfarin and the INR is within the therapeutic range. However, if the bleeding risk of the procedure is higher, then we would obviously have to interrupt warfarin therapy prior to the surgery. And together with the prescribing physician and the surgeon, we would have to decide whether the risk of thromboembolism is low or moderate or high. So if the risk of thromboembolism are low or moderate, we will be able to interrupt warfarin, so say stop warfarin 5 days before surgery, but may need not have bridging. Only if the risk of thromboembolism is high, that following the cessation of warfarin, we would need to bridge this patient. And this is an example of a study published in NJAME where randomized double-blind placebo-controlled trial of about 1,800 patients with AF were studied. And in one group of patients, warfarin was stopped 5 days before pre-op, and low molecular weight heparin bridging was started. In the other group, there was no bridging, but there was only a placebo. And the conclusion was that the patients who did not have bridging was non-inferior in terms of perioperative arterial thromboembolism. So there was no difference whether there was bridging taking place or not. However, the group of patients who were bridged with heparin had a higher risk of major bleeds. So again, going to show that it is not essential that we bridge in every case. Now, here are some of the indications that bridging is necessary. So patients with the VT within the past 3 months, a stroke or TIA in the past 3 months, and those on obviously prosthetic heart valve, certain types of heart valves will require bridging. And this is basically how we would bridge. So 5 or 6 days before the surgery would be the last dose of warfarin, and then from day 5 onwards, the warfarin will be withheld. An INR would be done round about 1 day after stopping warfarin to make sure what INR is like. And when the INR is 2 or less than 2, at that point we would start the bridging with low molecular weight heparin, therapeutic dose of low molecular weight heparin. So for example, enoxaparin. The last dose of enoxaparin would be 24 hours prior to the time of the surgery. And on that day or the day before, we would repeat an INR to make sure that it was less than 1.5. So the last dose of enoxaparin should be 24 hours before the procedure. What about the dose? Well, we know the dose of enoxaparin is affected by the renal impairment. And for patients whose creatinine clearance is less than 30, it would be a renal dose. That's 1 milligram per kg subcut daily. And for those whose creatinine clearance is okay, the dose would be 1 milligram per kg subcut twice a day or 1 milligram per kg once daily. Personally, my preference is during bridging to use the once daily dose if possible, because it's very clean. Then you give, maybe if the surgery is planned for 8 a.m. on a certain day, you give your last dose of enoxaparin exactly at 8 a.m. the day before, and things are fairly smooth. But this is optional and you can use either method you like. The other important or difficult condition could be when the patient is awaiting neuropraxial intervention or anesthesia. I'm not going to go through all of this, but if I direct your attention to the therapeutic dose of low molecular weight heparin, it is important to withhold low molecular weight heparin for at least 24 hours prior to the insertion of the catheter. And removing the catheter also, the last dose should be 24 hours prior to that. Once the catheter is in place, After 12 hours of placing the catheter, if everything is well, low molecular weight heparin at therapeutic doses can be restarted. But once the catheter is removed, again to restart low molecular weight heparin, we should wait at least 4 hours after removing it. Warfarin, on the other hand, we cannot insert a catheter while on warfarin, obviously. The INR should be less than 1.5, both for introduction of the catheter and removal of the catheter, and giving warfarin while there is a catheter in situ is contraindicated. What about the prophylactic dose of low molecular weight heparin? Again, if I may draw your attention to that, you need to withhold your low molecular weight heparin for at least 12 hours prior to either insertion or removal of a catheter for neuropraxial anesthesia. Right, that's for warfarin and for the heparins. Now, what about the DOACs? If it is an emergency and we have to reverse these DOACs in an emergency, that could pose a few problems to us here in Sri Lanka. If you look at the half-life, effective half-life of all these agents, it would be in the region of about 10 to 14 hours. And if you can look at the bottom, the last column, none of these reversal agents which are recommended for these DOACs are available to us here. And I don't think they are going to be available for a long time due to the exorbitant cost. So what we would have to use is basically something like PCCs. That's there in your second column. And it could be useful in reversing DOACs, warfarin, and even low molecular weight heparin to a certain extent, if at 25 to 50 inflation units per kg, if it is an emergency and we have to reverse it. Let me draw your attention again to something which is exciting. The last column on this table, siraparantag, which is a small synthetic molecule. It says here that the brand name is not known yet, but it is in fact, and this is something, a reversing agent, which we can use for almost any drug. So for DOACs, for heparin, for fondaparinux, this can be used as a reversal agent for all these and therefore might be quite handy. However, if we have time before the surgery to interrupt DOACs, then as a rule of thumb, if the surgical procedure is a low-risk procedure and the creatinine clearance is normal, then stopping your DOACs more than 24 hours is adequate. If the risk of the procedure is a high-risk procedure or high risk of bleeding, then we should stop it for at least, for more than 48 hours. So this is something which we need to keep in mind. However, if the creatinine clearance is affected or there's a low creatinine clearance, we would have to increase this duration of stopping the anticoagulants. For those with a low bleeding risk post-operatively, anticoagulation can be started even at about 6 to 8 hours, but for high bleeding risk surgeries, it should be after 48 hours, or anticoagulation should be, restarting anticoagulation should be delayed for after 48 hours of surgery. And remember, there is no bridging with DOACs because the effect lasts only for 24 to 48 hours, and therefore it is no use bridging. And once we restart the anticoagulation post-surgery, the effect is almost instantaneous, comes on within a few hours, and unlike warfarin, which takes days, it comes on immediately. So therefore, very, very quickly, and therefore we do not bridge for DOACs. Quickly on to antiplatelets, we have aspirin and the P2Y12 antagonists. This is the risk assessment for patients who are on antiplatelets. Again, I'm not going to go through this in detail, but you can see there's a high, moderate, and low risk, and it depends on when the procedure was done. So, for example, if someone's had a PCI within the past 3 months or has developed an ischemic stroke within the last 3 months, then it's a high risk. And if the PCI was inserted maybe more than 6 or 12 months previously, or the ischemic stroke or carotid stent placement was more than 6 to 12 months, then the patient would be at low risk of developing thrombosis. This is a meta-analysis of about 40 studies which was done to show that aspirin doesn't, although it increases the rate of bleeding complications by a factor of about 1.5, it does not lead to a higher level of severity of bleeding complications, except in intracranial surgery and TURPs. So therefore, most guidelines or consensus statements would recommend that aspirin monotherapy is continued throughout surgery and it is not stopped unless there is an exceptionally high risk of bleeding, like in the case of maybe CNS or posterior eye chamber surgeries and so on. However, with dual antiplatelets, it has a significantly more surgery-related bleeding of about 14.7% compared to aspirin. And this bleeding risk obviously will have to be balanced against the risk score which we saw a little earlier and the risk of bleeding. Now, what about emergency surgeries on patients with antiplatelets? Well, aspirin, as we said, is probably all right. But if it's a high risk and we have to transfuse platelets, then it would be ideal to transfuse platelets at least 2 hours after the dose of aspirin or 12 to 24 hours after the last dose of clopidogrel, because the circulating drug or the active metabolite of the drug, like in clopidogrel, could start inhibiting the transfused platelets as well. Rotem platelets and other bedside platelet function tests can be used to determine the antiplatelet effect of drugs such as clopidogrel, especially in situations, say for example, where there's a high risk of thrombosis, and if we are really contemplating whether we need to give platelets or not. But there are studies which have shown, like this one, like the patch trial in patients with ICH while on antiplatelets, that giving platelets, routinely administering platelets to these patients may not actually be very beneficial. In fact, this study showed that there was a higher odds ratio of death or dependence among those who are actually transfused platelets. So again, we need to be cautious before we just throw platelets at everyone who's on antiplatelets and who requires a procedure. Let me skip through that and go to this. So if we do have to discontinue antiplatelets, then this is what the recommendation would be. For aspirin, 5 days prior to the procedure. For clopidogrel and prasugrel, 7 days. Ticagrelor, 5 days. And ticopridine, 14 days prior to the procedure. And for neuroaxial procedures, these are the recommendations. Again, aspirin is not there because you can go for neuroaxial procedures unless there are sort of other compounding factors while on aspirin. So in summary, pre-op assessment, I think, would be the most important factor when we are approached or when we approach a patient who requires some sort of advice regarding antithrombotics pre-operatively. So assessing the bleeding risk of the procedure, taking into account additional risk factors for bleeding like drugs, the history, thrombotic risk of indication, the antithrombotics which are being used when the last dose was given, and then considering whether the drug really needs to be stopped. And if it is being stopped, do we have time to let it normally come down the blood levels come down, or is reversal necessary? We should not go to reverse the antithrombotic effect, just because the patient is on a drug. And what is the risk and the benefit of reversal? And to take into account very carefully what reversal agents we have available. So I'll stop there now. Thank you very much for your patient hearing.
Thank you very much, Lalindra, for that very comprehensive talk on a very broad topic and a very important topic too. I think it must have been very useful to all of us. Now, moving on to our next speaker, we are privileged today to have Professor Namal Vijay Singh, who's here in the audience with us. So he is the professor of medicine as General Sir John Kuttadawala Defense University. He is going to talk to us on the peri-operative management of cardiac conditions. Over to you, Namal.
Sri,
good morning to everyone, Chairman Sir. My topic is on peri-operative management of cardiac conditions. Many patients who undergo non-cardiac surgery have an increased risk of developing a major adverse cardiac event in terms of peri-operative myocardial infarction or cardiac death. Actually, cardiac complications are responsible for about half of the peri-operative mortality. And 1 to 5% of cardiac mortality in patients who undergo vascular surgery is observed. So this is an important complication to consider during peri-operative period. The objective of doing peri-operative risk assessment includes evaluation of the patient's current medical status and also assessing the cardiac risk profile of the patient, management of cardiac risk during the peri-operative period, treatment of modifiable factors such as hypertension, diabetes, and so on, and improve the clinical safety and reduce cardiac mortality and morbidity during the peri-operative period. This is a teamwork. Of course, the patient and the family and the general practitioner should be involved. The surgical team that includes the surgeon and the anesthesiologist and perhaps the intensivist should be involved. And during the peri-operative assessment, the specialist physician also involved and can play a major role in identifying the risk and management of these cardiac conditions during the peri-operative period. Of course, many other people that includes the nursing staff, the physiotherapists for early mobilization.
it's mute.
Okay, I hope everyone can see the slides and can hear me. So as I said, it is a teamwork. The patient, family, and the surgical team as well, the physician and many others are involved in good outcome. How do you advance? The role of the physician in this scenario includes reviewing the available patient data, taking a good history and thorough examination, determining if further help is needed to define cardiovascular status, recommendation of treatment to improve the medical conditions, and recommend pre-operative testing that should be decided only if that will change the surgical care and peri-operative medical therapy. Now, our clinical evaluation should include identification of serious cardiac conditions such as significant coronary artery disease, heart failure, severe valve disease. We'll discuss all these in a moment, and arrhythmias. Also, determining the severity and the stability of the disease condition and the prior treatment. Assessment of functional capacity is very important. Age of the patient, comorbid conditions such as diabetes, peripheral vascular disease, renal dysfunction, and pulmonary disease, and also the type of the surgery, especially the urgency of surgery, whether it's an urgent surgery or an elective surgery, and of the risk of the surgery, such as high-risk surgeries like valvular procedures, prolonged and complicated thoracic abdominal surgeries, and head and neck surgeries. We'll discuss each one of these next. Now, these are the risk factors for perioperative major cardiac events. That includes reduced functional capacity. We'll discuss what the functional capacity, how the functional capacity is determined. Ischemic heart disease, heart failure, cardiomyopathies, severe valve disease, especially severe aortic stenosis and severe mitral stenosis, significant arrhythmias such as AV conduction blocks, and also ventricular arrhythmias, chronic renal failure, history of CV and transient ischemic attacks, diabetes who are on insulin, chronic pulmonary disease, obesity, and anemia. These are the major clinical predictors of cardiac risk. The patients who are having unstable coronary syndromes, such as recent myocardial infarction with post-infarction angina, unstable angina, or severe chronic stable angina, that is of CCS class 3 and 4. People who have decompensated heart failure, significant arrhythmias, as I mentioned before, AV blocks, and also symptomatic ventricular tachyarrhythmias. Severe valve disease are also categorized into major predictors of cardiac risk. Then intermediate predictors include mild angina pectoris of class 1 to 2, history of myocardial infarction detected by the history or pathological Q waves in ECG, compensated heart failure or history of heart failure, diabetes mellitus. Minor risk predictors include, at the advanced age, abnormal ECG findings such as LVH, left bundle branch block or ST abnormalities, rhythms other than sinus rhythms such as atrial fibrillation, low functional capacity, that is less than 4 metabolic equivalents, history of stroke, and uncontrolled hypertension. This is how the functional capacity can be assessed by METs. We can take a good history and assess the functional capacity of the patient in the ward setting or in a clinic, or else we'll discuss later, we can do an exercise ECG where you can actually measure the METs objectively. Up to 4 or less than 4 METs is considered as poor functional capacity. 4 to 10 is moderate, and more than 10 or more METs, if you can do during day-to-day activities, is considered as having a very good functional capacity. Now, according to the surgery, also we can assess the risk of cardiac events. The people who undergo high risk surgeries like cardiac risk more than 5% are emergency major operations, particularly in elderly, aortic and other vascular surgeries, peripheral vascular surgeries, and surgeries where the anticipated prolonged procedures associated with large fluid shifts or blood loss. The intermediate risk surgeries, that is the risk of cardiac events between 1 to 5%, include carotid endarterectomies, head and neck surgeries, intraperitoneal and intrathoracic surgeries, orthopedic and prosthetic surgeries. The low risk surgeries are the endoscopic procedures, cataract and breast surgeries, and no other superficial surgeries. Now, in order to calculate the overall risk of cardiovascular events, there has been several published risk assessment methods. I don't want to go through all these, but it actually started in 1977 by Goldman's landmark publication, but that was modified by Desky and others later on. And many of the recommendations I am going to discuss today are from ACC and AHA guidelines, which was first published in 1996 and later updated in 2002 and 2014. What is important in the clinical practice is actually the last three, the publication of revised cardiac risk assessment index by Lee in 1999, and also these National Surgical Quality Improvement Program calculators by Gupta and later their updates. Now, this is what many people practice because it is easy to practice and it is very reliable. In Lee's revised cardiac risk index, they go by 6 independent risk factors. They are the risk of the surgery, history of coronary artery disease, history of congestive heart failure, history of cerebrovascular disease, diabetes who are on insulin, and preoperative serum creatinine of more than 2 milligrams per deciliter. So if all the factors are given equal weight and the score is calculated, if the score is 0, that is the lowest risk category, the cardiac event rate is 0.4%, and if 1.9%, 2 is 6%, and more than 3 or more is 11%. Now these figures also change time to time and change with each meta-analysis. But however, this is a very useful tool for the day-to-day practice. The other one is, as I said, the National Surgical Quality Improvement Program, myocardial infarction cardiac arrest calculator, where they use other parameters, type of surgery, functional status, creatinine concentration, ASA, physical status classification, and age. Now, in the previous Lee's index, the age was not considered. And some think that this model has a better discrimination over the revised cardiac index. The NSQIP surgical risk calculator is an online calculator like the STS calculator for cardiac surgery. And this is for the non-cardiac surgery, where 21 patient-specific variables are used and calculate the risk of myocardial infarction and cardiac arrest during perioperative period. So we can use either of these to assess the risk and discuss with the surgical team and the family at the time of the surgery. So this is an objective measurement of the risk. Now, the big question is, what should we do when a patient comes? Now, because all depends on the risk of the patient as well as the urgency and the requirement of the surgery. If it is a life-threatening emergency and the surgery, urgent surgery is essential to save the life, we have no choice but to go ahead with the surgery. We have to take all the precautions during the surgery and during the post-operative period. We have to discuss with the surgical team and the family and explain to them. If the patient is having ongoing acute cardiac event like myocardial infarction or decompensated heart failure, some significant arrhythmia, or else patient is having hemodynamically compromised valvular lesions, again, we have to manage those conditions as per the guidelines and then consider them for surgery if they can wait for the treatment. If the risk is minor and the patient also has low risk and going for low risk surgery, patient does not need any further evaluation, they can go for surgery. Otherwise, we can assess their functional capacity. If the METs are more than 4 and the patient is asymptomatic, again, we can consider them for surgery. So initial steps are very easy. Within few minutes of evaluation of the patient, we can decide. However, the outcomes may be vary. The problem comes if the functional capacity is also poor, they are going for elective surgery and has several risk factors. Then if they have more than 3 risk factors and going for high risk surgery or more than 3 risk factors going for intermediate surgery, you have to evaluate. Actually, the step 5 in this diagram are the patients who need real pre-operative risk assessment and evaluation with other investigations. These are the methods we can use: history and examination, ECG, echocardiography, stress ECG, pharmacological stress testing, ambulatory ECG monitoring, that's Holter, and coronary angiography. We'll briefly discuss how we do that. Of course, as physicians, we always have to do the objective examination and taking measurements like heart rate, blood pressure, respiratory rate, temperature, saturation, height, weight, and the body mass index. And especially to assess the cardiac risk, to identify any active cardiac problems, it's important to find out whether there is third or fourth heart sounds, pulmonary crepitations, elevated JVP, ascites, hepatomegaly, dependent edema, and also the patient, whether the patient has murmurs suggestive of hemodynamically significant valve disease. Now, almost everyone get a preoperative ECG. However, the guidelines say if the patient is of intermediate or high risk, going for intermediate or high risk surgery to get that. Draw the attention to the 4th line. Preoperative ECG is not recommended for patients who are not having risk factors and also going scheduled for low risk surgery. But most of the patients include in the first 3 categories and should have at least an ECG for cardiovascular risk assessment. Now, echocardiography is another common investigation we do. Actually, we do echocardiography to assess the LV functions as well as to assess the valve functions, including other structural heart diseases. Now, it is indicated if the patient has dyspnea of unknown etiology and also patient with a history of heart failure with worsening dyspnea or other change in clinical status in the recent past, or else even the patients who have history of heart failure with no echocardiogram done during last 1 year. Others, the routine preoperative evaluation with echocardiography to assess the LV functions is not recommended. In terms of valvular functions, if we hear a murmur, which is suggestive of moderate or severe stenosis or regurgitation with no echocardiogram done during the last 1 year, or significant change in the clinical status since the last evaluation, we should do an echocardiogram. Exercise testing is not commonly done in our country, However, this is a very useful tool because it gives us evidence of inducible ischemia and also can assess the functional capacity, as I mentioned before, and not only the evidence, but also the severity of ischemia and the hemodynamic stability during stress in terms of hemodynamic and electrical stability. Exercise stress testing is indicated in patients who have poor functional capacity or unknown functional capacity if they have high risk or intermediate risk factors. And also intermediate to high risk patients with poor functional capacity, we can do exercise ECG to assess the evidence of myocardial ischemia. And all these are done if we can do something either medically or by an intervention to improve the situation before the surgery. Pharmacological stress testing is also important, especially for the people who can't exercise. We can do dobutamine stress echo and also nuclear perfusion imaging with dipyridamole or adenosine stress. We can do this especially in people, high-risk people with poor functional capacity to assess evidence of inducible ischemia. Now, coronary angiography is not commonly done before surgeries, but especially in the patients who are very high risk and going for high risk surgeries and angina and unresponsive for adequate medical therapy, unstable angina, and also high risk patients going for high risk surgeries with unequivocal non-invasive test results should be considered for coronary angiography if facilities available. But there are class 2 recommendations, mostly, especially the patients who are going for high risk surgeries and when they have intermediate to high risk factors. Especially the people who demonstrate large areas of ischemia on non-invasive imaging or by exercise testing should be considered for coronary angiography. However, all these testing should be considered if we can go ahead with some treatment, some management plan to change the situation of the patient and to reduce the cardiac risk at the perioperative period. There are some class 3 recommendations where we should not consider coronary angiography before surgery. Those are the low risk patients going for non-cardiac surgery and no high risk results from the non-invasive testing. When the people have asymptomatic people have good functional capacity, those sort of patients should not be considered. And also very severe patients where we don't consider coronary revascularization, especially when they have severe left ventricular dysfunction, or if they are refusing to undergo revascularization, should not be considered. One controversial point is that candidates who undergo liver, lung, or renal transplantation, whether we should consider them for coronary angiography routinely. Now, various transplant programs include this as an investigation. Like in other countries, after 50 years or when they have diabetes more than 10 years, should routinely get an angiogram before it. But the guidelines says it should not be done even before these transplant surgeries. Now, perioperative management, I will discuss briefly because Dr. Ganaka Senaratne discussed this in detail. However, severe hypertension, especially when the blood pressure is more than 180 systolic and diastolic 110, should be controlled before the surgery when possible. And if the patient is on antihypertensives and the blood pressure is adequately controlled, they should be continued. Now, various studies have shown different results, and it's a bit confusing when you look at the literature. However, the guidelines say the continuation of ACE inhibitors and ARBs are reasonable, especially if they are given for purpose like heart failure. and should be continued cautiously during the surgical operative period. However, if they are stopped pre-operative, they should be restarted as soon as possible after the surgery. Symptomatic stenotic lesions such as mitral stenosis and aortic stenosis who are undergoing high-risk surgery and who are likely to develop perioperative shock because of the valvular lesion should be considered for percutaneous valvotomy or replacement to lower the cardiac risk before the surgery. But symptomatic regurgitant lesions rarely give rise to problems, and they are better tolerated. They can be stabilized with medical therapy before the surgery. However, all these patients with significant valvular problems should be monitored very closely during the intraoperative and postoperative period when they undergo, especially when they undergo intermediate and high-risk surgery. The people with arrhythmias, we have to investigate and see whether there is any structural or metabolic reason for the arrhythmia, such as electrolyte imbalances and also drug toxicities. They should be corrected before the surgery, and you prevent the risk of developing arrhythmia during the perioperative period. Especially people who are on pacemakers and ICDs, we need to contact the cardiac team and inform them that so-and-so is undergoing the surgery, especially if you are planning to use the diathermy. And oftentimes we can inactivate the device. However, if you inactivate the device, the meticulous cardiac monitoring should be done during the entire period of inactivation, and CPR facilities and external defibrillation should be readily available to resuscitate the patient if they develop a tachyarrhythmia. Coronary artery disease and heart failure medication should be continued. The beta blockers, calcium channel blockers, nitrates should be continued during the intraoperative and postoperative period. The medications given for pulmonary hypertension and right heart failure also should be continued unless they are contraindicated or not tolerated by the patient. Now, perioperative beta blocker therapy, again, this is very confusing in the literature. Different trials, different randomized control trials also have given different results, as Dr. Ganakasera described in the POISE trial. It gives adverse outcomes when you use beta blockers during therapy. However, the guidelines say beta blockers should be continued perioperatively in patients who take these medications long term. If they are already on beta blockers, they should be continued. And also, it is reasonable to start perioperative beta blockers in intermediate to high risk patients for myocardial ischemia noted during risk stratification, especially if the exercise ECG is positive and not going for revascularization and so on, should be on beta blockers. And the heart failure patients should be on beta blockers at the time they go for surgery. The issue is when we should start beta blockers. Ideally, as Dr. Ganakasera quite rightly described, beta blockers should be started at least 1 day before the surgery to assess the safety and tolerability. They should not be started on the day of the surgery. Statins should be continued perioperatively if they are already on those medications, and also they should be considered as treatment if the statin guidelines, therapy for statin guidelines indicates for high-risk patients. And also, especially when they undergo vascular surgery, such as carotid surgery, statins are indicated to be started at the time of the surgery. Antiplatelet agents was well described by Professor Lalendra Gunaratne. However, especially if the patient had balloon angioplasty or stent deployment, either bare metal stent or drug-eluting stents, they should be continued. The issue is patients going for urgent surgeries within first 4 to 6 weeks after the interventional procedure. Now, if this is done within the first 6 weeks, we encourage to continue dual antiplatelet therapy and assess the risk of bleeding and the stent thrombosis. If the risk of stent thrombosis is more than the risk of bleeding, we should continue with the antiplatelet therapy during that period, the dual antiplatelets. And many other patients, high-risk patients going for elective non-cardiac surgeries can be on aspirin at the time of surgery. Again, as Professor Lalinda said, the risk of bleeding and risk of thrombosis should be assessed. If the risk of bleeding is lesser than the risk of thrombosis, the aspirin should be continued. In all the other patients, antiplatelet therapy should be held, and he gave you the different time periods before the surgery. Bypass surgery or stenting, there are no randomized clinical trials to document decreased incidence of perioperative cardiac events by doing these procedures. However, if the coronary anatomy suggests prognostic lesions that can improve the survival of these patients by doing the revascularization, we should consider them before the surgery. However, coronary revascularization is not recommended before non-cardiac surgery, exclusively to prevent perioperative cardiac risk. Perioperative PCI also the same, no randomized trials to show a benefit to reduce cardiac events. And when it is done, elective non-cardiac surgery should be delayed for 14 days after balloon angioplasty, 30 days after bare metal stents, and 6 to 12 months after drug-eluting stent placement. Anesthetic considerations, there's no one best myocardial protective anesthetic technique. To my knowledge, our anesthesia colleague will have their opinions. Opioids, when used, they are good for cardiovascular stability, but they may need post-operative ventilation. And inhalational agents can cause myocardial depression, and neuraxial blocks can cause sympathetic blockage, especially low-level ones are okay with minimal hemodynamic change, but when they are used for abdominal operations, can cause profound effects by causing hypotension and reflex tachycardia. Perioperative pain management is very important, especially patient-controlled analgesia can be administered either intravenously or epidural to reduction of pain. They reduce the post-operative catecholamine surge and hypercoagulability, and in terms of that, it will reduce the myocardial ischemia. Intraoperative nitroglycerin may be helpful, but sometimes it can cause vasodilatation together with other anesthetic agents and may cause significant hypotension and even myocardial ischemia. Intraoperative monitoring is very important to reduce cardiovascular events. Nowadays, in major surgeries, high-risk surgeries, perioperative transesophageal echocardiography is done, and it is useful in patients with hemodynamic instability for the monitoring. Pulmonary artery catheters are also placed for monitoring of pulmonary artery pressure, and they may be considered in patients who have cardiac conditions that significantly affect hemodynamics, like recent myocardial infarctions, decompensated heart failure, severe valvular disease, and so on. Also, maintenance of normothermia may be reasonable to reduce perioperative cardiac events in patients undergoing cardiac surgery. Now, perioperative surveillance of myocardial infarctions, the best is to go by the clinical symptoms post-operatively, and also if there are symptoms or ECG changes, we can check the cardiac markers such as CKMB, troponins, and CKMB isoforms. One cost-effective method is to do an ECG at baseline immediately after surgery and the first 2 post-operative days and compare these ECGs, especially in the high-risk patients. Routine use of cardiac enzymes are not advised unless the patient has either clinical or ECG evidence of or hemodynamic evidence of ischemia. Another way is intraoperative and post-operative ST monitoring. Is computerized ST segment analysis can be done and may improve the sensitivity of detection of myocardial ischemia. Intraoperative and post-operative ST segments are strong predictors in perioperative myocardial infarction. Lastly, this is a good opportunity for us to find out patients. They may be coming for a surgery that can be cured by doing the surgery, but these cardiac conditions and the risk factors can be first found out at the time of the surgery, and they should be monitored long term. And also, we have seen enough of patients who were diagnosed before and have stopped their treatment. They can be restarted and motivate the patients to continue the treatment to prevent long-term complications and cardiovascular events. Thank you.
For participation. Thank you. There are actually some questions, but we are running behind the schedule, so I don't think we'll be able to answer any questions right now. So to conclude this session, may I once again thank Dr. Ganaka Senaratne, Dr. Suranga Mayugama, Professor Larindra Gunaratne, and Professor Namal Vijayasinghe for their excellent talks. Thank you very much on behalf of SLSIM and SLM. Now, we were planning to have a tea break, but I think we forego that and move on to our next segment, which is a series of roundtable discussions in DTs. And to begin the first, may I invite Dr. Vishaka Ratnamala, consultant hematologist, National Hospital, Sri Lanka. Actually, she was going to do this session with Dr. Harinda Karunatilaka, specialist in internal medicine, National Hospital, Sri Lanka, but due to unavoidable circumstances, he is not able to join us today. So I would like to invite Vishaka to deliver her talk.
Yes, this one.
Present the certificate.
This one. My arrow keys, madam. My arrow keys, you can move the slide. Arrow keys, you can. You can annotate this.
For the online participants, If you have questions regarding these presentations, you can send to the chat box so that we won't waste time and we can address your questions soon. Thank you. Yes, Lisa.
Good morning. Thank you very much. Today, the unusual case of myeloma discussion should be carried out with Dr. Harindra Karunatilaka, but he is unable to attend the session, so I have to continue. This is not moving. So I will present the history now. This is from Harindra's ward. This patient, 68-year-old male, was attending medical clinic for hypertension for a longer period, maybe 2 to 3 years. And the doctors noticed that he is developing mild cytopenia. Hemoglobin 9.8, WBC 3,919, and platelets 139,000. So the general and systemic examination was normal. So then the patient was admitted to the ward and investigations were done. So somebody has anyway very keenly suspected on multiple myeloma with above counts, and following investigations were done. The blood picture shows pancytopenia, but there was no rouleau formation, no abnormal cells. Serum protein electrophoresis was normal. Skeletal survey was normal. Urine electrophoresis showed a tiny monoclonal band, and the serum calcium was normal, 2.13. The creatinine was slightly high, 2.2 millimoles per liter. Further workup showed LDH of 361, ultrasound scan was normal, 2D echo was negative, and the viral screen was negative. Immunofixation study was done, and it showed IgG, kappa, monoclonal proteins. Then the serum-free light chain assay was performed because SPE is normal, and it was 895.8. And that was kappa. Lambda light chains were normal, 7.44. Kappa lambda ratio was 120.4. Albumin also normal, 43. And beta-2 microglobulin was very high. So you can see only few investigations were normal. The usual myeloma investigations were negative in this patient. So the final diagnosis was light chain myeloma with elevated serum creatinine and mild anemia. So treatment was started for multiple myeloma with bortezomib, cyclophosphamide, and dexamethasone. Now about plasma cell disorders, this is a clonal proliferation of plasma cells, presence in the serum or urine of monoclonal protein, that is M protein. When the complete molecule is there, we call it paraprotein. When the light chain is there, we call it Bence-Jones protein, or both can be there. So the plasma cell disorders are multiple myeloma, MGUS, that is monoclonal gammopathy of undetermined significance, solitary plasmacytoma, Poem syndrome, amyloidosis. In the picture, you can see amyloidosis in this slide, the pinkish material pushing the hemopoietic elements out, and it's spreading involving the bone marrow area, amyloidosis. Then about multiple myeloma, about 5,500 cases per year diagnosed in UK actually, and the peak age is 69 to 70 years. So at this stage, we must screen them for myeloma. So the basic types are MGUS, smoldering myeloma, multiple myeloma, and plasmacytoma. So you can see in this picture, the plasma cells, these are abnormal morphologically with eccentric nucleus and abundant bluish cytoplasm. That is because of the immunoglobulin secretion, the cytoplasm is blue. There are many plasma cells, here multinucleated one and so on. So there are normal hemopoietic cells also, we have to recognize them. This is a special cell, the myeloma flame cell, which occurs in IgA secreting myeloma. This is a normal plasma cell. You can see the halo here due to Golgi apparatus. So in the abnormal ones, usually halo has disappeared. So now in the ward, when to suspect multiple myeloma, when you see a patient, if it is a straightforward case, patient will have back pain, very high ESR, and you can straight away think of multiple myeloma. But there are many unusual presentations, sometimes persistent bone pain for longer than 4 to 6 weeks with no obvious trigger, neuropathic symptoms, recurrent infections, lethargy, concerning unexplained pains, fatigue, and the fever, sweats, symptoms of hypercalcemia, anemia, gastrointestinal disturbances, or weight loss, organomegaly, skin changes. Such unusual presentations, you have to think of unusual multiple myeloma. So the full blood count, blood picture, serum creatinine, serum electrolytes, serum calcium, serum protein electrophoresis, urine protein electrophoresis, and X-ray. So other imaging should be done as basic diagnostic investigations in the ward. All the other sophisticated investigations we should do after diagnosis of the myeloma. So indication for bone marrow, when you have seen a paraprotein or elevated serum free light chain, particularly when it's associated with anemia or renal impairment, hypercalcemia, immunoparesis, lytic bone lesions more than one, or focal lesions on whole body imaging, or with the recurrent infections, you can ask for a bone marrow. Now, diagnosis of symptomatic myeloma. Now, we have to consider the criteria of diagnosis of myeloma, because some need no need of treatment, but symptomatic myeloma, we should go for treatment. To diagnose these, the criteria are simple as that. Monoclonal plasma cells should be more than 10% in the bone marrow or trephine biopsy. With that, there should be CRAB criteria. Unless CRAB criteria, we should not go for treatment. These are the myeloma-related organ or tissue injury. The C stands for hypercalcemia, that should be more than 2.75, and the R stands for renal impairment. Creatinine should be 177 micromoles per liter. And anemia should be less than 10 milligram, and no other causes should be there for this anemia. And the bone lesions in the X-rays, CT, PET, or other imaging, it should be one or more than osteolytic lesions. So then the smoldering asymptomatic myeloma, we should not go for treatment. We can wait without treatment. Absence of treatment requiring myeloma defined events are not there. Those are the CRAB criteria are absent. But the monoclonal serum protein is more than 30 grams per liter. It's a fairly big M band, you can see. But 10 to 60% plasma cells can be there in the bone marrow as well. Still, the CRAB criteria are not there, so we can wait without treating. There are 3 conditions, however, even without CRAB criteria, we must go for treatment. That is, when the plasma cells are more than 60% in the bone marrow. Or when the serum free light chain assay ratio is more than 100, and you have to always, it should be involved serum free light chain assay. And the bony lesions are more than 1 on the MRI. Even without CRAB criteria, we should seek treatment. Then the MGAS is a paraprotein is less than 30 and the marrow clonal plasma cells are less than 10. In this situation, no evidence of CRAB criteria, we call it monoclonal gammopathy of undetermined significance. So we can wait without treatment, but patient need follow-up every 6 months. We have to do the CRAB criteria as well as the paraprotein assessment. Urine monoclonal protein also should be less than 500 in this case. And we find solitary plasmacytoma of the bone. They are a single bone lytic lesion confirmed to be composed of clonal plasma cells on the biopsy. Always we should go for bone marrow and other criteria, investigations to rule out myeloma. If only plasmacytoma, they can go for radiotherapy. So hematology workup also same as I described, the full blood count, retic count, blood picture, ESR, serum proteins, albumin, globulin, blood urea and uric acid we should do. You can see in this picture marked rouleau formation in classic case of myeloma. The Chinese letter arrangement here, the ESR will be definitely more than 100. Rest of the hematology workup also, as I mentioned, 24-hour urine collection to quantification of Beinstone protein. But in routinely, we don't do this. We do the spot urine Beinstones. That's also acceptable. Serum protein electrophoresis, urine protein electrophoresis, immunofixation, it's done to identify the subtype of protein, whether IgG, IgA, or lambda. We cannot quantify the paraprotein amount by immunofixation. Serum-free light chain assay, then we can do the cytogenetics and the skeletal survey, MRI, and calcium. So these are some pictures you come across daily. This is the electrophoresis strip. This is the M-band. This is albumin. Then alpha beta chains are here. You can see the M-band, corresponding M-band here. In the urine, this is the corresponding M-band. You can see a tiny band. This is immunofixation. To prove clonality, sometimes we have to go for immunofixation, which is very expensive investigation. Right. Then this is a common finding in our clinical practice, a tiny paraprotein band, which is a problem for all of us. Very small amount of paraprotein, sometimes available in the serum protein electrophoresis. We have done so many bone marrows and we found it's not mostly myeloma, maybe evolving. You have to follow up these patients and we have to screen for CRAB criteria and we can wait and watch. Other investigations to show the prognosis is serum beta-2 microglobulin, albumin, LDH level, and the FISH. So in FISH, deletion 13, 17p13, translocation 414, 1114 are bad prognostic markers. And CRP also, if very high, it's a bad prognostic marker. In the staging, we consider revised ISS staging. For staging, these markers are important. Beta-2 microglobulin, if less than 3.5, stage 1, albumin, if more than 3.5, and no high-risk cytogenetics in the FISH, and normal LDH, then this patient fall onto stage 1. If these are very high, with high-risk cytogenetics, it will be stage 3, and stage 2 is in between. So these are some of the images of immunohistochemistry done in the histopathology lab. To show clonality, sometimes we have to do the kappa, lambda staining immunohistochemistry. CD138, it's positive in normal plasma cells as well. So it does not show clonality. It's abnormal as well as normal plasma cells will be positive with CD138. Sometimes when the cells are scanty, to count the number of cells, we use this marker. This is a routine HNE of a trephine biopsy. So few pitfalls I am going to tell you. In clinical practice, sometimes we find patients with normal ESR, no rouleau formation, SPE normal. Then we have to think whether light chain myeloma, because around 15 to 18% of patients are light chain myelomas. So both kappa and lambda elevate in severe infection. So if you do only these, and if the levels are very high, you have to see whether the patient has an infection, and we should not do it during severe infections. And low light chains can be seen in immunosuppression, drugs like steroids, and high levels in renal disease. We have to take all these into account. Normal skeletal survey and no obvious CRAB criteria, then we should go for whole body MRI to detect whether there are tiny, invisible, bony lesions. Then sometimes during bone marrow aspiration, it can get clotted. Then we go for clot biopsy, trephine touch smears. Sometimes the trephine biopsy get crushed because of the osteoporosis. Then we have to look for again clot biopsy, trephine touch for reporting. And very small monoclonal band, as I told you earlier, tiny bands are really troubling. We have to observe the patient unless CRAB criteria are there. So the treatment wise, basically, we have to go for these treatments for myeloma patients: laminectomy, supportive care, radiotherapy, chemotherapy, and autologous transplantation. So there's no cure for multiple myeloma so far, but we can control the disease with all these treatments. Thank you very much. These are my references.
From the audience or online participants? If you have questions, you can post in the chat box. Just one question, Visaka. Like you told about the asymptomatic category without CRAB criteria.
Yes.
What
Smoldering?
Yes.
Yeah.
What is the prognosis of that? You said.
Yeah, usually smoldering myelomas, we see them going into multiple myeloma in about 6 months time. So we have to closely monitor them.
Thank you. Right now, the certificate will be handed over to Dr. Visaka.
The next topic in this series of MDTs is a woman with walking difficulty. Dr. Premani Jayasekara, specialist in internal medicine, General Sir John Kothadal Defense University, is here with us today. So may I invite her on to the podium, and Dr. Duminda Munidasa and Dr. Munidasa, who is the consultant rheumatologist, Rheumatology and Rehabilitation Hospital, Ragama, and Dr. Darshana Sirisena, consultant neurologist, Colombo North Teaching Hospital, will join us virtually. May I invite Priyamali onto the stage?
Good morning, everyone. We have come to the second case of our roundtable discussion, a woman with walking difficulty. Myself, Premali Jayasekara, physician, Dr. Darshana Sirisena, neurologist, Dr. Mudhuminda Munidasa, rheumatologist, will be discussing this case. A 54-year-old woman presented with constitutional symptoms for 3 months. And she had acute onset burning pain in lower limbs, numbness of both feet a month ago. And there was progressive difficulty in walking. There were no backache, no other systemic symptoms. When we look at the past history, she had a pulmonary TB at the age of 18 years, an episodic short of breath for 3 years, no history of cough for weeks, no diurnal or seasonal variation. She was treated as late onset asthma with inhaled corticosteroids. She was self-medicating with theophylline and montelukast as well. She had recent exacerbation 3 months back requiring oral prednisolone. And further, she had allergic conjunctivitis for 3 years, 3 episodes of acute suppurative otitis media, and hypertension for last 3 months, and she had hypothyroidism for 5 years. So we'll go to the examination. She's an average built woman with no significant lymphadenopathy, no skin rashes, no evidence of arthritis. Blood pressure was 140 by 90. Respiratory system, there's a bibasal end inspiratory crepitations, no rhonchi. Abdomen, no organomegaly. Central nervous system, cranial nerves were normal. Upper limb examination was normal. In lower limb examination, she had bilateral high stepping gait, left more than right. When you look at this chart, you can see the left side is more affected than right. There's a zero power of ankle dorsiflexion, extensor hallucis longus, ankle plantar flexion, ankle eversion, inversion in left side, but ankle dorsiflexion and extensor hallucis longus, grade 4 power in right side. And she had absent ankle jerk on left side and sensory loss of L4, 5 and S1, right side L4 and L5. Back examination was normal. So with this, the problem identified was woman with walking difficulty having sensory motor deficits in both lower limbs. I would like to ask Dr. Darshana Sirisena, neurologist, to evaluate this problem. Over to you, Darshana.
Thank you, Primali, for the presentation of the history and the examination. So this is a 54-year-old lady with a lot of comorbidities in the background, presenting with a neurological problem which is difficulty in walking, and the examination findings are confined to the lower limbs. So when it comes to the neurological aspect of this, my priority when examining this patient is to come for a neurological diagnosis. So when you go through the history and examination, the salient features in this patient is it's an acute onset, painful, progressive over 1 month, and predominantly asymmetrical, where the left side is more affected than the right, which is distal, flaccid, motor more than sensory weakness. So clinically, which we call as a predominantly asymmetrical, motor more than sensory, lower motor neurotype of lesion. So when it comes to such a neurological diagnosis, the next aspect would be to what site could be get affected. When it comes to the lower motor neuron type of lesion, it could be a radiculopathy, which is very a vague term, very broader term I would say, which involves the nerve roots at the level of the spinal cord, which could be compressive or non-compressive, as you know. Or the next is the involvement of the peripheral nerves. When it comes to the classification, it could be a mononeuritis multiplex or a symmetrical peripheral neuropathy. So as the key features in a mononeuritis multiplex, it's painful and asymmetric, which our patient had. Whereas in the peripheral neuropathy is usually a symmetrical, which pain may be there, usually it's a tingling or a burning sensation, which did not fix into our patient's presentation. So therefore, this is at this stage. So most important investigation I would like to consider in this patient would be the neurophysiological studies, or which we namely the nerve conduction studies coupled with the EMG. So what it will give, it will confirm our examination findings. At the same time, it gives some further evidence whether it's a demyelinating or axonal, which is very important in the management aspects and finding etiologies. And next time, depending on the nerve conduction findings, which we can further look forward for the other investigation. So what were the findings? So it showed or it confirmed our examination findings where it showed asymmetrical nature, sensory and motor involvement, and other important thing is the axonal involvement. So it usually excludes the demyelinating pathologies, maybe the atypical Guillain-Barré-like picture or a CIDP, and it confirms the findings are due to the lower limbs, which confirms our findings. Thirdly, it shows some sort of a sheds light on some sort of sites also. It says postganglionic, so it's outside the spinal cord. It's outside the spinal cord, which could be plexus. So the plexus is very unlikely in the clinical history, and the proximal nerves, which could be the peripheral nerves or a neuropathy or mononeuritis multiplex, as I mentioned already. So what is mononeuritis multiplex? It's a painful, asymmetrical, asynchronous sensory and a motor peripheral neuropathy involving isolated damage to at least two separate nerve areas. The multiple nerves in random areas of the body can get affected, as you very well know, which could be a diabetic patient could have a 6-nerve palsy, and later he could have a foot drop due to the common peroneal, like they are two separate areas of the body. So, but the most important thing is when this mononeuritis multiplex evolves, especially at a rate, as in our patient, it becomes less multifocal, therefore it becomes less asymmetrical, or what we call as more symmetrical. So what are the causes? Common things are common. Always consider diabetes, but in our patient, it didn't give a clear history of such. So immune-mediated pathologies has to be considered. What we call as, it's a broader term as vasculitic neuropathies. Amyloidosis has to be considered when it comes to mononeuritis multiplex. In our patient, it's less likely because there was no clinical features in the history and examination to suggest such. Paraneoplastic always come to the picture, especially at elderly and other rheumatological conditions like polyarthritis nodosa, rheumatoid SLE, and the idiopathic always has to be considered. So at this point, the most important investigation for me would be a biopsy. The commonest site to the biopsy is the sural nerve. So there is, which showed, and in fact in this patient, sural nerve biopsy showed evidence of histological features suggestive of vasculitis. So it confirms, and so far this confirms the patient has a vasculitic neuropathy. More specifically, it's a peripheral vasculitic neuropathy. So when it comes to diagnostic classification for peripheral vasculitic neuropathies, it could be two types. It could be a systemic or non-systemic. Systemic could be further subdivided to primary systemic vascular neuropathy or secondary forms. So what are the primary ones which you know, which is the vast majority represent of the peripheral vascular neuropathies? The polyarthritis nodosa, the Churg-Strauss syndrome, vaginous granulomatosis, and microscopic. Those are the common. There are many in the list, but I have listed the common ones only. All the connective tissue disorders, right, rheumatoid SLE comes to the secondary causes, as well the cryoglobulinemia associated with hepatitis C infection and always paraneoplastic infection.
So we'll start with the investigations. Full blood count, she had low hemoglobin, which was 10.3, which was slightly low, and WBC of 9,500 and 20% of eosinophils. Absolute eosinophil count was 1,820. She had blood picture showed moderate eosinophilia with mild iron deficiency anemia. ESR was 48. Her X-ray lumbar sacral spine was normal, and as she had nasal congestion and bit of a headache, we went ahead with CT brain. So it was normal except for ethmoid and maxillary sinusitis. Her ANA was positive, which was above 1:80. P and C anchor were negative. This is a chest X-ray which has bilateral lower zone reticulonodular shadows with calcified lymph node which resembles old TB. This is a HRCT which has patchy ground glass opacities in subpleural areas of lower lobes. The impression was chronic organizing pneumonia. You can see her lung function test. Diffusion capacity is low, which was 48. And FeV1 to FVC ratio is 110, compatible with restrictive lung disease. We went ahead with bronchoscopy and BAL studies, which were normal, and her sputum AFB 3 times negative, sputum for TB gene experts negative. As she had hypertension, we want to exclude any renal involvement, so we did UFR, which had 2+ albumin, and RBC and CAST were nil. Urine protein creatinine ratio was 2. Blood urea and creatinine was normal, with normal ultrasound KUB. This is a renal biopsy, which is favor of small vessel vasculitis. This slide shows the rest of the basic investigation with normal fasting blood sugar, and echocardiogram was normal except grade 2 MR. The liver profile was normal. TSH was normal with serum ferritin of 300. In this point, I would like to explain about few investigation in small vessel vasculitis and chest X-ray finding. Usually we see transient pulmonary infiltrates, and we can have peripheral patchy pulmonary opacities, and about 25% of people chest X-ray can be normal, and they can have extensive airspace opacity when there is hemorrhage, and there can be pleural effusions, and rarely they can have large hilar lymph nodes. An HRCT finding, our patient had ground glass opacity. Actually, it is the frequent feature which can be transient, often bilateral, and it can be symmetrical or patchy. And they can have traction bronchiectasis, honeycombing, subpleural nodules, consolidations, and bronchiectasis, usually compatible with interstitial pneumonia. The lung function test shows restrictive lung disease with low diffusion capacity, and full blood count shows eosinophilia, which is above 1500, and this particular lady has VC. And interestingly, revealing the history, this patient was self-medication with Montelukast. What is the significance? So, eosinophilic granulomatosis is increasingly recognized in asthmatic patients who are on leukotriene antagonists, but they don't know the cause exact mechanism is not known yet. So, clinician to be vigilant in all patients who develop systemic symptoms when start treatment with leukotriene antagonist. With that, I would like to compile all the problems up to now, starting with painful asymmetrical sensorimotor peripheral neuropathy of lower limbs, mononeuritis multiplex confirmed, sural nerve biopsy compatible with vasculitis, then preceding constitutional symptoms for 3 months, allergic conjunctivitis, recurrent otitis media, CT sinusitis, lung disease with recent exacerbation and good response to steroid. HRCT shows chronic organizing pneumonia, and she had renal involvement with newly diagnosed hypertension, subnephrotic range proteinuria, renal Bartley showing small vessel vasculitis, peripheral blood eosinophilia, ANCA negative but ANA positive. With this problem list, I would like to ask Dr. Dominda Munidasa, rheumatologist, can we put all these problems under one umbrella? Over to you, Dr. Dominda.
Thank you, Priyamali. Looking at this problem list which Priyamali presented to you, it is obvious this patient is having a disease which has involved multiple systems. Specifically here, mainly the neural system, the lungs, and the kidneys. Whenever you are presented with such a patient, or you start taking a history and then examine and find that there are multiple systems involved in that patient, you should try to build up a differential diagnosis first and then work it out to find what exactly the cause. So generally how I look at these patients, when they come with a multi-system, of course, the autoimmune inflammatory conditions comes in the top, the connective tissue diseases and different sort of vasculitis. But we need to always think about the infections, especially tuberculosis in this country, the HIV, as well as leptospirosis and even dengue can present with the multi-system involvement. Neoplasms and paraneoplastic syndromes are also a common reason that we may see patients having multiple systems involved. Diseases like amyloidosis, which cause infiltrative type of changes in different organs, is something always need to keep in our back of our mind. So building up this differential diagnosis is through the history examination investigations. Using the history, symptoms, signs in examination, investigation findings, we try to build up a pattern of involvement in our patients. This pattern recognition is especially very important in rheumatological diseases, specifically in the connective tissue diseases and vasculitis, which will tell us what most likely diagnosis. But going on, not only the pattern recognition of this, we always need to exclude the infections, neoplasms, and the diseases like amyloidosis in this patient. Otherwise, you may mislead into believing the patient is having something else. So while the history, like in our patient, the history told us there is very likely the respiratory and the neural system is involved, the examination gives us a clue that blood pressure is high, since maybe renal is involved. So that missing parts were added by doing the investigation. So always when you plan out investigation in such a patient, need to go through all the systems or do basic investigation to see whether any of the other systems are involved. Then we need to do supportive investigations like autoantibodies in the rheumatological diseases. But of course, remember, the false positives can happen. Like in this patient, the ANA is positive, but certainly this patient is not showing any other feature to suggest that patient is having SLE. So all ANA positives does not mean that. Similarly, in this patient is ANCA negative, but still we ultimately came to a diagnosis. This is ANCA associated vasculitis because of the other features. And also we may need to do investigations to exclude, like I told you before, the infections and neoplasms in most of these patients. So what we are dealing here is with a patient with vasculitis, and very likely it's a small vessel vasculitis. When we name the vasculitic diseases, we now use the 2012 revised International Chapel Hill Conference nomenclature. Everybody, I'm sure, is very familiar with large vessel, medium vessel, and small vessel classification. In addition to these main classification diseases, they have also included the variable vessel vasculitis, single organ vasculitis, vasculitis associated with systemic disease, and vasculitis associated probable etiologies in this classification, or in naming. No, it's not really classification, it's the naming of these diseases. When it comes to the small vessel vasculitis, we have immune complex small vessel vasculitis, including anti-glomerular basement membrane disease, as well as the ANCA associated small vessel vasculitis, which we are interested in this patient. So the ANCA associated small vessel vasculitis include microscopic polyangiitis, granulomatosis with polyangiitis, and eosinophilic granulomatosis with polyangiitis. When we say ANCA associated vasculitis, that is because of the ANCA is found to be commonly positive in these patients, but looking at this picture, we'll find even with GPA and MPA, 5 to 10% can be negative. eGPA, especially 50% can be negative ANCA, but still we consider it as an ANCA-associated vasculitis in this nomenclature. There are two varieties of ANCA, the C ANCA, that is proteinase 3 ANCA, positive ANCA, and myeloproliferative positive ANCA, that is P ANCA. And GPA commonly has PR3 ANCA, while MPA has MPO ANCA. eGPA again, it's more commonly MPO or myeloproliferative positive ANCA. Remember, there are other diseases which can have ANCA positivity, like SLE. Now the newer thinking, or what people are trying to persuade others and to develop a newer nomenclature based on the features as well as how they respond to treatment. They think it will be better to call them PR3 positive ANCA-associated vasculitis, MPO positive ANCA-associated vasculitis, and then eGPA ANCA positive as eGPA and ANCA negative eGPA. This might be the future. This might be the future where different treatment plans will come up for this type of grouping. Although any tissue can be involved in ANCA-associated vasculitis, the upper and lower respiratory tract and kidneys are the most commonly and severely affected. In addition, that you will get changes in the nervous system, gastrointestinal system, and cardiac as well. This patient, you have noticed that with the high peripheral eosinophil count, with the vasculitis, we always take it as eosinophilic denominators with polyangiitis. There are different diagnostic and classification criteria developed. Starting about 40 years ago in 1984, the Langham diagnostic criteria, which include 3 features which should be there for a diagnosis, and our patient had all 3. And then later, the American College of Rheumatology made a classification criteria in 1990, where you had to have 4 out of 6, and our patient also fulfilled this. But the newer trend in making classification or diagnostic criteria is by giving weightage to each of the features, the positive and negative features to be used, a group of them to be used for the classification. This already we have approved rheumatoid arthritis as well as a SLE criteria, which has gone into this change. So similarly, the diagnostic and classification criteria for vasculitis group, which is a worldwide group which has recruited a large number of vasculitis patients and analyzing each of the different diseases, are coming up with this classification criteria. The draft for the eGPA at present include this, with the clinical and investigation criteria giving positive and negative weightage marks and needing more than 6 or more for the has to classify. If we put this into our patient also with the mononeuritis multiplex, eosinophil count, with a negative ANCA, and we can still make this diagnosis of eGPA in this our patient. eGPA classically has 3 phases of development. So it's developed very slowly over many decades in a patient. So they generally have this prodromal phase, may start in 2nd or 3rd decade of life, characterized by atopic disease, allergic rhinitis, and asthma, which our patient had for many years. Then there is what we call eosinophilic phase, where you get either blood eosinophilia and the infiltration of organs with eosinophils. We have detected blood eosinophilia in this patient recently, but that may have been there for last few months or so. though we did biopsies, we couldn't get any infiltration, evidence of infiltration with eosinophils, but that's not essential to have that. Then patients will get the vasculitic phase by developing either the life-threatening systemic vasculitis of medium and small vessels, generally coming in the 3rd or 4th decade of life. Each associated vascular and extravascular granulomatosis, and may be heralded by non-specific constitutional symptoms as in our patient. So different organs can get involved: pulmonary, neuro, GI, cardiac, and renal. When it comes to treatment, there are 2 modes of guidelines which are available. There's one which is specific for EGPA, as well as the EULA, ERA, and EDTA recommendation, that is European League Against Rheumatology, European Renal Association, and European Dialysis and Transplant Association, which recommend ANCA-associated vasculitis as one group treatment plan. The EGPA specific one used what we call 5-factor score, looking at the severity. So if any one of these are there, they take this patient having a severe disease, and people who don't have any of the features are gone as non-severe disease, a different pathway of treatment. So the age over 65, creatinine over 150 micromoles per liter, cardiomyopathy, GI involvement, and absence of ENT manifestations are taken, and non-severe, where you can give corticosteroids, and if with failure, that you will use immunosuppressants. In severe disease, you use corticosteroids with cyclophosphamide induction plus plasma exchange if there is a pneumorenal syndrome or rapidly progressing renal disease or lung hemorrhages. Then they can be maintained with azathioprine and methotrexate, and failures again will consider especially the new forms of treatment, the biologics, anti-IL-5 and anti-IgE, which is not available in this country, is developed and is available in European countries for use for this disease. But we have the B-cell therapy, rituximab, also will be alternate treatment for failures when they fail for the cyclophosphamide and corticosteroids. When it comes to ANCA-associated as a group, all 3 diseases which are called ANCA-associated vasculitis, we simplify by looking at again as not non-organ threatening disease, organ or life-threatening disease, or rapidly progressive renal or pulmonary renal failure or pulmonary hemorrhage. The non-organ threatening disease where the organs are involved but then they are not in a failure state, you can use methotrexate or mycophenolate with steroids. Whereas organ threatening, the organ going into a failure or life-threatening situation, we will use cyclophosphamide or rituximab with steroids, especially if there is severe life-threatening with the RPG and pulmonary hemorrhage, may need to consider plasma exchange in addition to the cyclophosphamide or rituximab with the high-dose steroids. Maintenance can again in this patient be managed with azathioprine or methotrexate. That's the overall management plan in our patient, because he doesn't have very severe life organ failure type of involvement. We have decided to treat with steroids plus MMF, and she has done a good response to that so far. So this brings us into the second case discussion in this roundtable case discussions in this program. Together with Priyamali Darshana, I would like to acknowledge and thank our patient for consenting to be discussed here. All the consultants who contributed to establishing the final diagnosis in this patient, and Dr. Thirini Pereira, my senior registrar. to collecting all the necessary details of the patients and the documentation for this presentation. Our special thanks goes to Sri Lanka Medical Association and Sri Lanka College of Internal Medicine for the opportunity given. Thank you to all who have joined this session from 3 of us, and we'll be happy to answer any questions provided the time permits that. Thank you very much.
Thank you very much, Duminda, for that excellent talk. And I must thank Dr. Primari Jayasekar and Dr. Darshana Sirisena as well. Any questions from the audience?
I suppose it was very clear. No,
Yes,
everything was
yes,
handled properly.
yeah. I think Darshana is there. May I just ask a question from you, Darshana? Is it okay? Darshana, what sort of?
Darshan is muted. You can hear.
Darshana, can you hear me? But just a quick question for you. What do you think would be the neurological improvement with immunosuppressive therapy in this patient? Probably.
This is not muted. These.
Darshana, can you hear us? Can you unmute yourself?
He is now unmuted. I don't know whether he can hear from.
Maybe he can't. Yeah, we skipped that. Yeah, it's all right. Yeah, I think probably he is not able to hear us. So to conclude the session, I think Dr. Primali is here, so I would like to hand over the certificate of participation to her.
Now moving on to the third session on bleeding and chest pain in a patient with a prosthetic valve. We have two speakers here, Dr. Kumuduni Jayasinghe, specialist in internal medicine, National Hospital, Kandy. I think she's joining online. And Dr. Chandika Ponnapperuma, consultant cardiologist, National Hospital, Sri Lanka. He's here.
Thank you very much. I would like to thank the SLMA, SLSIM, and their councils, presidents, and Dr. Madhuvanti Hettiarachi for giving me this opportunity. Let me share my screen. Can you all allow me to share my screen now? Still, I cannot share my screen. Right, okay. Myself and Dr. Chandrika Ponnapperuma, cardiologist, will discuss the case. A bleeding and chest pain in a patient with a mechanical heart valve. He's a 53-year-old male patient and admitted to National Hospital Kandy on 2nd February 2021 around 11 a.m. with a history of hematuria for 2 days and chest pain and shortness of breath for 1 day duration. So he gives a history of mitral valve replacement in 2011 and also for the tight mitral stenosis. Also had permanent atrial fibrillation, ischemic stroke in 2009, and warfarin-induced upper GI bleeding and anterior non-STEMI in 2019, and heart failure with preserved ejection fraction as well. His hematuria was painless. There were 2 episodes over these 2 days There were no other urinary symptoms. On admission, the hematuria was settled and the urine was no other bleeding manifestations. Not taken the previous day offering dose. He had been having symptoms of NYHA grade 3 to 4 heart failure symptoms for the last 1 month. On top of that, he has developed ischemic type of chest pain and shortness of breath for 1 day duration. He has not checked his INR for the last 3 months. As he from the hospital. Before that, INR has been the normal therapeutic range. According to the clinic notes, his hemoglobin was 10 to 10.5 gram per deciliter, and he was on hematonics, as the blood picture shows mixed deficiency anemia. He has defaulted investigations to exclude inducible ischemia following his MI in 2019. He was on warfarin 6 mg, enteric-coated aspirin 75 mg, bisoprolol 5 mg, atorvastatin 40 mg, omeprazole, and hematonics. The drug compliance was satisfactory. He used to take green leaves according to the instructions given. He has not been on any other medications. On examination, there was mild pallor with a bilateral mild leg edema. The pulse rate was 86 and he was in atrial fibrillation. The blood pressure was normal. Metallic heart sounds were well heard and there were no regurgitant murmurs. Respiratory rate was 26 per minute. The saturation was 94%. There were crepitations in both lung fields, mid and lower zones. The bedside urine sample was clear. The ECG showed atrial fibrillation with the T inversions V1 to V6. The blood was taken for urgent INR, full blood count, UFR, and the troponin, and also the basic investigations. The troponin was positive with a 1.988 nanogram per deciliter. The history, ischemic type chest pain, ECG changes, and the positive troponin, we made the diagnosis of anterior non-STEMI with acute and chronic heart failure. So discussed with the cardiologist team as well. The clopidogrel 300 mg loading dose was given, followed by 75 mg. Considering his the thrombotic risk and also unavailability of the INR at that moment, we gave the enoxaparin 40 mg stat dose as well. Continued aspirin 75 mg without giving a loading dose. Furosemide IV infusion was started. The bisoprolol was withheld as he was in acute heart failure. Oral digoxin was started to control the heart rate. We got down his investigation. The hemoglobin was low, 9.5 gram per deciliter. The INR was high, 5.67, and the UFR shows RBC 100 to 150. Other basic investigations were normal. 2D echo showed ejection fraction 35 to 40% with the anterior wall hypokinesia, and the mitral valve processes was well functioning, and there were no paravalvular regurgitation or leaks, no thromboevagitations. Warfarin withheld with the high INR. However, on day 2, he restarted bleeding again with the fresh blood in urine. The clopidogrel and low molecular weight heparin 2 withheld. Aspirin 75 mg was continued. INR was still high, 5.21. The hemoglobin was little lower than the previous, 8 gram per deciliter. So because of that, we have transfused him with a Paxil RBC, slowly under furosemide cover. The aspirin, statin, and digoxin, omeprazole, and furosemide were continued. Bladder irrigation was done with the advice by the GU surgeon. Plan was to arrange cystoscopy once the patient was stable. The cardiology opinion was taken at this moment and started conventional heparin, and the aspirin, furosemide, and digoxin continued. Sorry, I think I have missed one. So day 4, patient developed an ischemic chest pain again with features of heart failure. ECG showed tachycardia with atrial fibrillation and T inversion in V1 to V6. Troponin high sensitivity was elevated, 500 nanogram per liter. INR was high, 4.25. Hemoglobin was still low, 9 gram per deciliter. No active bleeding. So at this moment that we started conventional heparin with the discussion of the cardiologist. Aspirin, furosemide and digoxin were continued. Few hours later, heart failure worsened. Monitor showed non-sustained VT and which confirmed by the ECG. Treated with an amiodarone bolus followed by an infusion. 1 hour later, he went into the cardiogenic shock and restarted inotropes and raised pressures. He developed a cardiac arrest with a pulseless VT around 6 p.m. the same day. Resuscitated and maximum supportive care continued with monitoring. However, the next morning, around 5 a.m., he developed another cardiac arrest and we could not resuscitate him. So this is a patient with very high thrombotic risk in the presence of mechanical heart valves, atrial fibrillation, heart failure, the previous history of cardiovascular diseases, MI and the strokes, who was on warfarin, presented with a bleeding and thrombosis. He also had underlying chronic anemia, probably due to upper GI bleeding and also the poor compliance. So he had two main management problems. The management of bleeding in a patient with high thrombotic risk and management of acute coronary syndrome in the presence of bleeding. I will discuss the first part and Dr. Chandrika will discuss the second part. So management of bleeding in a patient with high thrombotic risk according to the guidelines. These are my references for this presentation. And this is very important picture actually, because this shows how the bleeding will cause the thrombosis. With the major bleeding, there will be anticoagulant and antiplatelet discontinuation, which will lead to prothrombotic state leading to thrombosis. Again, they will go into shock and also the severe anemia. With the anemia, they used to transfuse. That will lead to inflammation and oxidative stress, causing plaque rupture and causing again thrombosis. And the shock will lead to myocardial ischemia. Again, will lead to the thrombosis, so it can cause the inflammation and oxidative stress again the same pathway. So same thing has happened to our patient as well. When you get a patient with thrombosis and bleeding, you must assess the thrombotic risk versus the bleeding risk, as previously mentioned by the two other speakers. So let's see what is the thrombotic risk in our patients. In the presence of mechanical mitral valve, he carries a very high risk. On top of that, he has atrial fibrillation with a Chadwick score 4 carries a high risk. So obviously, he carries a very high risk of thrombosis. So his bleeding risk has split these three because he has three risk factors: stroke, the bleeding history, and also the labile INR. So he is carrying a moderate to high risk of bleeding as well. So let's see what is the target INR in this our patient. In the presence of mechanical mitral valve, it has to be 3. But if they are having the risk factors like atrial fibrillation, heart failure with ejection fraction less than 35%, previous thromboembolism, LA spontaneous echo contrast, mitral stenosis, and LA size more than 50, it has to be 3.5. So in our patient, again, it has to be 3.5. So median INR value is recommended rather than a range, because in the extreme values in the range, either it's not safe or effective. Let's see how do we manage a patient with a high INR. If there's no bleeding, no mild bleeding, in the presence of INR 4 to 6, either you can reduce the warfarin dose or stop it for 1 to 2 days. And we can restart the warfarin with a lower dose. First should be investigated. If the INR is 6 to 8, if the other risk factors for bleeding is there, you may give 1 milligram oral vitamin K. If the INR is more than 8, give 1 to 2 milligram of oral vitamin K. Again, when the INR is more than 10, remember all these are for the no bleeding or minimal bleeding. You have to give oral vitamin K 5 milligram. The cause need to be identified on all these situations. Let's see what's the place of vitamin K for high INR in the presence of mechanical mitral valve. ACC/AHA does not recommend vitamin K in patients with mechanical heart valves, as vitamin K will induce hypercoagulable state, causing thrombosis and thromboembolism. High dose of vitamin K Also will increase the risk of warfarin resistance, and higher doses are needed to reach the high target. The guidelines recommend prothrombotic complex concentrate or PCC to manage bleeding on mechanical heart valve patients compared to high dose of vitamin K. However, low dose of vitamin K can still be considered with the PCC combination. Immediately reverse anticoagulation effect can only be done if there is major bleeding. So what are the causes of major bleeding? The intracranial, retroperitoneal, intraocular, pericardial muscle bleed with compartment syndrome, or if there's any kind of active bleeding with hypotension or 2 gram per deciliter fall of hemoglobin, or leading to transfusion or 2 or more blood transfusions. Again, it causes the major bleeding. In that situation, you have to stop warfarin, give vitamin K 10 milligram intravenously this time, give PCC. If PCC is not available, you have to give FFP and identify the cause. So in our patient, have we managed our patients according to the guidelines? Whether we would have given a small dose of vitamin K and PCC with his second bleed when the INR was still more than 5, and continue dual antiplatelets and conventional or heparin or arrange PCI. Let's see what the cardiologists want to say. Over to you, Chandika.
Thank you, Kimudini. I wish to thank the President, Councils and the academic committees of the Sri Lanka College of Internal Medicine and SLMA for giving me this opportunity. And in this sort of forum, it is usual to select a success story for presentation, though failures have more academic value. Dr. Kumudini Jaisinghe's courage and selfless attitude towards academic advancement demonstrated by selecting this case of a presentation demand a round of applause. Thank you very much, Kumudini, for that. So basically the topic is, which I have to discuss, is acute coronary syndrome and non-ST elevation MI in a bleeding patient with a mitral valve prosthesis and on warfarin. So bleeding and thrombosis are two inherently conflicting problems. Actually, two problems which both can be life-threatening. And it's conflicting because treating one will aggravate the other. So when you are managing a patient with acute coronary syndrome, a bleeding patient, there are a few principles which I would stick to. First would be treat the more life-threatening entity more aggressively than the other. The second would be to avoid over-treating either, because both can be life-threatening. You have to use your judgment to decide to which extent to treat each of them. When you are managing the bleed, it's better to take local measures to stop the bleed early than aggressively correcting the coagulation defect whenever possible. For example, if it's a gastric bleed, try to get an endoscopy done and treat the ulcer locally. In this case, it was a urinary tract bleed, so you have to try to address that early. Then when correcting the hemostatic defect, what you should do is a calculated correction of the specific clotting factor defect. In this case, it was due to warfarin, high INR. The best way to correct it is using prothrombin complex concentrate and a calculated amount to achieve a target INR rather than to overcorrect it. Then when managing the acute coronary syndrome, one should stick to guideline-based minimum antithrombotic regime in managing it. And there's a definite place for early coronary angiography and PCI of the culprit vessel with the use of, again, minimum essential antithrombotic treatment whenever possible. So these are the 6 guidelines, principles which I would stick to when managing a patient like this. Anyway, as cardiologists, we love guidelines. So we'll see later on what the guidelines would say about this. So from here on, I will be discussing with a patient whose acute coronary syndrome poses a greater risk to life than the bleed, as in this patient. So what will we give in the initial medical management? Aspirin. It's usual for us to give 300 milligrams of loading, followed by 75 to 100 milligrams daily in patients with acute coronary syndromes. However, if the INR is known to be more than 3, you should avoid giving the loading dose of 300, and you should give the maintenance dose of 75 to 100 only. In all other patients, including those on NOACs and those on warfarin with INR less than 3, the loading dose is indicated. Then the second antiplatelet agent we use is a P2Y12 inhibitor, and clopidogrel is the preferred agent in the presence of high bleeding risk. You should not use agents like prasugrel and ticagrelor. And now, anyway, even without high bleeding risk, patients who are having non-ST elevation myocardial infarctions, who have life-threatening features, who need to be taken to the cath lab early, what is recommended is not to load with clopidogrel. This doesn't, with P2Y12 inhibitors. This does not apply for patients who are being managed medically, who will not be taken to cath lab early, but people who are taken to cath lab early, it is suggested to avoid loading, because most of the time these severe non-ST elevation myocardial infarctions end up having non-stentable lesions, which need surgical revascularization, and loading with clopidogrel or P2Y12 inhibitors will delay the bypass surgery due to high bleeding risk. In this patient where the bleeding risk is also high, that it is more true than in others that you should avoid loading with clopidogrel. Then the anticoagulation. Sorry, when you are using anticoagulation, the question is, should all these patients be giving anticoagulants like heparin or enoxaparin? Answer is no. Patients who are on warfarin for prosthetic valves, for DVT and pulmonary embolism should be continued on warfarin alone without switch to parenteral anticoagulation with heparin or enoxaparin, provided that they are within the therapeutic INR. But patients who are on warfarin or NOACs for atrial fibrillation should be started on parenteral anticoagulation, either when the next NOAC dose is due, or for patients who are on warfarin when the INR is less than 2. Otherwise, you should not give anticoagulants. So out of the anticoagulants, unfractionated heparin is considered better in the setting of a recent bleed due to easy reversibility than low molecular weight heparins like enoxaparin. Then the other management like statins, beta blockers, nitrates, and heart failure medications will be as per usual guidelines. And all patients who are on oral anticoagulants, who are giving antiplatelets, a proton pump inhibitor is indicated unless there is any contraindication to it to prevent GI bleeding. Then the critical question coming to any treating physician of such a patient is there a place for a coronary intervention in this patient? My answer for that is this: the first principle, treat the more life-threatening entity more aggressively than the other. So if the acute coronary syndrome is the more life-threatening entity, there's a definite place for a intervention. let's see what the guidelines say. This is ESC guidelines for management of non-ST elevation myocardial infarctions 2020. It clearly says that an early invasive coronary angiogram should be considered in high bleeding risk patients, irrespective of oral anticoagulant exposure, to expedite treatment allocation, medical versus PCI versus CABG, and to determine the optimal antithrombotic regime. Class 2A recommendation with a level of evidence of C. So it's recommended in guidelines. This chart demonstrates even without high bleeding risk in usual patients with non-ST elevation MIs, how you triage to take to cath lab. The very high risk patients, on the left hand corner, you see the dark red box, the very high risk patients who have hemodynamic instability, who are in cardiogenic shock, recurrent and refractory chest pain in spite of medical management, life-threatening arrhythmias, mechanical complications of MI, acute heart failure clearly related to the non-ST elevation MI, and patients who are having ST segment depression of more than 1 millimeter in more than 6 leads, plus ST segment elevation in AVR and V1. These patients are at very high risk, and anyway angiogram is indicated within the first 2 hours. For the patients who are at high risk, that is established non-STEMI diagnosis, dynamic new or presumably new contiguous STT changes, resuscitated cardiac arrest without ST segment elevation, or grace risk of more than 140. These are at high risk in these patients. Non-STEMI, the coronary angiogram and intervention is indicated within first 24 hours. And the others are fall into the low risk category. They can be selectively taken for coronary angiogram after stress test later. So independent of bleeding, this our patient, there was a definite indication for a invasive angiogram early, and the presence of bleeding further reinforces that indication, because we have to come to a anatomical diagnosis early to decide on revascularization as well as to optimum antithrombotic regime. So when doing the coronary angiogram in the cath lab, radial artery approach should be the default vascular access, because femoral artery approach is associated with more bleeding complications. And if the INR is more than 2.5, no periprocedural anticoagulants are required. Should not give heparin or enoxaparin during the procedure of the PCI. And glycoprotein 2B3A inhibitors are for only bailout from periprocedural complications, should not be used routinely. And if the INR is less than 2.5 on warfarin, or patients who are on NOACs need low dose anticoagulation. So once coronary angiogram is done, prognosis and further management will depend on the coronary anatomy. If culprit lesion is favorable for PCI, you load with aspirin and clopidogrel if not already done. Choose the minimally complex technique to do the PCI. So you have to finish the procedure quickly without using with the least amount of anticoagulants. Use the minimum required number of stents and the shortest possible length of stents to use. If you can do without stents, if you can just balloon and come out with a reasonable result, that is the best. And you treat only the culprit lesion. You don't look for, try to for complete revascularization in these patients in this stage. And use third generation drug-eluting stents, which has safety data for early termination of dual antiplatelet therapy. There are non-polymer drug-eluting stents and certain drug-eluting stents which have evidence for early termination of DAPT. Those stents are preferred. However, if the culprit lesion is not favorable for PCI, which is frequently encountered in this kind of patients who go into cardiogenic shock with non-STEMIs, then you have to have a multidisciplinary meeting with the cardiac surgical team and decide. And they will obviously have a poor prognosis in this setting. Once the PCI is done, you have to select the appropriate antiplatelet regime for these patients. So having a very high bleeding risk, the appropriate regime would be dual antiplatelet therapy, aspirin and clopidogrel for 1 month and clopidogrel thereafter. If the bleeding risk is very high, you can stop the second antiplatelet agent, aspirin, in 1 week and clopidogrel thereafter. In this patient, due to the mitral valve mechanical processes, warfarin is also needed to be continued with an INR of about 3. In summary, we come back to the principles which I told earlier. Treat the more life-threatening entity more aggressively than the other. Avoid over-treating either. Take local measures to stop the bleed early than aggressively correcting the coagulation defect whenever possible. Calculated correction of the specific clotting factor defect should be done, avoiding overcorrection. Guideline-based minimum antithrombotic regime should be used to manage the acute coronary syndrome. And early coronary angiography and PCI of the culprit vessel with the use of minimum essential antithrombotic treatment should be done whenever possible. Thank you.
Yeah, thank you very much, Chandika, for that excellent talk. I think both of you, I'm sure will consent to answer questions if there are any.
Yes. I couldn't get it. You can give IV pantoprazole. Earlier there was a query with the clopidogrel would. I think you are. Yeah. That is not proven anymore, but anyway, pantoprazole is preferred.
There is a question. How do we come here? Sajid. There is a question. Oh, right.
Yeah, there's a question from one in our virtual audience. Yes, two questions actually. One is on when there is ACS and concurrent upper GI bleeding, and bleeding has to be controlled by upper GI endoscopy, it is usually refused due to acute coronary syndrome. How could we negotiate this? I think
again, yeah, you have to select which one is more life-threatening. That is your clinical judgment actually. That's where the clinical judgment comes to play. If the bleeding is the more life-threatening problem, you have to upper GI endoscopy should get precedence than angiogram. And usually upper GI acute coronary syndrome is usually not a contraindication for upper GI endoscopy. I mean, not in a patient in cardiogenic shock, obviously, but otherwise.
There's another question. When a patient is on a beta blocker, if he develops heart failure, can we continue it? I think probably referring to this patient who
Yes.
had AFN heart failure.
Yes. Yeah, depends on the degree of heart failure. In severe heart failure, one will not, you will withdraw, but otherwise will continue.
Then there's another question. Can you re-explain the place of the stat, that is the stat dose of clopidogrel or non-STEMI in the presence of bleeding? I think they're not clear about what to do with the stat dose of clopidogrel when there's bleeding.
Yeah. Anyway, without bleeding in non-ST elevations, having severe, the very high risk group, which I am telling, I can't go back to my slides here. So if the patient has very high risk features with a non-STEMI, like heart failure, recurrent arrhythmias, we recommend not to load with clopidogrel, because patient should be ideally take, if the patient has the possibilities there of taking the patient to the cath lab, not in a medical setting, right? If that possibility is there, better to avoid loading a P2Y12 inhibitor like clopidogrel, because most of the time after doing angiogram, these patients need bypass surgery. So if you have the facility to take the patient to the cath lab early and the facility to do an emergency bypass if required, then it is better not to load with clopidogrel. In patients with bleeding, also it is not recommended to load with clopidogrel. In patients with bleeding, they also need early angiogram to define coronary anatomy, and particularly when the acute coronary syndrome is more life-threatening one, needs early angiogram. If the bleeding is the life-threatening one, anyway, you should not give even aspirin, right? If the bleed is the more life-threatening one, you should not give any antiplatelet or any anticoagulant, right? But if the acute coronary syndrome is the more life-threatening one, you manage it without clopidogrel. You can give aspirin, as I mentioned earlier. Depending on the INR, you should decide whether to load or not. And you can give anticoagulants, again, depending on the indication for anticoagulation and the threshold of the INR. Is that clear?
Yes, I think that was asked. There's another patient has a prosthetic valve with INR within the range. What should be done?
Well, you have to get a neurosurgical opinion. I think that is the first thing to do, because it's a severe life-threatening hemorrhage you are dealing with. You have to treat the problem at hand. So still the valve has not thrombosed. So I think you should not give anticoagulants without a neurosurgical opinion for that.
There's another question, one final one. In a bleeding, in an MI, when there's bleeding, is there still a place for an angiogram?
That's what I said.
Yeah,
yes.
yes.
If the acute coronary syndrome or the MI is the life-threatening one out of the two, there's a definite place for an early angiogram.
Yeah, okay. Thank you very much. Thank you very much, Kudi, for selecting that very interesting case and presenting it. And thank you very much, Chandika, for explaining the cardiologist's position and answering all those questions. May I take this opportunity to hand over a certificate of appreciation.
The certificates of the speakers who are not here will be sent to them in due course.
The next item is the next on this series of roundtable discussions is a case of well, it's actually a series of cases, day-to-day clinical dilemmas through case-based scenarios. And the participants are Dr. Tushara Matthias, who is specialist in internal medicine, Faculty of Medicine, University of Sri Jayawardenepura, Dr. Chamara Ratnayaka, consultant cardiologist, RCD Group of Hospitals, and Professor Shehan Williams, professor in psychiatry, University of Calgary. Yeah, may I invite Tushara to
Okay, so the next presentation we have is about clinical dilemmas that we have in our medical wards. And over the next half an hour, I'll take you to 3 presentations of the same patient where we actually have therapeutic clinical dilemmas. So this is a case scenario. We have a 55-year-old patient with diabetes, hypertension, chronic kidney disease, and multiple myeloma presenting to the casualty medical unit with chest pain and shortness of breath for 1 hour. Her medication at present includes metformin 500 twice daily, sitagliptin 100 daily, losartan 50 BD, and atorvastatin 14 octet. Her blood pressure was 94/70, and her heart rate was 84, and her respiratory rate was 60. And the initial ECG taken shows there is ST elevation in the anteroseptal leads. The point of care troponin done reveals 10 nanograms per milliliter. As this patient has multiple myeloma, she has visited a hematology clinic last week, and the investigations done at the clinic a week ago is present with the patient. So you see the investigations, the total white cell count is 8,000, the hemoglobin is 9, the platelet is 38,000, and the creatinine is 1. So in this clinical scenario, we have 2 problems. One is the patient has acute coronary syndrome because the patient has presented with a typical chest pain, and there is an ECG showing an ST elevation, and the cardiac biomarker, which is troponin, is positive. So we have a definite diagnosis of acute coronary syndrome. But we also have another problem at our hand, and that is thrombocytopenia. Because the patient has multiple myeloma, the patient has a platelet count of 38,000. So in this scenario, we have to treat the acute coronary syndrome. And as we all know, the cornerstone of management of acute coronary syndrome involves antiplatelets, heparin, thrombolytics, PCI, and all of which cause problems in a patient with thrombocytopenia. So there is our clinical dilemma. So to help us solve this dilemma, I have with me Chamara. So Chamara, I would like to ask you as a first question, in this kind of scenario, can we give antiplatelets? And if we do decide to give antiplatelets, which antiplatelet is the best drug? And what is the lowest platelet count you would consider giving antiplatelets for?
Thank you, Tushara, for the questions, and thank you for inviting me as well for this forum. So yes, it's an interesting case, and it's something that we do encounter quite often in clinical practice. So it's good to know, and it's probably good to know what to do and what not to do, I guess, in another sense as well. So the patient whom we are dealing with obviously has multiple comorbidities, including multiple myeloma. So before doing anything, probably it's good to know 2 things. So we are dealing with an ST elevation myocardial infarction. It's a life-threatening medical complication, obviously. And as we learned throughout our medical career, ST elevation MIs, the saying goes is that time is muscle. So what we do, we must do it fast, and we have to do it as soon as possible, whatever treatment modality that we are going to do, and that decision has to be made as soon as possible. The number 2 thing, especially with any patient who has cancer or any form of cancer, is that we need to have an idea about the prognosis, because whatever we do, whatever active treatment that we do, we need to do it so that the patient's best interest is also at heart. So if the patient's prognosis as far as the cancer is concerned is not that great, so I would look at the life expectancy of this patient as well to see if they have a reasonable life expectancy, and then I will decide on what treatments I will go for in this patient. So assuming that this patient has a reasonable life expectancy with the multiple myeloma, I would probably go for active treatment. And to answer the question, so as far as antiplatelets, so we are dealing with a patient who has a baseline level of 38,000 platelets, and we have that luxury. Sometimes, though, to be honest with you, we don't have that luxury. Whenever a patient comes with a STEMI to the emergency department, we don't know what the platelet levels are. So again, our treatment will depend, and it will be for the treatment of that life-threatening problem. As Dr. Chandrika mentioned in his talk previously, we have to always deal with the immediate life-threatening issue. So as far as antiplatelet, to answer the question again, so as far as the first antiplatelet that we give, and that's a proven one throughout the last few years, the last few decades, aspirin definitely has to be given. And if the platelet count is more than 10,000, there is reasonable evidence that we can give aspirin as a loading dose or maintenance dose as well if the platelet count is more than 10,000. So in this patient, aspirin definitely will be indicated. The question is about then what do we give next? So obviously in a patient who is having a STEMI, an ST elevation myocardial infarction, we need to give another antiplatelet as well. So the second antiplatelet, a P2Y12 inhibitor. So again, the options wise, we have clopidogrel and the newer antiplatelet agents such as ticagrelor and prasugrel. So the important thing here again is that as far as the second antiplatelet is concerned, we have to go by the platelet count again. If the platelet count is more than 30,000 or between 30 and 50,000, that's kind of our cutoff. If it's more than 50,000, there is no question we can give. But again, if it's between 30 and 50,000, clopidogrel is the choice. There is no evidence to support the newer antiplatelets in patients who have platelet counts less than 50,000. So prasugrel, ticagrelor, and the 2B3A inhibitors, unfortunately, there is no evidence to support their use. So we can give clopidogrel in these patients. If the platelet count is less than 30, so this is a hypothetical situation. So in our patient who's 38,000, I think we could give it. If the platelet counts are less than 30,000, it will require some sort of an MDT again. We need to have a chat with the patient's family, an oncology and hematology team as to, again, prognosis and have a risk-benefit analysis. And if the benefit of giving the antiplatelets, dual antiplatelets, will outweigh the risks as far as bleeding is concerned, and if the patient has a reasonable prognosis, then clopidogrel can be given again. However, in this patient, aspirin and clopidogrel combination will be a good option.
Thank you, Shamara. So moving along, we have two options after we give the initial antiplatelets. So we can either thrombolize the patient if we are in a non-PCI capable hospital. But if we are in a PCI capable hospital, we can go ahead with PCI. Most of us work in non-PCI capable hospitals, Shamara. So I would like to ask you, with this platelet count of 38,000, can we give tenecteplase?
Yes, another very good question. So again, speaking of non-PCI centers, so the real guidelines actually, so even if you are in a non-PCI center, always remember, if you have a possibility of transferring this patient to a PCI center within 120 minutes, that's 2 hours, that should always be considered as number one, because as we all know, in a patient with a STEMI, primary PCI is the best mode of treatment, and the outcomes are best if you are able to offer the patient primary PCI. So even if you are in a non-PCI center, always contact the closest PCI center, find out if they have the ability to take the patient over, and if you are able to transfer the patient within 2 hours to the PCI center, that should be your number one option. However, unfortunately, due to logistical problems, it's not always possible. So we need to consider thrombolysis in this patient, again, as something as a life-saving option. So in this patient of ours, we knew a baseline platelet count. But again, most of the time, I feel that when a patient comes with all these comorbidities to our emergency department, we don't know what their platelets are actually, because majority of the patients just come even if a full blood count was done a month ago, 2 months ago, 6 months ago. So sometimes ignorance is bliss. We don't know what the platelet is. We just treat the patient as they are, face value, and we do the best that we can to save that patient's life. So that should be our number one priority. Again, there are no hard and fast rules as far as whether we can give thrombolysis or not. But if you look at the drug labels, etc., as far as thrombolysis is concerned, tenecteplase, which is the drug that is used commonly these days, but it says as a relative count, if the platelet count is less than 100,000, it's considered a relative contraindication. So that's essentially putting the ball in your court. You make a decision, you make a call, a clinical judgment, whether you could give thrombolysis in this patient or not. So again, there have been case reports where they have given thrombolytics and tenecteplase in patients who have platelets less than 100,000, and the outcomes have been good. So my suggestion again is we need to have a talk, consider many things, including the patient's prognosis again. If the patient has a reasonable prognosis and we are doing this to save the patient's life, I think giving tenecteplase in this patient who is having a platelet count of less than 38,000 is a reasonable option, as long as there is no major bleeding, for example, and the patient has a good prognosis. Giving tenecteplase in this patient would be a good option if PCI is not an option.
Okay, so moving along, as I mentioned, the other option that we have is PCI. So with this kind of low platelets, Shamara, can we go ahead with PCI? And if we do decide to go ahead with PCI, are there any measures that you all take as cardiologists to minimize the bleeding risk?
Yes, and I think in this kind of a patient who's having bleeding problems, PCI probably is one of the better options, because again, thrombolysis would cause trouble as far as bleeding is concerned. So whenever the option is available, I think it is definitely something to consider. So given PCI, so let's just go through the steps again. If we are to take this patient into the cath lab, a patient with thrombocytopenia, the good news is that doing a diagnostic coronary angiogram in this patient is no problem. There is no lower limit as far as platelets are concerned to do a diagnostic coronary angiogram. So we can take into the cath lab, see what the coronary anatomy is, and it's a PCI. I'm sorry, it's a STEMI. So we would expect a completely occluded coronary artery in this patient. And as far as access is concerned, as was spoken about in this previous patient as well, who had bleeding problem and warfarin, etc. In any patient where there is some sort of a bleeding complication, radial access is preferred over the femoral approach. Again, proven to be less problematic as far as bleeding is concerned. So as far as access is concerned, we go radially. Then problem comes as to if we are to intervene in this patient as far as angioplasty is concerned, which is probably the best option. How do we go about it, and which antiplatelets do we give in this patient in that case? So obviously, if we are going for an intervention in a STEMI patient, we need to give the patient dual antiplatelets. If the platelet count is less than 50,000, usually giving these antiplatelets is going to be the problem about duration more than which antiplatelet that we give. So clopidogrel will be the antiplatelet that we give, but the problem is how long can we give it for, and should we give it for? So as far as the procedure is concerned, we probably should just do the minimum possible procedure, culprit lesion, and leave it with the shortest possible stent, etc. But the choice of stent matters, and whether we put a stent at all. Sometimes, as Dr. Chandrika mentioned in the previous patient as well, angioplasty alone without a stent, if you get a reasonable result, may not be a bad option in this patient as well. If you can get a good result, we don't have to put a stent. But unfortunately, in STEMI patients where they do have a high thrombotic burden, angioplasty alone without a stent may not be always a possible scenario. So in that case, we need to place a stent. So options wise, we have the old bare metal stents, in which case 4 weeks of dual antiplatelets is recommended. The second generation drug-eluting stents usually require a bit longer duration, 6 months is what they say. However, more recently, we do have the so-called polymer-free drug-eluting stents, where the duration of these dual antiplatelets are more minimal, and we can withhold the dual antiplatelets at 1 month. So that would be my recommendation in this patient. If we are to put a drug-eluting stent, a polymer-free third generation drug-eluting stent will probably be the best option.
Shamara, just a quick question. Are these polymer-free stents expensive than the normal drug-eluting ones?
Well, first of all, if we were talking about government service, we know that we do have stents available in the government service. And I believe there are limited stocks of these polymer-free drug-eluting stents as well. For example, I know that it was available at General Hospital. If you're talking private sector, to be honest, no, there is no major price difference. It's actually the same price. So it's widely available, and the price is not any different.
So if we do go ahead with PCI, can you give heparin during PCI for this kind of patients? And do you at any point consider platelet transfusions for such patients with thrombocytopenia?
Yes. So To be honest, yeah, that's a good question again. So heparin is something that we do give during the procedure. Peri-procedural heparin is something quite important, essentially to prevent stent thrombosis. So the usual heparin dose that we give is 100 units per kilogram body weight. But in a patient who is having thrombocytopenia, obviously we'll be a little bit more cautious about giving heparin. So we reduce the dose. So the recommendation again is to give 30 to 50 units per kilogram rather than the full dose of 100. And more importantly, we need to keep in mind thrombocytopenia and the consequence of giving heparin, which is heparin-induced thrombocytopenia. So I would monitor this patient's platelets very closely, especially after about 5 days, 5 to 10 days after giving heparin, to make sure that the platelet count does not drop any further. So that's very important. And as far as platelet transfusions are concerned, again, there is no guidelines, there is no hard and fast rule, but in general, what they're saying is that there is no real indication to give platelets in these patients, because although they are thrombocytopenic, their functionality, the limited platelets that they have, functionality wise, they remain the same. So there is no real indication to give platelets unless there are significant indications, such as a patient with low platelets, 20,000 or less, with high fever, leukocytosis, a rapid fall in the platelet count, or if there's any other coagulation abnormality. Apart from those, there is no real reason to give platelets in this patient.
Thank you, Shamral. So moving along with this same patient, after successfully managing the acute coronary syndrome, the consultant has ordered atorvastatin 80 milligrams daily among the other drugs. And the house officer is concerned about continuing statins for this patient because of the following investigations. The AST is 120, the ALT is 110, both of which are elevated, and the total bilirubin and the alkaline phosphatase are almost normal, and the ultrasound scan has revealed that the patient has a grade 2 fatty liver. So we have a problem here. The baseline liver function tests are elevated, and the patient has been prescribed atorvastatin. So in this kind of situation, can we give statins if the AST and ALT are increased? Well, the short answer is yes. There are many schools of thoughts as to how far you can initiate statins for this kind of patients. The liver function test elevation, some people think it's 3 times upper limit, sometimes they say it's 5 times upper limit. But the recent most NICE guideline, which was published in 2020, it says that up to the transaminases up to 3 times upper limit, it's not a problem to initiate statins, and we should not deprive these patients of statins. It is more important to monitor the trend of liver function tests after we start statins. And what the same guideline recommends is that we start the statin at this baseline, which is less than 3 times upper limit in this patient. And then we repeat the liver function test. And if it does not double, we can continue using statins. Why are we so concerned about statins in patients with non-alcoholic fatty liver disease? Well, non-alcoholic fatty liver disease is increasing worldwide, and it also carries with it a very high cardiovascular disease mortality. And statins, as we all know, has pleiotropic effects. They not only have lipid-lowering effects, but they also are anti-inflammatory, they're anti-apoptotic, anti-thrombotic, and they are known to be antioxidants. So it is very important not to deprive patients who actually benefit from statin therapy just because of baseline liver function test abnormalities. Then we come to the question, which has been studied in some researchers: do we actually initiate statins just to improve non-alcoholic fatty liver disease? Well, the data is limited, but with a few selected studies, what they have found is that the transaminases may improve with the treatment of statins, and also the ultrasound findings might improve. But the cardiovascular morbidity and the histology might not improve. And this was further reiterated by a Cochrane systematic review done in 2013. It's a bit old, but that's the latest available, where they studied 2 studies which had very small sample sizes. And there was a lot of risk of bias. So what they said was the transaminases can improve, the imaging findings can improve, but the histology hasn't improved. So there is no clear answer for this question whether statins can improve NAFLD. So we have to wait for more data to come to this conclusion. So statins have always been associated with drug-induced liver injury, and a lot of people associate statin with liver injury. Usually statins increase the liver function test, but if there are larger increases in liver function tests or the transaminases up to about 10 times the upper limit, it is usually said not to be due to statins, and we are to investigate for any undiagnosed liver diseases. Because as we know, statins are metabolized by the cytochrome system, so there's always a lot of potential for drug interactions. Talking a little bit about statin-induced liver injury, the duration of onset is variable, but is usually very common in the first year of treatment. And the common liver injury that we talk about when we start statins is transaminitis. That is, there is no proven hepatotoxicity, it's just the AST and ALT which go up. And this is usually a class effect, and the patient is asymptomatic, it's dose-related, and is usually reversible either when the statins are stopped or when the dose is reduced. Whereas actual true liver injury because of statins is very rare in clinical practice. And this liver injury can be in many forms. It can be cholestatic, it can be hepatocellular, and sometimes it can even be autoimmune. So what we are generally concerned about is the transaminitis because that's the one that is common. As we said, that the NICE recommends that if the baseline liver function test doubles within 3 months, that we stop statins. There is a thought process that there is no point in routinely monitoring liver functions in patients who are on statins. Because what they say is the patients who might develop idiosyncratic reactions to statins, we will not be able to identify by routinely repeating the liver function tests. Then again, the guidelines always recommend that when we start the statins, it's always good to do a liver function test, because then we know that the baseline liver function test was a certain number. And always it helps us to identify whether the patient has pre-existing abnormalities. And the guidelines also recommend that we repeat the AST and ALT 3 months after treatment and again at 1 year. And again, if the patient's clinical picture changes, say suppose we increase the dose of statin or we change the statin, we can repeat the liver function test. Having said that statins can be used in the non-alcoholic fatty liver disease, there are 2 indications with regard to liver disease where we don't use statins. That is in acute liver failure and in decompensated cirrhosis. So moving on to the next scenario of the same patient around the follow-up, I would like to invite Prof. Shehan Williams. So the same patient, she was discharged and she comes to the clinic in 3 months and she complains of poor sleep. She had trouble falling asleep almost every night and she woke up at 3 a.m. several mornings a week. She normally wakes up at 6 a.m. She had low energy and lack of concentration to continue her work as a shop assistant, attributed her symptoms to all the side effects of all the strong drugs she was taking. She was on metformin 500 BD, sitagliptin 100 milligrams daily, ramipil 5 milligrams daily, and atorvastatin 40 milligrams nocte, aspirin 75 milligrams nocte, and carvedilol 6.25 BD. And she has been on this regime for the last 3 months. The investigations done in her previous clinic visits are hemoglobin of 10 with a MCV of 85, a TSH of 3, which is normal, and a serum creatinine of 2. So I would like to ask Prof. Shehan Williams, can we attribute this patient's symptoms to depression, or are these somatic symptoms due to her multimorbidity? And if this is depression, does she need drugs? And if she needs drugs, what is the best treatment for this patient, as she has a lot of diseases and she also has a cardiac disease?
Thank you, Dr. Tushara. And also for considering the psychological aspects in the care of this person. Now, it's important to always not work in silos and only think of an acute coronary syndrome in terms of its medical management, but also the long-term outcome for this person. Studies have been done widely on this issue, and these are some figures. I mean, post-MI, up to
1/5 of patients end up with depression. And similarly, following catheterization and even bypass surgery. So it's an important area that we cannot leave to psychiatrists alone. And I think all physicians have to be proactive in identifying depressive disorder and managing it accordingly. So to reinforce, up to 20% of patients meet criteria for major depressive disorder, and almost 2 out of every 5 ACS patients develop depressive disorder. Now, also important is this fact that depression is an independent predictor of morbidity and mortality following cardiac events. So although we focus on the grace points, diabetes, previous MI, and all the other risk factors, in terms of eventual morbidity and mortality, scores on Beck depression inventory correlate with eventual negative outcomes post-intervention as well as following ischemic heart disease. So this is an important area that has to be looked at. It relates to diminished health-related quality of life, high costs, and poor medical prognosis. Because as you know, like this classic patient, they try to discontinue medical medication because in our context, they think it is due to or whatever side effects or whatever perceived problems related to depression are interpreted as related to the medicines that are being given. I feel this way is the common outcome. So depression is with morbidity and mortality, and depressive symptoms are associated with major adverse coronary events. Therefore, there have been many studies again looking at this, and they even recommend that we look at depression routinely, and there are algorithms that have been developed. And if you look at the symptom profile, I think it's sometimes very difficult to identify because low energy per se, although a symptom of depression, does not really differentiate tiredness following a cardiac event or even heart failure. So we have to look at their interest and motivation, and also persistent low mood, their inability to resume activities, to go back to their job like this lady, and particularly things like persistent negativity, worry, guilt, even concerns about medicine, not following clinics, and so on. Particularly medically unexplained symptoms. In Sri Lankan culture, nobody comes and tells you, doctor, I feel depressed. They will come and say, anger pitchenava, all sorts of symptoms which are not related to any of the cardiac issues, and you feel out of your depth to sort of address these. And also particularly poor attention and concentration, inability to concentrate and also participate in the exercise regime that is recommended, and all these things are important signs that suggest that this person is now depressed. Particularly this issue of giving up on life, I don't feel like doing anything sort of thing. So obviously RCTs have been done on cardiac patients to address this issue, and there are many studies that have been done. So what they found interestingly is that antidepressants, giving them did have effects on depressive symptoms, but unfortunately the studies were not able to show improved cardiac outcomes following depression treatment. Further analysis did sort of show that in some instances, antidepressants who did not receive antidepressant treatment were prone to adverse outcomes. So depression works in many ways, and we know that now depression is considered as part of a inflammatory process. And in ischemic heart disease too, we know that, cytokines, endothelial dysfunction, and elevation in plasma homocysteine levels play a role. And these do have a role in depression as well. And which is why even this issue of statins are quite important in preventing even depression, and anti-inflammation, antioxidants seem to have a role in the prevention of depressive disorder. So much so that we talk of psychocardiology, and people now think that we have a low threshold for starting antidepressants. But unfortunately, the trials, particularly the Enrich-T trial, and there are other trials like the SAD Heart and Mind-It trial, which also looked at antidepressants, prescribing them routinely following ischemic heart disease or acute coronary events, don't seem to really be of positive benefit in the populations randomized. So routinely starting antidepressants don't seem to be helping so much in terms of outcome. But there is one study, the COPES-2 study, which was done post ACL, which used a bit of a more broader approach, a step depression care model, where they involved the patient a little bit more and had a specialized team to look after them, and which was followed up for a period, did have show some encouraging results. And this is the sort of trial, if you look at it, I don't know whether you can see it clearly. So post-intervention, looking at the cardiac events or whatever, no intervention, there were more events. And in the never depressed group also there were events, but in where we intervened, sorry, it's the other, the intervention group had less events. Sorry, intervention group on top had less events, whereas the usual care had very much higher intervention here. So therefore, interventions in a step care model looking at depression, a bit of a holistic approach rather than just prescribing antidepressants, did help in overall reducing major adverse cardiac events, mind you. It's not about depression, but it reduced cardiac events because you address the issue of depressive disorder. Now, if you were to use antidepressant, then I think this person, it's really worth a trial, going from what she has been saying. And the most preferred is sertraline and fluoxetine. Generally, cardiac safe, you can use them post, MI immediately following a acute event. The others sometimes that are used are paroxetine, fluoxamine, but I think first line sertraline, fluoxetine, quite safe, well tried out. Caution with citalopram and escitalopram because in high doses they cause QT prolongation. And one thing when you add in sertraline or fluoxetine SSRI that you have to keep in mind is that they are going to decrease platelet aggregation. So when you are using aspirin and copilogel concomitantly, and if you are using warfarin, you have to take this into account because it will have some impact, and so it may be a beneficial effect eventually. And there is some insignificant sinus node slowing, which can really be ignored. Now, other antidepressants which are useful are drugs like mirtazapine, usually has some sedative effects, but to be avoided are venlafaxine, duloxetine, and the tricyclics. Now, a lot of people do seem to use them because these are marketed widely, but see, tricyclics particularly have a lot of issues with the heart. They do prolong the QTC interval, and they may precipitate even ventricular fibrillation. And finally, just to capture, sometimes it's even worthwhile in severe depressive cases, considering ECT, if they are not improving, not particularly for this patient. This patient, I think, would benefit more from a little bit of psychological support. supporting her and encouraging her to get back to work. So that's where maybe a referral to the psychiatric team will be useful, because they may be able to bring in some resources to support her to get her back into work. But even in another situation where a person is very down, we can consider ECT even if the ejection fraction is quite low, and even between a range of 15 to 40%, people improved significantly. Thank you.
Thank you, Prof. Shahan. So that concludes the case scenario on this patient. I hope we gain some insight as to how to handle therapeutic dilemmas. Thank you.
Thank you very much, Tushara, Chamar and Shehan for that excellent roundtable discussion. And we had a proper roundtable discussion with all three speakers who are here. Are there any questions from the audience? In the absence of questions, may I now present certificates of appreciation to the three speakers. Dr. Chamar. Shehan. Thank you very much. Now we would be breaking for lunch and coming back around 1:45. Please do join us, and thank you again to our, must thank the virtual participants. I think there are more than 300 people at any given time. So that's very encouraging, and do join with us again at 1:45.
Good afternoon, everyone.
Good afternoon.
We'll come back after the lunch break. Now we move on to our next segment, which is case-based scenarios. And the first one out of 4 is on hypertension with altered mental state. And the speaker today is Professor T. Kumanan. He is a professor in medicine, University of Jaffna. Over to you, Professor Kumanan.
Good afternoon, everyone. First of all, I would like to thank Ceylon College of Internal Medicine and the SLMA for providing me this opportunity to participate in this virtual symposium. For the next 20 to 25 minutes, I'm going to take you through 3 different clinical scenarios related to hypertension and on altered mental state. The first case scenario is a 47-year-old man with a 2-month history of progressive headache presented to the emergency department with nausea, vomiting, visual disturbance, and confusion for a day. He denied fever, weakness, numbness, shortness of breath, and flu-like symptoms or symptoms suggestive of encephalitis. And he had significant medical history of hypertension and was on amlodipine 5 mg daily in the past. But a year ago, he stopped taking medication due to an unspecified reason. The patient denied any history of smoking, alcoholism, and recreational drug use, but had a significant family history of hypertension in both his father and mother. His physical examination was unremarkable, except his blood pressure was very high, 195 by 123, and it's equal in both arms. The patient was promptly started on intravenous labetalol with a goal to reduce the blood pressure by 15 to 20% in the first hour. The blood pressure rechecked, and after an hour of starting labetalol, and the target was achieved by 1 hour time. 165 and 100 value was obtained. His initial ward investigations revealed nothing remarkable except raised serum creatinine. Left ventricular hypertrophy was noticed on the ECG, and the urine showed a proteinuria. The initial CT scan was arranged to rule out any intracranial events like stroke, and that showed a typical picture of a occipital lobe hypodensitivity, and that was symmetrical, so that is not in favor of stroke. So the radiologist requested an MRI brain. So the presumptive diagnosis was made as PRES, that is a progressive reversible encephalopathy syndrome on CT brain. The MRI of the brain demonstrated multiple scattered areas of increased signal intensity on T2 weighted and fluid attenuated inversion recovery FLAIR images in both occipital and posterior parietal lobes. There were also similar lesions in both hemispheres of the cerebellum, especially the cerebellar white matter on the left, as well as in the medulla oblongata. The lesions were not associated with mass effect, and after contrast administration, there is no evidence of abnormal enhancement. These are the images of MRI images that typically shows fluid attenuated inversion recovery images showing that hyperdensities in the cortex and subcortical white matter, right parietal occipital lobe, consistent with posterior reversible encephalopathy syndrome. We move to the second case scenario. A 35-year-old man, previously in good health with no past history of hypertension, presented with a 2-day history of bitemporal headaches and a sudden onset of left-sided weakness 4 days after ingestion of an over-the-counter medication for back pain, possibly an NSAID. And he was afebrile, drowsy, disoriented, and dysarthric with a blood pressure of 270 by 170. So the neurological examination revealed mild left facial weakness and with a power of grade 4 out of 5 in the left upper and lower limbs. Deep tendon reflexes were brisk, and he demonstrated bilateral extensive plantar responses. Fundoscopy revealed grade 4 hypertensive retinopathy changes. This was the fundus photograph, which shows bilateral papilledema incompatible with hypertensive retinopathy. And an initial CT scan again showed low attenuation abnormalities in the brain stem, white matter of both cerebral hemispheres consistent with cerebral edema. Again, there's no clear-cut images or clear-cut lesions could be identified by a general physician on admission. Subsequently, a hypertensive brainstem encephalopathy was the diagnosis made by the treating clinician and requested an MRI brain again. And the FLAIR sequence of the MRI brain image revealed asymmetrical hyperintensities within the brainstem, dentate nuclei, inferior cerebellar peduncle, and white matter of the cerebrum. Diffusion weighted imaging was normal, indicating the absence of infarction, and there was no enhancement with the administration of gadolinium contrast. So this was the MRI image of the patient. Areas of increased signal were present in the pons, right thalamus, and cerebellum in brain MRI fluid attenuated version recovery and T2 weighted images without any accompanying occipital lobe changes. The treatment with intravenous labetalol was commenced to achieve a normal blood pressure. His serum creatinine was 188 micromole, indicating renal dysfunction. ECG was again compatible with left ventricular hypertrophy. A 24-hour urinary protein estimation was done since the urine spot test was positive for protein, which revealed 3.4 grams of proteinuria for over 24 hours. Ultrasound and Doppler studies of the kidney were unremarkable, and urinary metanephrine, no metanephrine, and VMA levels were within normal ranges, excluding a possible pheochromocytoma. The last case scenario, the third scenario, a 19-year-old shop assistant in a 38-week of pregnancy was admitted to the emergency room. She had a generalized seizure prior to the admission. Her blood pressure was 170 by 110, and she had diffuse edema and proteinuria. Her blood pressure during the last antenatal visit a week ago was 125 by 70. And this is a typical presentation of eclampsia. So the provisional diagnosis of eclampsia was made and a cesarean section was performed. A CT scan of the brain just after delivery disclosed diffuse white matter edema with occipital prevalence. The patient was treated with a loading dose of 4 gram magnesium sulfate. An infusion of 1 gram per hour was commenced. Blood pressure was controlled with, again, labetalol infusion. Full recovery ensued without complication, and after 4 days, the patient was transferred to the postnatal ward, and shortly after discharge, with the normal repeat CT brain. This was the CT scan of that eclamptic woman, again showing hypoattenuation, mainly in the occipital region. It's very difficult to appreciate on a non-contrast CT brain. So these all 3 case scenarios are associated with elevated blood pressure, fairly high blood pressure levels, and all 3 patients were presenting with altered sensorium, and all of them had focal neurological symptoms or signs. So whenever a patient coming with this clinical syndrome, Those are the three main syndromes or distinct clinical syndromes I'm talking about. One is a progressive reversible encephalopathy syndrome or PRES. Number two was a brainstem encephalopathy. And number three is eclampsia. Those are the three recognized syndromes of hypertensive encephalopathy. But there are patients who can overlap with each other. So we'll have a look at the pathophysiology of hypertensive encephalopathy. Usually the cerebral blood flow is maintained by a delicate balance of vasoconstriction and vasodilatation of the peripheral vessel on the cerebral vessels. Whenever the mean arterial pressure exceeds 120, then the cerebral hyperperfusion occurs, and then there is an autoregulation failure happens, which is most commonly observed in the occipital lobe, because those vessels are poorly supported. So there is always, the occipital lobe is more prone to get auto-regulation failure. That's why the images, all the images showing that cerebral edema of the occipital lobe rather than the other lobes. In a patient with non-hypertension, usually the biostat of cerebral perfusion was shifted to right. So these patients can withstand very high blood pressure levels. We can observe this with the patients with chronic kidney disease, even with blood pressure of 230 and by 120, they don't develop hypertensive encephalopathy because their biostat is shifted to right. So this slide shows us a blood-brain barrier where the endothelium and astrocyte glial cells come in contact with each other, forming a tight junction. So the hypertensive emergency and hyperperfusion always disrupt this blood-brain barrier and end up in vasogenic edema. The opposite also can happen. Hypoperfusion or any cytotoxic related to the endothelium can result in leakage of fluid and vasogenic edema. So there are so many causes for cerebral edema and disruption in autoregulation. When you take up the pathology of PRES, there are a number of reasons that can result in PRES, but the main reason is hypertension, and it can be observed in autoimmune disorders, steroids therapy, cytotoxic drugs. The mechanisms are slightly different. In hyperperfusion, causing disruption of tight junction, but in hypoperfusion with microabscess formation and neuronal loss and neurotransmitter imbalance were observed with various other mechanisms. So the pathophysiology of PRES is multiple, but hypertension contributes a significant proportion of patients. So normal cerebral perfusion pressure is usually 50 to 150 millimeter mercury. Mean arterial pressure is 60 to 160 millimeter mercury. And so the intracranial pressure is around 10 to 15. So the cerebral perfusion pressure is maintained by the mean arterial pressure minus the intracranial pressure. So when the MAP increases, cerebral arterial vasoconstriction occurs. When the MAP reduces, cerebral arterial dilatation occurs. So with both will keep the CPP constant. So intracerebral elevated blood pressure causes a breach in the blood-brain barrier. Vascular fluid diffuses across the capillary membrane of the brain parenchyma, and that leads to development of cerebral edema, increased intracranial pressure, and neurological deficits such as altered mentation, visual deficits, and seizures. So that's the basic mechanism of hypertensive encephalopathy. So what are the essentials to diagnose hypertensive encephalopathy? When will you suspect hypertensive encephalopathy? When a patient presents with gradual onset of headache, nausea, vomiting. You have to note that gradual onset of headache, nausea, vomiting, because most of the stroke patients, they present with acute onset of headache, nausea, and vomiting. And usually encephalopathy followed by non-localizing neurological symptoms such as restlessness, confusion, seizures, and potentially coma. If the hypertension is treated promptly, the symptoms of encephalopathy are usually reversible. So on history and examination, with suspected patients with elevated blood pressure, an altered mental state, visual disturbance, and headache or seizures, the following points should be noted. A thorough drug history is essential for identifying any previously used antihypertensive drugs, because a patient who's a non-hypertensive are more likely to develop encephalopathy than a non-diagnosed hypertensive patient. And typically in chronically uncontrolled hypertension and may have discontinued their antihypertensive medications recently, that is another category of patient, or in rapidly developing and intermittent episodes of hypertension are also more at the risk of developing hypertensive encephalopathy, like in eclampsia. In the majority of the patients, the blood pressure exceeds 220 by 120. That is, they have accelerated hypertension or malignant hypertension. Therefore, should be evaluated for signs of other organ damage that can be found during a hypertensive emergency. Precordial auscultation may reveal signs of reflective of cardiac dysfunction, such as adult heart sound or third heart sound, pulmonary edema with crepitations heard over the lung bases, or fundoscopy may show retinal hemorrhages and papilledema, which is a sign of a severe hypertensive retinopathy. A complete neurological exam can identify whether a focal or non-focal deficits. So the diagnosis is made with severely elevated blood pressure plus a neurological symptoms by ruling out other conditions that may cause similar symptoms. Ischemic stroke and intracerebral hemorrhage must be excluded in these patients. Those are the most important differential diagnoses. And these conditions are treated totally differently and are not managed primarily or exclusively by lowering the blood pressure. So what are the differential diagnoses of hypertensive encephalopathy, which include, as I said, ischemic stroke, intracerebral hemorrhage, intracranial tumor, occult brain trauma, acute toxic metabolic encephalopathy, particularly due to substance abuse, and cerebral venous thrombosis. Those are the important differential diagnoses. So, since these are the differential diagnosis, obviously neuroimaging is the key to differentiate these DDs. So CT brain or MRI scan should be performed to identify brain lesions responsible for neurological signs. To exclude conditions such as ischemic stroke or intracerebral hemorrhage, CT brain is usually more readily available and takes less time to perform. However, CT may not be sensitive as MRI in identifying regions of the brain edema. And CT brain is essential in ruling out some intracranial lesions. This is a very basic concept in MRI. And the three images I have put, T1 weighted, T2 weighted, and flare. T1 and T2 weighted images can be easily differentiated by looking at the CSF. CSF is dark on T1 weighted imaging and bright on T2 weighted imaging. Fluid attenuated inversion recovery flare sequence is similar to T2 weighted image. Here the abnormalities remain bright, but normal CSF fluid is attenuated and made dark. So this sequence is very sensitive to pathology and makes the differentiation between CSF and an abnormality much easier. So when you suspect hypertensive encephalopathy, always request a T2 weighted images or flare images. T2 weighted MRI can localize regions of cerebral edema found with hypertensive encephalopathy, which can then be categorized further as posterior reversible encephalopathy syndrome PRES, as in case scenario 1, or hypertensive brainstem encephalopathy, as in case scenario 2. Bilateral white matter edema in the posterior cerebral hemispheres is characteristic of PRES. The distribution of cerebral edema is localized, particularly to the parieto-occipital regions in PRES and the pontine region in cases of hypertensive brainstem encephalopathy. So what is the role of CSF analysis in hypertensive encephalopathy? Lumbar puncture is not required for the diagnosis of hypertensive encephalopathy, and it may be performed when a patient is being evaluated for encephalopathy to determine etiology. In press, there may be modestly elevated protein level without pleocytosis, that is albumin cytological dissociation as observed with other conditions. In the meantime, we have to look for other acute HMODs, that is hypertension-mediated organ damages. The common three hypertensive-mediated organ damages are heart failure, acute kidney injury, and retinopathy. So other investigations should be performed are ECG, chest X-ray, urine analysis, troponin to rule out acute coronary syndrome, serum electrolyte, serum creatinine. In female patients of childbearing age, do a HCG level to rule out pregnancy, and toxicological screening assays, particularly if you suspect a sympathomimetic abuse. So how are we going to manage hypertensive encephalopathy? The initial aim of treatment in patients with moderate to severe hypertensive encephalopathy is to rapidly lower the mean arterial pressure by approximately 10 to 15% in the first hour. No more than 25% compared with the baseline by the end of the first day. So this we should keep in mind. More aggressive hypotensive therapy is both necessary and may lead to ischemic events like stroke or acute coronary syndrome. So you have to switch to oral therapy and achieve the target of systolic BP of 130 and diastolic BP of 80 over 2 to 3 months. The initial reduction of blood pressure is often associated with a modest worsening of kidney function. Again, the kidney is adapted to hyperperfusion. So this change is transient as the vascular disease tends to resolve and the renal perfusion improves over 1 to 3 months. Again, the same phenomena is observed in patients when you initiate on AC inhibitors and ARBs, and it is more pronounced in patients with renal artery stenosis. So in a summary of management, the immediate reduction of blood pressure is maximum 20 to 25%. The first line treatment available is labetalol or nicardipine. I hope labetalol is more widely used in Sri Lanka than nicardipine. An alternative is sodium nitroprusside. So this chart comprises the common drugs that can be used in encephalopathy: nitroglycerin, labetalol hydrochloride, sodium nitroprusside, nicardipine, and hydralazine. Labetalol and hydralazine are the preferred drugs in eclampsia, and in encephalopathies, usually labetalol and nicardipine is preferred than nitroglycerin. So what is the prognosis of hypertensive encephalopathy? In most cases, hypertensive encephalopathy can be reversed with a prompt but conservative lowering of the blood pressure. The prognosis for this condition can vary depending on whether other comorbidities are present or not. Once patients are released from the hospital, continued vigilance in hypertension management is necessary. So these patients are at risk for other hypertensive crises if they become non-compliant with their medications in the future. What are the complications that can occur if an untreated hypertensive encephalopathy? So failure or late treatment of hypertensive emergency can result in renal failure, retinopathy, myocardial infarction, and stroke. Without prompt treatment, brain edema can progress and lead to status epilepticus, coma, or death. An aggressive treatment of hypertension is not advised and can lead to ischemic conditions in target organs, especially in patients that have an adapted autoregulatory mechanism due to chronic high blood pressure levels. So the clinical pearls or the take-home message: the symptoms of hypertensive encephalopathy are insidious as opposed to stroke. Headache, nausea, and vomiting gradually worsen with time and are followed by non-localizing neurological symptoms This is in contrast to the abrupt and focal neurological symptoms found with ischemic stroke or intracerebral hemorrhage. CT is not sensitive enough, but to exclude other causes of altered mental state, it can be performed. Avoid an over-aggressive lowering of blood pressure, as it may result in ischemic organ damage. And it should not be lowered any more than 25% of the baseline blood pressure within the first day of treatment. The most common first choice of antihypertensive drug for this condition is labetalol or nicardipine. Finally, I would like to do TME part or MCQ based on the presentation. A 65-year-old male presents to the emergency department complaining of generalized weakness, has a past medical history of hypertension treated with hydrochlorothiazide, lisinopril, and amlodipine. His heart rate is 87 beats per minute, blood pressure 240 by 150. The temperature is 37 degrees Celsius, respiratory rate is 12, SpO2 is normal, around 95. Physical exam reveals bilateral horizontal nystagmus with no other physical exam findings, including no focal neurological deficits. Labs are unremarkable. A non-contrast head CT is negative for pathology. What is the next best step in the management of this patient? First, to reduce the systolic blood pressure to 175 in the first hour. Second, lower the mean arterial pressure by 10 to 15% in first hour, or reduce the diastolic blood pressure to 80 to 90 in the first hour, or the lower the mean arterial pressure by 35% first hour. So it's again virtually a hypertensive emergency. Again, the answer, I think you know that lower the mean arterial pressure by 10 to 15% in the first hour. And others, the true drastic drop will be deleterious for the patient. That concludes my brief talk. Thank you. Thank you very much for your patient listening. Thank you.
Thanks, Prof. Kumanan, for that excellent lecture. There are some questions, if I may read them out to you. The first one is, can you recap the differences between hypertensive encephalopathy and PRESS?
Yes, hypertensive. Yeah. Yeah, can you hear me?
Yes, we can hear you. Yeah, go on.
Hypertensive encephalopathy and PRESS are two distinct syndromes. At places both can overlap. So there are features of hypertensive encephalopathy that is common for PRESS also. So PRESS have a wide variety of symptoms and signs and a lot of even neuroimaging features which may sometimes overlap with hypertension. So PRESS is not equivalent to hypertensive encephalopathy, but certain features coexist when we call it a separate distinct category of hypertensive encephalopathy as PRESS.
Okay, thanks. The next question is there a risk of cerebral edema when giving a GTN infusion?
Yeah, it's a good question. The previous guidelines, say 2 to 3 years back, they have included GTN in the management of hypertensive encephalopathy, but none of the current guidelines of 2020 has included GTN. So that means definitely there is a deleterious effect of GTN on the brain perfusion. So most of the guidelines, they are very unanimous and they say that nicardipine or labetalol are the drug of choice. So I hope we should avoid GTN for cerebral insult due to hypertension, but it is the drug of choice in cardiac condition like pulmonary edema or acute coronary syndrome with hypertensive emergency.
Yeah, the last question is, you may have actually answered this. They're asking, when are we going to restart routine antihypertensives if the encephalopathy was due to non-adherence to treatment?
Yeah.
When would you restart the usual?
Yeah. There's no hard and fast rule when to restart, but the principle is to reduce the blood pressure gradually over 24 hours. And once it is an acceptable level, like say 180 by 110, then we can restart, if the patient is already on antihypertensive drug, we can restart the same medications. Or you start one by one, slowly the drugs, and you can taper down. So there's no hard and fast rule when to start oral drugs. But the most important thing is to reduce the blood pressure gradually over days.
Sorry, I have one question. When the features are suggestive of high blood pressure and no other focal sign, are you going to do a CT or MRI scan in the acute stage itself? What is the purpose?
Sir, I couldn't understand your question, the first initial part. Can you repeat the question, sir?
No, if you have a patient suggestive of hypertensive encephalopathy,
yes,
and no focal signs,
yes,
are you going to do a CT scan and MRI scan in the first, I mean, at the beginning?
Actually, we don't need, sir. We don't need. Then we can't diagnose hypertensive encephalopathy. Actually, it's an accelerated hypertension. So I would prefer to start medication to control the blood pressure rather than sending the patient for an immediate neuroimaging.
Okay, thank you.
Thank you very much, Prof. Kumanan. Thank you.
Next, we have Dr. Vimalasri Uluwathage, specialist in internal medicine, teaching hospital Karapitiya, to talk to us on leptospirosis pulmonary hemorrhage. Dr. Uluwathage.
Good afternoon. First of all, I must thank College of Internal Medicine and SLMA for giving me the opportunity to do this presentation. Okay, today's my topic is leptospirosis pulmonary hemorrhage. Let's start with an introduction. Leptospirosis is the most widespread zoonosis in the world. It's all over the world except in Antarctica. It infects more than 1 million people and is responsible for about 60,000 deaths per year worldwide. Recent study done by WHO in 2015 named Sri Lanka is one of the hyper-endemic countries. The mortality, the estimated morbidity in Sri Lanka is 300 per 100,000 population, and the mortality, estimated mortality was 18 per 100,000 population per year, which is a very high figure. Even when you compare it with other tropical countries, we are on the top. There is a renewed interest regarding leptospirosis in the recent past world over. Why? Because the frequent epidemics that has been experienced in the world is it's a frequent thing, and it's mainly attributed to environmental factors, especially the climatic change, and also increasing pollution and overcrowding, especially in the urban areas, leads this disease to migrate from rural areas to urban areas. The leptospirosis is a known illness which is confined or the prevalent in rural areas, now has become migrated to the cities. And also the affected groups, the traditional groups like farmers and other high-risk groups, is still there, but there are many other groups in the community are also at risk now. The clinical patterns are changing, it's mainly geographically. The recent study shows that different parts of the same country even may have different dominant clinical patterns. For example, in Sri Lanka, according to our observation and some of the studies done recently in our country, shows that leptospirosis associated pulmonary hemorrhage is predominantly a disease of wet sore. So this pattern has been described in many other countries as well. So people believe that the disease is becoming more and more severe. The clinical patterns have becoming more and more severe. And also they suspect that there are more and more virulent strains are coming up as time goes by. One of the very interesting and important thing is that the severity of leptospirosis is directly linked to the immune response of an individual. So considering all these interesting facts, the leptospirosis has become a disease which has had a renewed interest world over. To discuss more about leptospirosis, move on to discuss a case. This is a 17-year-old boy who was transferred to Teaching Hospital Karapitia. We managed this patient a few weeks ago at Karapitia, and he was admitted to a local hospital with a history of fever, body aches, and reduced urine output. There he has given a history of helping his father in the paddy field 5 days back. So the diagnosis was clear. It's no doubt that it was very much like leptospirosis, including considering the other clinical the features as well. So the reason for transfer was to Teaching Hospital Karapitia was that he had persistent hypotension despite IV hydration. So these are the parameters recorded at base hospital before transferring the patient to Karapitia. His blood pressure was 74/40 and he was running a tachycardia of 136. His saturation was 93 with 6 liters of oxygen ongoing. To tell you something more about this patient, I'll just give you how he progressed over the next few days while he was at Karapitia. So this is where he started at the local hospital. His pulse, he was running a tachycardia of 136 and blood pressure was 70/40. And his saturation was 92 with 6 liters of oxygen. He was tachypneic. His respiratory rate was 42. And the blood gas done there showed that he was hypoxic. His PO2 was 63 and he had high lactate level 6.1. On admission to Teaching Hospital Karapitia, his blood pressure was settled with noradrenaline 0.3. And he continued to be tachypneic and he demanded more and more oxygen to maintain his saturation. He was on he was on NRB with 10 liters of oxygen and saturation of 95 on admission. And his on admission blood gas showed that he had high lactate of 7. And considering his age and the severity of his illness, we decided to admit him to ICU. He was lucky to get a bed at ICU actually. And there his blood pressure further dropped and needing more and more inotropic support. And his saturation also needed to maintain with more and more supportive care. And he needed BiPAP to maintain his saturation at 98. His lactate came down while the chest X-ray when it was done at ICU showed bilateral infiltrative shadows suggestive of pulmonary hemorrhage. So on the following day morning, he was a bit calm and his pulse was 88 and blood pressure was 140/96 with noradrenaline 0.2. And still he needed BiPAP support to maintain his saturation and his respiratory rate was little less. It was 34 and lactate came down. But all of a sudden in the 3 p.m. in the afternoon, he became restless. His respiratory rate went up to 47 and started coughing out blood. He was not tolerating, he was restless and is not tolerating BiPAP. So we had to sedate him and intubate him and the mechanical ventilation started there onwards. To tell you something more about his other organ involvement, his liver function was essentially normal by this time. Actually, he had little hyperbilirubinemia and his renal involvement was moderate. It was 135, creatinine was 135, blood counts was normal, and hemoglobin was 9.9, platelet was 33,000, had evidence of ECG and echo evidence of myocarditis. So this was the X-ray done at ICU at Teaching Hospital Karapitia when he was on admission to ICU. But when you compare it with the X-ray done at local hospital, there is a clear marked difference between these two X-rays. The second X-ray shows there are multiple rounded opacities, bilateral, and especially peripheries and upper lobes. and middle and upper lobes. And this is suggestive of cotton. This is the appearance of, we describe it as cotton wool appearance and suggestive of pulmonary hemorrhage. So just to recap, the sequence of event that he had underwent from the beginning of his, during this short course of illness is very important to remember this sequence of event, because that helps in diagnosis. So the first thing noticed was the persistent hypotension, which was not responding to fluid regurgitation. Then the hypoxia was a dominant clinical symptom or sign, and demanding gradual worsening for demand for oxygen. And after that, he developed infiltrates in chest X-ray, and then he developed hemoptysis, and ultimately he went into a respiratory distress requiring intubation. Now, most of these patients who comes with leptospirosis pass a similar sort of sequence of event, and which is a common feature among patients with leptospirosis, pulmonary hemorrhage, especially with pulmonary hemorrhage. So what is the importance of discussion of this case? Now, she is a schoolboy of 17 years old. Now, if he comes with a febrile illness, you would not consider leptospirosis as the number one possibility. And in fact, when we inquired about from his father, the father is a regular farmer, and he has not had a leptospirosis of this severity in his life. And according to his father, even the farmers who have been working with him around this area has not had severe leptospirosis like this. Is not known to that. And when you consider his other organ involvement, the liver involvement is minimal and renal involvement is moderate, but yet he had severe illness requiring ICU care, including intubation and mechanical ventilation. So we concluded that this is a severe form of leptospirosis with predominant pathology in the lungs. This is a clear and definite case of pulmonary hemorrhage in leptospirosis. A little bit more about leptospirosis pulmonary hemorrhage, which was first described in 1995 in an outbreak that occurred in Nicaragua, where the people noticed that there was a cohort of patients who died of confirmed leptospirosis, but their cause of death was severe pulmonary hemorrhage. But this is different from what we know at that time. But because the severe most form of leptospirosis disease where liver and renal involvement was the dominant and cause of death usually. But here the significant thing was renal and hepatic complications were minimal. And later many other countries also reported the same thing, and they name it as severe pulmonary hemorrhagic syndrome. Going back to their surveillance data, Brazil reported this entirely new phenomenon, and which has not been described before. And they name it as, they concluded that leptospirosis has a changing clinical pattern in the recent past. How severe leptospirosis can be, how severe can they present you? This is one of the patients we managed recently at Karapitiya with the chest X-ray showing severe bilateral opacities, evidence of severe pulmonary hemorrhage. Luckily, he survived. And this one, the patient, actually another patient who came to us with a similar background, with similar history, and started coughing out blood. And suddenly he went into respiratory distress, and we had to intubate him. This is what we saw when he was intubated: the blood coming through the ET tube and even going into the ambu bag. This is another patient who was not so lucky to survive, and during postmortem, it was noticed that there was an extensive hemorrhage into the lungs. So what the clinical picture and how are we going to diagnose pulmonary hemorrhage. As you all know, the pulmonary hemorrhage can occur in Weiss disease where the clinical picture is dominated by renal and hepatic involvement. But the problem arises when pulmonary hemorrhage occur on its own, where you call it severe pulmonary hemorrhagic syndrome. There, for that, you need to remember these clinical patterns. I am going to remind you again, the persistent hypotension was the first thing that a patient would develop. Then the patient will show that increased work of breathing, and he will become hypoxic, and the chest X-ray will show infiltrates, bilateral infiltrates, and he will develop hemoptysis and might go into respiratory distress requiring mechanical ventilator support. So the diagnosis of leptospiral pulmonary hemorrhage is essentially a clinical diagnosis. For that, you need to look for these things. So you need to look for evidence of shock at the outset, and with the patient becoming tachypneic. Arterial hypoxia is an important indication, and chest X-ray infiltrate definitely suggests that the pulmonary hemorrhage, and hemoptysis also confirm that patient is having a significant hemorrhage. So when you have this picture, you're you're sure that you are dealing with a severe case of pulmonary hemorrhage. Then what is the relationship between leptospirosis and septic shock? As we already discussed, hypotension is a frequent finding in severe leptospirosis. In fact, it is the earliest sign of severe leptospirosis which distinguishes it from milder form of leptospirosis. The recent study shows that there are a lot of similarities between severe leptospirosis and septic shock, histologically as well as immunologically. This paper concludes that severe leptospirosis behaves very much like bacterial sepsis. They describe cytokine storm to describe the similarity between septic shock and pulmonary hemorrhage. So a little bit about immunology in leptospirosis. As you all know, severe leptospirosis consists of 10% of the cases. 90% of the leptospirosis are milder cases. The severity of infection is depend on two factors. The first thing is the virulence factor, where if you have the virulent pathogen, you get more severe disease. But the evidence to support this change of virulence and having more virulent strains is not much evidence-based, and not much evidence is there to support that possibility. But there are a lot of evidence to support the immune response of the individual is the main contributor of determining the severity of leptospirosis pulmonary hemorrhage, or the leptospirosis in general. So the organ damage in leptospirosis is due to immune response to the pathogen. As you all know, immune response is essential to eliminate any pathogen. But the problem arises when the immune response is dysregulated. And when you have dysregulated immune response, there is an overproduction of cytokine, we call it cytokine storm, and which leads to sepsis and multi-organ failure, which is essentially a genetically determined thing. If somebody ends up having mild disease, that means his immune response is well regulated. If a person is, person met with a lot of complications and severity, develop a lot of complications, that means his immune response is overwhelming, and it's dysregulated, and that leads to organ damage, and which was the immune response was counterproductive for him. So what is the pathophysiology of pulmonary hemorrhage? This is a normal alveolar, diagram of normal alveolus. This is a bit of same thing in a more of a histological diagram. What happens in pulmonary hemorrhage in leptospirosis is that there is a linear deposition of immunoglobulin and complements on the alveolar surface of the epithelium, which causes direct damage to alveolar capillary membrane. This is is something like that. When these immunoglobulin deposits, there is a damage. It causes damage to the alveolar capillary membrane, and which opens up the capillaries onto the alveoli, causing alveolar hemorrhage. Imaging plays a very important role in diagnosis and management of pulmonary hemorrhage. Chest X-ray, this is one of the very clear X-ray of a patient with severe pulmonary hemorrhage. The first thing you would notice is that actually X-ray findings are also evolving at the times as the disease evolves. Initially, you would see that X-ray there is small nodular opacity that may progress later on into large coalescent areas of consolidation, which we call cotton wool appearance, suggestive of alveolar hemorrhage. The areas of alveolar shadows and alveolar hemorrhage. This could be initially unilateral, but it can spread bilaterally and often is inferior and peripheral. If you have a chance to get a HRCT done, that will further confirm the same thing. So what are the poor prognostic signs of pulmonary hemorrhage? According to our observation, late presentation to specific treatment is one of the common factor which the patient goes into poor prognosis. And the severe and multiple episodes of hemorrhages again indicates that the patient will have a poor prognosis. Coexisting severe myocarditis with pulmonary hemorrhage, this is a deadly combination. If you have if the pulmonary hemorrhagic patient is having a significant or severe myocarditis, prognosis is very severe, poor, and mortality is very high. Evidence of multi-organ failure and heavy history of smoking may also play a part. So what is the management of these patients? The first thing is to treat the shock, because it is very common. You need to use IV fluid judiciously and do not overload. That is very important. And the inotropes, the adrenaline, noradrenaline can be used, which is very effective in treating this patient with shock. And while when you suspect a patient is having going to have pulmonary hemorrhage, you need to do some monitoring in the ward. It's especially very important to pay attention to respiratory rate. You have to monitor his respiratory rate and saturation, and also watch out for hemoptysis. It's very good if you can have arterial blood gas analysis in between. So once you are confirmed that you are confident that your patient is having pulmonary hemorrhage, then you move on to specific management of leptospirosis. As you already discussed, alveolar hemorrhages occur due to immune-mediated injury. So what are the possible ways to minimize the immune-mediated damage? The one thing is immunosuppression by giving steroids. Secondly, we can do immune modulation by the modalities like therapeutic plasma exchange, and IVIG are available for that. ECMO is the third option, which is not easily available, and it's a very expensive option. Now, use of steroids in severe leptospirosis has been explored, and there is some evidence to support the use of steroids in severe leptospirosis, including pulmonary hemorrhage. But according to our experience, what we have experienced is when you give steroids, especially if the patient is in the ICU, and if you give more than 3 days or more than 3 doses of methylprednisolone, they end up having sepsis very frequently. So in our practice, what we do is the maximum 3 doses of, we limit the methylprednisolone maximum of 3 doses. Our main stay of treatment of these patients are therapeutic plasma exchange, which is relatively simple and which is widely available throughout the country, and it is relatively cheaper option. And we did a study at THK, and which indicate that actually the therapeutic plasma exchange is quite effective in treating pulmonary hemorrhage. This is a study we did at Teaching Hospital Karapitiya. We recruited 62 patients, all are confirmed cases of leptospirosis, and employed therapeutic plasma exchange as a treatment. And we managed to save 45 of them, achieving the survival rate of 72, which is very highly significant. And which is when you compare it with the results we had, when you use standard treatment that includes steroids, where 14 patients had only the standard treatment, and all of them died during hospital stay. So this is not to tell you that this is not a randomized control trial. This study published in two years ago at in BMC infectious diseases. So what are indications to start therapeutic plasma exchange? Any three of the following we consider as indications for plasma exchange, do plasma exchange in leptospirosis patients. The first, continuous tachypnea, arterial hypoxia, an increase in demand for oxygen. If the patient shows the oxygen demand is increasing from face mask to NRB to NIV, and ultimately intubation and ventilation. So that is a very bad trend, and that there is a definite significant lung pathology. It's mainly pulmonary hemorrhage, and they need pulmonary plasma exchange. Sudden drop of saturation, that's why you need to check their saturation in the ward. And hemoptysis is a clear indication that patient is having a significant pulmonary hemorrhage. And of course, the chest X-ray shadows will confirm the hemorrhage. So this is how therapeutic plasma exchange is being done. This is the patient we discussed. And it's a simple, you do it with a simple machine. And one nurse and one doctor is adequate to perform this treatment, and which take a couple of hours. But for a patient with average or the severe pulmonary hemorrhage, on average 3 sessions of plasma exchange would be sufficient. This is what we achieved. This is result actually we achieved when doing plasma therapeutic plasma exchange for this patient. This was the X-ray we started with, and this is the X-ray after one plasma exchange, and this is how he progressed after a couple of days after further 2 sessions of plasma exchange. So it's actually this condition, the treatment of this condition is very rewarding. Why? Because most of these patients are young, physically fit, and economically they are productive. And because they recover fully, there is no long-term sequelae, especially their recovery of lungs are 100%. We have not seen any patient ending up having fibrosis, some other long-term sequelae as a result of pulmonary hemorrhage. So it's very rewarding to treat these patients. There are a few unanswered questions remaining. And the first thing is that whether the therapeutic plasma exchange is an effective therapeutic modality for LPH. The answer should come from a properly conducted RCT. The problem of conducting RCT in this situation, this condition, is that when you randomize patients to standard care arm, the clinicians who manage these patients, nobody wants to keep their patients in the controlled arm, which is standard care. Because of that, the one attempted clinical trial failed because all the patients ends up having plasma exchange ultimately. What is the future? At present, it's true that there is no robust evidence to support the use of plasma exchange. But it is not because it is not effective. There is no proper clinical trials have been conducted so far. That is the reason. But the reality is we have to deal with pulmonary hemorrhage with whatever the treatment modality is available. Because of that, what we can say is that we have seen some success with use of plasma exchange in pulmonary hemorrhage, and what we need to do is we need to do more research to bring in robust evidence. And in summary, leptospirosis is a re-emerging disease world over, and it is a disease with changing clinical patterns over the time. Different clinical entities have emerged to dominate in different geographical settings. Pulmonary hemorrhage is a severe form of newly emerged entity associated with high mortality. Severity of leptospirosis is directly related to immune response of an individual. Immune modulation therapies such as plasma exchange appear to be effective in pulmonary hemorrhage. Of course, we need more research on this subject. That ends my presentation. Thank you.
Thank you very much, Dr. Mesri, for that excellent presentation. There is one question from a virtual participant. He wants to know whether the severity of leptospirosis could be linked to a particular serotype.
Yes, actually that has not been confirmed so far. Can you hear me, Satish?
Yes,
Can you hear me?
Yeah, can hear. Go on.
Yes, it has not been confirmed so far, but there are a lot of studies being done around the world, but yet no, formidable evidence to support that. But they are thinking in line of the increased virulence of certain pathogens, certain strains of leptospira may be a cause of this thing. But it's mainly, as I said, as I described in the lecture, it's mainly the individual immune response. But the reason this reason developed may be due to the appearance of more virulent strains. Yes. So far, not much evidence.
Yeah, one question from me. Now you mentioned IVIG in your list of treatment modalities. Do you have any experience using IVIG?
Yes, yes. Actually, I didn't mention that it's the same study. We added at the second option, we added IVIG together with plasmapheresis. But there was a significant improvement with that. But the numbers to show the the efficacy was not enough. We had nearly 15 patients together with this plasmapheresis. It definitely showed, there was an apparent synergistic effect of adding IVIG. Yes.
I think we are running out of time, so we will conclude that talk. Thank you very much again, Dr. Mesri, for joining today.
Thank you.
It's a slight change in the schedule. The next speaker would be Dr. Manika Sumanatillaka. He is consultant endocrinologist at the National Hospital of Sri Lanka. He is going to talk to us on the management of recurrent hypoglycemia in diabetics. Over to you, Manika.
Thank you very much, Satish. Thank you very much, Satish, for the kind words of introduction. Very strange times to have a case discussion, but I'll try to do my best, ask the questions and answer them as well, and go on. I have selected few cases, actual patients from our clinics, and let's go through them one by one. So the case one would be a 70-year-old lady with type 2 diabetes, 20 years of diabetes, and with a history of hypertension and dyslipidemia as well, and admitted to the casualty with history of recurrent faintishness for the past 3 to 4 months. And her CBS on the casualty around 10 o'clock in the night was 46, and she's on glycoside 160 milligrams twice a day. Common scenario in our wards. Apparently, she has been on metformin 1 gram TDS before and glycoside 80 milligrams BD, but due to a routine screening where a increased creatinine has been found, that this dose change has been done. So these are her details: a BMI of 26, HbA1c 8.5, and the last recorded fasting blood sugar before this change was done has been 180, and the creatinine 1.4, and the EGFR 40, and the rest of the investigations and the examination was unremarkable. Common thing, what has gone wrong here? So what do we do? How do we manage this patient? These are very simple day-to-day cases. Should we have stopped the metformin straight away altogether and increase only the glycoside in a 70-year-old lady, which prompted the hypoglycemic episode? So my answer is, unfortunately, there are no responses from the audience these days. So answer is that we should have half the dose. I'll show you a guideline, a brief guideline on how we should have reduced the dose of metformin and probably keep the same dose of glycoside and add a third drug if necessary, looking at the HbA1c. If there is a possibility, something like renal safe linagliptin or even renal dose sitagliptin, which can be 25 to 50 milligrams, would have settled the problem. But there are other issues also. Just one reading of serum creatinine and EGFR on further questioning all these patients, sometimes they have been fasting without drinking water also for about 12 hours. If you ask them to drink water normally and do the creatinine and the EGFR, sometimes it may be 45 or 48. We need not, change at all. So it's always better to double check the EGFR and the creatinine as well, and then take a very simple practical measure not to increase the glycoside like that, which can cause a problem with the elderly. This is the current recommendation for use of metformin with your EGFR of your patients. So I think everybody knows that this lady falls onto the 30 to 45 range, where we should have reduced the dose by 50%. And then, of course, recommendation now is less than 30. You should omit. It's due to this rare occurrence of lactic acidosis by many mechanisms as shown there, but I don't have the time to go through the details there. But it's a rare occurrence, maybe less than 1 in a million, but it can happen, especially with intercurrent illness and renal impairment on patients on metformin. So that was a very simple thing. Another simple case, day-to-day, 45-year-old man with type 2 diabetes, shorter duration, 4 years, with a chronic alcoholic liver disease, for which banding has been done recently, and he's on glycoside MR 60 BD, admitted to the casualty again with a CBS of 32. No other intercurrent illness, and there is no previous admissions due to hypoglycemia as well. I'm sorry, this is not recurrent, but these people tend to come, if you don't change the medication. His biochemistry as shown here, HbA1c is high. Liver seems to be reasonable, creatinine 1.4 and the cholesterol of 220. And the rest of the investigations are all unremarkable. So what do you do now? Again, the sugar is not controlled, but the person is coming with hypoglycemia. So somebody probably thought because of the liver disease, this is compensated. I mean, it's decompensated, but not very severe liver disease, right? And the patient is quite well. So probably somebody has omitted the metformin, and we could easily add metformin and reduce the dose of glycoside NC. And what are the other drugs? What do the guidelines say? If you look at the ESD and the ADA guidelines in there's some icon. I'm sorry, my screen is doing it's frozen. Okay, so the guidelines, what they say is that unless it's very severe decompensated liver disease, we could use metformin. They say even pioglitazone, a small dose is helpful in the steatosis, the fatty liver stage. So we could easily add those two drugs if there is no edema and heart failure and the usual contraindications are not there. We could easily add and probably reduce the dose of metformin. I mean the glycoside. Maybe the long-acting one can be replaced by a short-acting glycoside with a half-life of about 8 hours. Normal glycoside 40 BD or 40 TDS or something like that could be tried depending on this thing. These are very simple day-to-day cases. Third one may be a bit more complicated. A type 1 diabetic girl, 5 years of diabetes. She's 14 now. This is actually a happening case. Just the last 2-3 weeks, we have been, treating her. Fluctuating blood sugars for the last 6 months. She was pretty stable, but the HbA1c was around 7 to 8 range. Last 6 months, she has had 2 hospital admissions. One for a major hypoglycemic episode and followed by a diabetic ketoacidosis. So typical what we call as brittle diabetes, where hypoglycemia plays also a major problem. Good compliance in terms of diet and her insulin regime, what we have given, injection sites were normal. There were no other dysmorphic features or anything that we could find to attribute to this unusual behavior. So these were her basic investigations. About 3 months back when he first saw her, 4 months back, HbA1c has gone up from her average of about 7 to 8. Liver functions were high, transaminase were high, but the hepatitis screen was negative. Ultrasound showed a fatty liver with mild hepatomegaly, and the ANA was positive. Other ferritin, ceruloplasmin, the usual tests, including we went to the extent of a liver biopsy. We thought this was autoimmune hepatitis, but unfortunately, the biopsy also we could not give a diagnosis. It came as normal, and the rest of the biochemistry, including cortisol and the they're not seeing this slide.
Yes.
I'm sorry, there's some technical problem. Do they hear? Yeah. They're not seeing. Okay, quick. Can I keep on speaking? Are we online? No. Okay, so I'm sorry. You all have told that the screen is not visible to you all, but this I'll be talking in the interest of time. So this is a type 1 girl, typical with brittle diabetes, and now having very poor control with high liver enzymes, and the ANA is positive. So we did a liver biopsy, and then that did not show any, we were looking for autoimmune hepatitis, but that also came as normal. The routine biochemistry, what I mean is even up to the extent of cortisols and all that was assessed. The renal functions, everything was assessed. The common causes of hypoglycemia and brittleness. So all those investigations were normal. So we were looking at the autoimmune aspect of her disease and the associations of type 1 diabetes. Are we online? No. Okay. I'm very sorry about the technical glitch, but I think we are okay. So we are looking at the third case. We have heard this, so I'll skip this slide and go to the next one. So she was on actually a pre-mix insulin, our usual thing in our clinics, twice a day premix insulin, which I thought was not the best regime for this girl with brittle diabetes. So immediately I put her on a basal bolus regime, as the parents could afford the best available analogs, because even with the human insulin also we could have a variability. So she was put on analogs, short acting 2 to 4 units for each meal, and long acting glargine about 4 to 8 units according to the blood sugar levels they were instructed. Nothing worked. One day with the same regime, she's having a CBS of 36, and the next day the parents called. I mean, we gave them the phone numbers also to call. The sugar is 500. So we were just wondering what's happening, and because of that ANA and the history and all being negative, I went down the autoimmune pathway, which can be the things that can be associated with the type 1 diabetes. So just a long-acting insulin only also didn't work. So I tried all regimens. So then we did few more tests. Hormone, thyroid were normal, but the TPO antibodies were positive. ANCAs were all negative. GAD65 just to double check whether we are dealing with type 1, C-peptide low, and GAD antibodies were positive. So it's a proper type 1, not a MODY or some other rare type of monogenic diabetes. Anti-insulin antibody sometimes gives this picture, the autoimmune syndrome, what we call as the Hirata syndrome, insulin antibody autoimmune syndrome. That also was not the antiphospholipid, cardiolipin, all negative. Gliadin came as negative. She didn't have any abdominal complaints and no diarrhea, abdominal pain, loose stools, but the biopsy also confirmed celiac disease. So this is a very, I mean, since we did the whole panel, we came to, got to know, and now she's on a gluten-free diet and things are improving, but bit slow. So this was because of the desperate situation, and parents opted what technology we have. So I suggested CGMS. They managed to get it down from Singapore, even in troubled times. And so this was the pattern. You could see the daily, they take about 300-400 readings every few minutes. And you could see that the sugars were up and down with no proper pattern that we could recognize. But nocturnal hypos were prominent, and you could see below 54, 28 times she dipped below 24. And of course, above 250 also, majority of the time. So the sugars were fluctuating. And about 2 to 3 weeks on a gluten-free diet, and things are stable. At least we are avoiding hypos. Now we have to get on top of things with a higher dose of insulin, and we are increasing the doses of insulin. So we are still, our mind is open. Could there be any other associations also with the ANA positive? So we'll be looking closely monitoring her. For the moment, I think the hypos have been settled. So celiac disease was the problem. So in type 1, think of these associations as well. So the best regime that we could offer all these type 1 patients would be a basal bolus regime using the analogs. But as you can see in the background, the light green background is the ideal body weight. Still, we can't match what the natural pancreas is doing. So other countries, unfortunately, we don't have. They have options like the insulin pumps and the CGMS I was talking about. So these patches will monitor the blood sugars, as you can see in the cartoon, and will stop the pump, which is giving a continuous dose calculated according to our requirements, and can stop the pump when we at a set point. So if we give a level of 70, it will stop the infusion when the sugars drop, and then it gives out an alarm also. Now there is technology that people are developing dual pumps, where you can give glucagon and insulin together, and what you call as the artificial pancreas, where we are having a closed loop system. One side is monitoring, the other side is giving, which can be connected through a smartphone, and it's a closed loop system. So this would have been ideal for people like this if the sugars are fluctuating. Other countries in children, she would have definitely gone on a pump if we had the facility. Again, a type 1 lady, slightly older, 25, 15 years of, about 10 years of diabetes. On top of that, she's having primary hypothyroidism on 75 micrograms of thyroxine. And over the year, we have been reducing her insulin dose. A year ago, she was on a total dose of 50. She was on Mixtard actually, pre-mix insulin, about 20 and 30 and 20. And gradually every visit, the doctors have been reducing the dose. And now she's on about a small dose, 20 units, and getting major hypoglycemic episode, couple of episodes, mainly at night. And now she's not taking even the evening dose. So what do you think? So very briefly, her creatinine, yeah, of course, is high. So deteriorating renal function could be a thing. But the electrolytes 5.7, sodium 139. Virtual audience, if you all think about, if I may ask, what is the next test that you would want to do? It's not fair without looking at the patient. If I say that she was a tinge darker than, or a shade darker than, I think you will get the point. The test that you want to do was noticed to be little darker, getting darker. So immediately, because I have seen this patient for a long time, I went for a short synapton test. Of course, you could do other things were done, liver, other than the renal impairment, there was nothing. And the electrolytes were slightly suggestive, 5.7, 131. So you could see she's having additions on top. So moment we gave her 10-5-5, 20 milligrams of hydrocortisone, her sugars are back to square one with 40-50 units. So this is a autoimmune polyglandular syndrome, like Schmidt's syndrome, or the type 2, where you have hypothyroidism, diabetes, and now the other spectrum additions also has come in. And this is her own handwriting, what she was having, the food diary. We were wondering what's happening. You could see like she was having bread and high carb diet just to maintain her sugar levels with additions and insulin on board. So this was her own writing, what she was doing. So that case settled, the hypoglycemia settled with giving hydrocortisone. The fifth case is a 30-year-old man, recent onset diabetes, 5 months, and was discharged from a surgical ward, I think on soluble insulin, 4 units TDS. That's how I got the referral, and he's getting fluctuating blood sugars, hypos again, and the last admission was a hyperglycemia with vomiting and abdominal pain. He has a history of alcohol intake, sort of a very high level of alcohol intake in the past, and abstained for the last 6 months, and a history of chronic pancreatitis. So you can gather your thoughts. These were his baseline. BMI 18, sugars were 230 and 360 when I saw, but HbA1c 5.2. So he has had more hypos than the hyperglycemia, and the serum calcium is marginally low, serum albumin 34, TSH 0.4. So what are your thoughts? So this person, very short duration. That's why I didn't label it as type 2 or type 1, or it's most probably diabetes secondary to pancreatitis. And the fluctuations, looking at the biochemistry, what do you see? The common thing, low hemoglobin, low calcium, there's an element of malabsorption. So I tried again, basal bolus regime, only long-acting insulin, nothing worked. And he was given pancreocyme. The exocrine deficiency was setting in after this thing, everything settled. Again, his insulin requirement went on. So exocrine replacement settled the whole thing. So these are all, maybe rare, but can happen. You have to think of all these things when you get a patient with hypoglycemia. And my last case, if I'm, we have 2 minutes, is a 57-year-old gentleman with type 2 diabetes for 6 years on a stable dose of metformin with good glycemic control. But for the past 8 to 9 months, he has been getting mild hypos with a CBS, lowest recorded home CBS has been 50. Not common, metformin, as you know, very rarely causes hypoglycemia. And he has gained about 10 kilos, being in a good diet, exercising, all that. And family history, past medical history, all was unremarkable. So having examined the routine things again were done, the liver, everything, nothing was found to be abnormal, HbA1c 5.1. Then I thought, so this could be hypoglycemia unrelated to diabetes or association. Because of the clinical picture, we did a 72-hour fast, and in 34 hours into his fast, his sugars dropped to 35, and the insulin and the C-peptide was high. So it's an insulin-dependent, hypoglycemia. So we did a CT immediately. There was a 2-centimeter lesion in the body of the pancreas, and the calcium, selective arterial calcium stimulation confirmed that there was a tumor blush in that area, and there was a rise of calcium when you, rise of insulin levels when calcium was injected in that particular area. And we have operated and successfully taken the tumor out. And of course, now he's on multiple drugs and insulin. After the operation, he became a worse diabetic, curing his hypoglycemia. But this was a more serious tumor, which we managed to detect because of his hypoglycemia. So, ladies and gentlemen, in diabetes, it could be simple, practical things, iatrogenic, injection technique, simple things, not matching the timing of the dosing insulin with the meal can happen. So you have to look into all these things, plus the rare occurrences, some of which I have shared. You have to think of these patients. So the blood sugar control, you have to think of so many things, balance out the malabsorption side, the compliance, practical things, then whether the insulin is getting absorbed, that there are antibodies against insulin. So many factors could cause the problem of recurrent hypoglycemia in diabetics. And my last slide, if I may summarize, remember the med school Sommergy effect, dawn phenomenon, these things, if you give a higher dose at night, you get a nocturnal dip and you get a rebound hypoglycemia, and you are not diagnosing, getting the point. So you need just reduce lipohypertrophy, the insulin is not properly variably absorbed. Sometimes you get a hypo, sometimes it works and doesn't work. Malabsorption, pancreatitis, we have. Then other things I didn't discuss, some things like diabetic gastroparesis, autonomic neuropathy, all these things can contribute to hypoglycemia in different ways. And of course, the other problems, CLCD, CKD, and the other endocrine problems as listed here. So think of all these problems when you have a difficult patient or a recurrent hypoglycemia in a diabetic. Thank you very much.
Took us through a spectrum of cases where patients could present with hypoglycemia with different etiologies. There is a question for you. What are the options available for exocrine replacement? I think they mean pancreatic.
So it's pancreatic enzyme replacement, pancreocymin, and they're asking the brands. I'm not quite sure what's available. What I got for that patient was pancreocymin. It was a bit expensive, 10,000 units for each meal was the gastroenterology recommendation, and he so perhaps I suppose depending on the meal and his this thing, further adjustment would be done. Roughly about 10,000 units for each meal. Whatever the preparation, it's a replacement. Pancreocymin was the one I remember.
Yeah, thank you. And may I invite Dr. Gamini to send the certificate of okay.
Yes. Next, we'll have Dr. Ananda Vijayvikrama, the specialist in internal medicine at the Infectious Diseases Hospital, to speak to us on complicated dengue fever. Dr. Vijayvikrama, please.
Thank you very much, sir. Good afternoon, everybody. First, I wish to go through the classification of dengue. As we know, this is the classification we use. As we know, most of them are asymptomatic, and the symptomatic ones are classified into undifferentiated fever, dengue fever, and dengue hemorrhagic fever. And it is commonly we see these complicated issues in dengue hemorrhagic fever. However, even in dengue fever, sometimes there can be patients with unusual hemorrhages, which is not very common. There's another classification which we don't use in Sri Lanka, which is where dengue is classified as dengue without warning signs, with warning signs, and severe dengue. When we studied these two classifications, what we found was this second classification, rather than the second classification, the first classification is more user friendly, and that is why we continue to use this in spite of WHO using this second classification. As we know, the first outbreak occurred, dengue was confirmed in Sri Lanka in 1992, and since then we have been having many outbreaks. And initially, dengue was mostly seen in the pediatric population. For example, in 1996, more than 70% of the population were dengue patients were less than 15 years of age. However, this had been changing, and by 2012, more than 70% of patients were about 12 years of age, and of this, about 50% of patients were within the working population from 15 to 50 years of age. This has been noted in other countries too, in countries like Indonesia, Bangladesh, and Thailand and India. And with this, we have seen certain differences when we compare the children and adults. There have been many studies in countries, and this study from Vietnam shows that they say the plasma leakage and shock were more common and severe in children than adults, while bleeding and organ dysfunction were more frequent in adults. We too see a similar picture, and again in Thailand, they found that bleeding is significantly more frequent in adults. In Singapore too, they have had similar findings. And so basically in dengue, most of the people will have febrile phase and the convalescent phase. However, in dengue hemorrhagic fever, in between these two phases, the febrile phase and the convalescent phase, there is this critical phase where plasma leakage occurs. And generally, it lasts for 48 hours. If we look at a case was transferred to us from Japura Hospital some time back, the patient was managed there for about 36 hours. And on admission to us, he was stable. However, his platelet count was for 16,000 with a hematocrit of 27, and ultrasound showed moderate ascites. Because the hematocrit was low, in spite of having plasma leakage, we decided to transfuse him with the packed red cell. And with that, the hematocrit increased to 29, but again dropped to 27 within 7 hours. Another full packed red cell was transfused, and then the hematocrit increased to 30,000. And then the hematocrit dropped, and he was from time to time getting tachycardia, and the liver enzymes AST rose to 1,370. And we transfused another pint, that's the third pint. In spite of this, there was no signs of bleeding. The liver enzyme went up further, AST to 1,869 and ALT to 1,516. INR was marginally high. And then the next day, the patient was complaining of inability to extend the leg, and he was keeping the leg in the semi-flex position. And then we did a CT scan of the abdomen, and which showed bleeding into psoas muscle. Even though I put this under this problematic case, this sort of cases are not uncommon, where the evidence of bleeding is not evident. However, we see the PCV is dropping and the patient is becoming unstable, either with tachycardia, and if it continues to go on, we will see patient going into hypotension and shock. So therefore, this is something which we have to always keep in mind in these patients. As I said at the beginning, bleeding is common in adults. Bleeding can occur without patient going into shock, and therefore we have to anticipate bleeding in all the dengue patients. And as the bleeding is not evident often, we have to go with other changes in other parameters like the drop of hematocrit or unstable parameters where hematocrit is without the rise of hematocrit. This lady, a 51-year-old lady, admitted with history of fever for 3 days with vomiting and myalgia. On admission, the platelet count was 112,000 with hematocrit of 28. Antigen was positive. And then on day 5, the hematocrit increased. Platelet went up to 38. Platelet dropped to 38,000, and the ultrasound showed the early ascites. So the output dropped, and we increased the fluid. And then the hematocrit dropped further. There was no signs of bleeding. However, because the patient was unstable, we decided to transfuse her pint of packed cells. With that, the hematocrit increased, but then again the hematocrit continued to drop, and she was complaining of left lower mid-abdominal pain. To keep her in a stable condition, we had to give another transfusion. When we repeated the ultrasound scan, it showed a thickened rectal muscle, and they queried the hematoma. So later we did the CT scan, and you can see the thickened rectus muscle with bleeding into this, and you can see it here very nicely. When you compare with the rectus muscle on the left side, you can see how the this other rectus muscle was thickened due to bleeding into the muscle. Later, the the fever continues in spite of rising platelet, and it was the lower abdomen was tender. We continued on antibiotics, which was started empirically initially, and then since the patient was showing evidence of sepsis, after much deliberation, we decided to go ahead with an exploration laparotomy, and that showed rectus hematoma with necrotic muscles. And when that part was removed, the patient became stable, and later the patient was discharged. So once again, this highlights the bleeding which can be occult in these patients, and this is a rare case where it got infected, leading to sepsis. This is the dissected part of the muscle. This boy was admitted from a transfer, initially admitted to a private hospital. Later, he was transferred to us. He had evidence of plasma leakage, so we adjusted the fluid intake accordingly, and he was stable throughout. However, his fever continued. Then and he was ill with complaining of generalized abdominal pain, and there was some tenderness also. So suspecting a possible intra-abdominal infection, we started empirically on antibiotics, and then the plasma leakage we thought stopped, and he started diuresing, and the platelet count started to rise, and the abdominal pain continued, and there was tenderness, and the fever too continued. So there was a high suspicion of intra-abdominal infection. And on day 8, the platelet count went up to 143,000. And then we thought it is time to get surgical opinion, because what we suspected was whether it could be an intra-abdominal abscess. The parents wants to get the patient to a private hospital again. So we transferred the patient, and on transfer, we thought of doing a CT scan straight away. And the CT scan showed a ruptured appendix. And the platelet count was 146,000 there also when the patient went there, and the patient went had the laparotomy, and then in the night I got a call saying that the patient's so of course it's a surgical condition now. I thought the platelet count has gone up, so I didn't expect any problems as far as dengue is concerned. But then I got a call around 8 o'clock in the night saying that the patient's hematocrit has dropped to 35 from 38. So I said to transfuse the blood. Then actually I didn't inquire about the patient after that, because I thought it's more sort of surgical thing. But then next day early morning I got a call. The patient had problems. When it was told to the surgeon that we suggested to give a blood. Surgeon has thought it's not necessary. Of course, generally you don't give blood after an appendicectomy. But then in the night, the patient collapsed. And then the surgeon had to come in the middle of the night and reopen the abdomen to find that there was a lot of oozing everywhere. There was no single point of bleeding, but the patient had hemoperitoneum. It was evacuated, blood was given, and then it was a complicated case. Later, the patient went into respiratory failure, acute renal failure. He was ventilated, hemodialyzed, but finally, fortunately, the boy recovered. And interestingly, during this period, he had several thromboelastographies, all were normal. So during this period, we had to give packed red cells. And in addition, because in spite of having normal thromboelastographies, we decided to give factor 279. There's a preparation with 279 concentrate. So we gave the factor concentrate to him, and fortunately somehow the bleeding stopped, and later the boy recovered. So interesting point here is the patient started bleeding in spite of recovering from dengue and in spite of having a near normal platelet count. So probably this bleeding tendency may be continuing, maybe with fresh platelets, still the clotting may not be normal. Therefore, we have to anticipate problems even after the recovery of dengue during the initial couple of days of possible bleeding, when they, especially when they need surgery. There have been studies to see how the bleeding scores correlate with the hemostatic data. Some studies shows the APT, prolongation of APTT, and reduction of fibrinogen. However, the clotting factors basically were not deranged grossly during bleeding of these patients. So it is thought to be due to multiple factors. This patient was admitted about 10 years ago to us, and she was initially stable, but then he started plasma leakage. Then later, to cut a long story short, she became unstable towards the latter part of critical phase. And again, we couldn't find the bleeding in spite of she was point of bleeding in spite of she was dropping her platelet count, dropping her hematocrit. So we had to put a femoral catheter to keep her stable and to give blood. She went into respiratory distress. We had to intubate and ventilate her. And we had to give several pints of blood to keep her hemodynamics stable. And then still she was getting better with blood transfusion. Then after another 4 or 5 hours, she was becoming unstable. So I didn't have any option to do. So I thought might as well try and aspirate the pleural effusion and see whether that can reduce increase the lung volume and help the ventilation. So I went ahead with aspirating the pleura. She was intubated. This time you can see I was trying to aspirate. And then what we got through the tube was this. We aspirated 1,600 ml of blood, and in the middle of the aspiration, my MO was telling me, so now I can feel the pulse. So probably we thought the patient was having tension hemothorax, and later we put a tube, and then we were able to extubate the patient, and then later she recovered, had a complete recovery. Fortunately, in spite of all this, liver enzymes kept within the normal range. So the pleural aspiration has to be done rarely in dengue when there's an possibility of tension hemothorax, or sometimes there can be large effusions causing respiratory distress and interfering with ventilation. These are rare occurrences. Rarely one can get pyothorax due to secondary bacterial infections, but these are very uncommon indications, I would say. On the other hand, aspiration of acidic fluid, need for aspiration of acidic fluid could be more frequent. One has to consider aspiration when the response to dextran is inadequate in a patient with a lot of ascites. If the patient has tense ascites interfering with ventilation, or if the patient is having tense ascites with reduced urine output, this can be interfering with the renal blood flow. In such instances, what is advised is to check the bladder pressure, and if it is high, to consider aspiration. So the best thing what we do is we put a PD catheter and aspirate it, and because then if necessary we can continue peritoneal dialysis in these patients. The ideal way to check the bladder pressure is to put through the urinary catheter. You can connect it to the manometer. However, what we do in the ward or ICU setup is we connect it to the tubing of the giving set, saline giving set, and then put 100 ml of normal saline and then lift it horizontally. If the bladder pressure is more than 30 ml, then that's a definite indication of for aspiration of the acidic fluid. If the bladder pressure is between 10 to 30, then depending on the clinical scenario, we have to decide whether to aspirate or not. This is another case history where the 31-year-old girl was admitted with 3 days history of fever, and her platelet count was 110,000 on admission with a hematocrit of 32. Her platelet count was gradually dropping to 70,000, but hematocrit remains stable. And the ultrasound showed a small amount of ascites and gallbladder wall edema. So we didn't have to change much of fluid. That's a little increase, and she was stable. However, the fever continued. In a dengue patient, if the fever continues more than 5 days, generally it lasts for 5 days, we have to consider the possibility of secondary bacterial infection. On the other hand, it may be a co-infection. Rarely we see, or uncommonly we see prolonged dengue fever. Occasionally it can get prolonged to about even 10, 11 days. The common reasons for secondary bacterial infections is the gram-negative infections coming from gut organisms. Therefore, it is essential to do a blood culture in these patients before starting antibiotics. And the other common reason is in these patients is the thrombophlebitis. Now, in this one, so we started on antibiotics because the fever was continuing after day 5, and she was looking ill. Then the hematocrit started dropping, and she was becoming hemodynamically unstable. Then we gave her a transfusion. Generally, we expect to see after 5 days a rise of white count, and then after the end of 6 days, generally we start to see a rise of platelet count. This is the usual pattern we see in almost all dengue patients. However, this one, the fever continued, hemoglobin started dropping. Instead of rising, the platelet continued to drop even after day 7. And then the liver enzymes are high. So in such patient, we have to suspect the hemophagocytic syndrome, which is characterized by at least bicytopenia should be there, and their ferritin levels are very high now. This patient had a 73,000 odd ferritin level. It's not just 2-3,000. In dengue hemorrhagic fever, the ferritin can go up to sometimes the ferritin can be about 2-3,000, but in this patient it was 70 odd more thousand, and triglycerides were high, and the confirmation is done by doing a bone marrow which showed a moderate hemophagocytic activity. So we started on IG and dexamethasone IV, and she responded well and recovered fully. HLH is a condition which has to be treated quickly, early, so one has to have a suspect the diagnosis in a patient whose platelet count is dropping in spite of beyond the illness going beyond 7 days and the fever continues. We have to suspect the hemophagocytic syndrome. It can be fatal if it is not detected and treated early. So they have high fever, cytopenia, hemophagocytosis, so we cannot check, of course, the killer cell activity. For the diagnosis, these are the criteria. So diagnosis, the continuing fever, splenomegaly, cytopenia, at least 2 cell lines, hypertriglyceridemia, high serum ferritin, and of course these two we cannot check, and the hemophagocytosis. Other unusual manifestations could be liver failure, usually secondary to prolonged shock, and rarely liver failure can occur in patients without shock. And one possible reason is the use of NSAIDs. And other rare one is encephalitis, which is rare and generally is symptomatic management, which is necessary. And that's quite a rare occurrence. I thought of showing this case, even though this is this shows how this is in a patient who would have been an uncomplicated made an uncomplicated recovery can went into a severe case because of various issues. This one is a 17-year-old girl admitted around 4 o'clock in an afternoon. She had come in with fever for 3 days. She had nausea, arthralgia, and she had she had menstruation at that time. So these are adequate to suspect dengue in a country like ours when they come with fever, headache, nausea, and vomiting. And she was afebrile on admission, and so they have ordered a full blood count and a dengue antigen. And till next morning, she has had about 800 ml of fluid. And the next day morning, now a dengue patient coming after, especially after 3 or 4 days, if they are afebrile, one has to be careful because that's the time a patient can have plasma leakage. So we have to have a closely monitor such patients because otherwise they can go into problems. And the next day morning, the patient was found to have a blood pressure of 90/70. And the full blood count done on admission showed a hematocrit of 40 and the platelet of 70,000. And an urgent count was done when the shock was detected, which showed the platelet count of 44,000 and the hematocrit of 40. So obviously the patient, and the ultrasound showed plasma leakage. Obviously the patient would have been having leaking during all this period. Unfortunate thing here was this report, the blood count done on admission was available only next day morning. And because it was not available, probably the patient was not monitored. The patient may have gone into shock before 8 o'clock, or at least had signs of instability before this. So unfortunately, full fluid bolus was given at that time, but then the patient was sent to the ultrasound department. For about 1 hour, patient did not have any fluid. And then the fluid had been cut down quite rapidly to a 7 to 75 ml. The other important thing here is the patient's admission hematocrit is 40. And at that here, when the patient was in shock also, it is 40. So that shows, and the ultrasound shows plasma leakage. So this shows, in addition to plasma leakage, the patient has had bleeding. So in such instances, one has to give blood quickly, and then the fluid has to be tailed off gradually, not to this low level, because if this happens, then the patient will go into shock again. So that is what exactly happened. The patient's output dropped, blood was given, but late, and later the patient went into full-blown shock. And later the patient was actually transferred to our hospital, but then it was bleeding, acidotic, and we could not save her. So such things can happen. And therefore, one has to keep an open mind and monitor these patients carefully because such things can lead to unrecoverable complications in a patient who could have recovered without much of a problem. Sorry, just one. sorry, there was another slide I want to show you. So again, what I want to say is, even though you see these problematic or unusual cases from time to time, commonly these problematic cases are due to either late presentation or not giving proper attention or to changing parameters or misinterpretation. Often one problem we see is, if the urine output is okay, changes in other parameters might have been disregarded. Or else, if the blood pressure is okay, changes in other parameters might be disregarded. And in such instances, if this plasma leakage or bleeding continues, and that can lead to an irrecoverable situation. So therefore, any change in these parameters of urine output, hematocrit, pulse rate, blood pressure, capillary refill time, any changes in any of these parameters is significant. One has to anticipate or look for problems if you notice a change in any parameters. If you continue to allow that change in parameters to continue without any intervention, then it will become a problematic case, and sometimes we may not be able to recover the patient. Thank you.
Thank you very much, Anand, for that very interesting talk. There is one question for you. Someone is asking, can persistent bleeding cause fever in dengue? Persistent bleeding cause fever in dengue?
I don't think so. The patients we had who have showed evidence of bleeding, they didn't manifest as bleeding, manifest as fever. Of course, bleeding into abdomen might cause fever due to inflammation, but I don't think it is a manifestation. The fever is a manifestation of bleeding.
One other question, Ananda, how useful is the thromboelastogram, the TEG in a patient who is in shock and having bleeding? Do you go by the thromboelastogram, or is it useful?
The simple answer is useless. Thromboelastography is useless in managing dengue. Don't waste time and money on you doing thromboelastographies.
Okay, thank you very much. I think we have run short of time. Thank you very much, Ananda, for joining with your busy schedule. Now we come to the end of the session, end of the symposium today. I think we have had interesting case discussions in different segments. I must thank Dr. Madhuvanti Etiarachi, editor SLSIM, who was instrumental in drawing up the program and organizing the activities, and the two secretaries, Dr. Tushara Matayas and Dr. Indika Boteju. And also I must especially thank SLMA, Dr. Sargami is here, and then Madam Padma Gururatna, who actually agreed to have this joint session. So we wind up there, and we hope to meet you soon with other academic sessions. Thank you.
Thank you.